Are there any flights from US to Indonesia now, Ronnie?
Not really sure. Yeah, there's international flight. There's from Singapore, I think. So it should be because I don't know what's go from US to Singapore, but from Singapore to Indonesia is still right.
There is true. So Singapore is true. Japan. Kuala Lumpur is true.
Oh,
that's the only spot. It used to be Hong Kong, but no more Hong Kong.
Oh, it's Japan.
Hopefully by next year we'll be able to travel again.
Yeah. I don't know if the vaccine is work or not, but I don't know. US will start the vaccine at the end of this year or
soon,
really?
coming up a few weeks.
Hội Tim mạch Việt Nam trân trọng giới thiệu chuỗi hội thảo trực tuyến về tim mạch.
Tâm điểm 2020, nơi cập nhật những tin tức mới nhất về chuyên ngành tim mạch học.
Nơi trao đổi, tương tác đa phương tiện với những chuyên gia tim mạch hàng đầu về những chủ đề khoa học và thực hành mới nhất của chuyên ngành.
Nơi tổng hợp những kiến thức về tim mạch học cho các bác sĩ và bệnh nhân.
Đồng hành, đồng sứ mệnh, Tâm điểm 2020.
Hứa hẹn sẽ là diễn đàn trực tuyến hot nhất được phát trực tiếp trên các nền tảng trực tuyến của Hội Tim mạch Việt Nam. Tâm điểm 2020 phát sóng 9 giờ đến 10 giờ sáng, thứ Bảy hàng tuần bắt đầu từ ngày 13 tháng 6 năm 2020.
Ấn phẩm truyền hình hàng đầu của Hội Tim mạch học Quốc gia Việt Nam.
Tin tức chắt lọc, cập nhật, thấy gì trong dòng thác thông tin.
Kiến thức chuyên sâu,
giá trị thực tiễn.
Tâm điểm 2020.
Đồng hành, đồng sứ mệnh.
Hội Tim mạch Việt Nam trân trọng giới thiệu chuỗi hội thảo trực tuyến về tim mạch.
Vietnam Society of Cardiac Intervention, VSCI. And today, I'm very happy to have the brief speech to welcome and to open ASEAN Sky Fellow Call. We are very pleased to be joined with your expert from the world, Dr. Ramesh Bagati, Dr. Kwan Lee, Dr. Rosli, Muhammad Ali, and Dr. Let's see the list. Yeah. Recently, the VNSI have cooperated with the Sky to have some call for the training and education. But this time, officially, we hold the ASEAN Sky Fellow course. I think it's very useful and very beneficial for young interventionists in Vietnam and ASEAN country. As you know, in Vietnam, 10 years ago, we have a very few cath lab. In some big city, look like Ho Chi Minh City and Hanoi capital, we have 1 or 2 or 3 cath lab. But nowadays, the number increased very quickly. The total number here, now cath lab 160 cath lab in every province, every city, have a 1 or 2 or 3 Hanoi capital, we have Catalan. So I think the velocity of the growth is very quickly. It's very useful for acute MI, for really chronic coronary syndrome. So I think today the Asian Sky Fellow Call is very beneficial, very useful for our interventionist, not only Vietnam, for every country in ASEAN. I think the interventionist can learn some skill, some some expert from the world. The Sky continue to hold many core, many education training for us. And the last, I hope in the COVID-19 period, I wish all of you the health, the good health, and I hope every participant in here who can receive the good knowledge. Thank you. And we can go to the session. Yeah.
Thank you, Dr. Doom.
You in the coronary intervention 2020. Please, Dr. Ramesh Tubagati.
Thank you, Dr. Doom. This is a great pleasure to be with you today and at the Vietnam National Heart Association, and also a collaboration between Sky and the second ASEAN region series. It's my great pleasure to join you. And as you know that I visited Vietnam since almost 2009. I have been coming almost every couple of years, and I always miss being there in person to make this presentation. So let's go ahead and give my talk on Intervention 2020. Andreas Grunzigen, since 1939 to 1985, we consider him as the father of angioplasty. And his dream was the catheter-based percutaneous treatments of vascular disease in alert and awake patients. So this is a 90-year-old Chinese woman with non-ST elevation MI, ST elevation AR, suggestive of probably left main or triple vessel disease. And troponin I was 45. And as you can see, she has significant left main disease with bifurcation, and also mid-RCA calcified disease in the mid portion, and LV systolic dysfunction. How do we treat such a patient? Obviously, in the United States, we do a heart team approach. We involve the cardiac surgeons. And then when they turn the patient down, then we go ahead and do PCI. And so this patient underwent a successful PCI as she became unstable and felt not to be a candidate for cardiac surgery with the hypertension. And so DK crush was done with the impeller support, and she was able to go home within 2 days. In 2020, what is new in coronary intervention? As you know, everything now revolves around COVID. There have been several STEMI series in COVID-19 literature review where it showed about an average of 7 to 115 patients and all different types of presentations, and these are all observational series. And the in-hospital mortality ranged anywhere from 18% to all the way up to 72% in New York. So this is really very alarming to see how we could have high mortality. But when we started looking at the North American COVID-19, ST segment elevation myocardial infarction registry, the NACME registry, and to collect more data to make some headway into this. This is actually by our president-elect, Tim Henry, presented it day before yesterday at TCT on the webinar. And several patients can get into the NACME registry, that is suspected COVID-19 with a clinical diagnosis of coronary MI, successful PCI, and they can be enrolled. And a patient who is confirmed COVID-19 and they either have a non-ST elevation MI or a type 1 or type 2 MI, and they can also be enrolled if they receive or don't receive fibrinolysis or no angiogram. They can still be enrolled in the NACME registry. What actually it showed is that patients who are positive with COVID-19 had a in-hospital mortality of about 32%, not 72, which is at least good. But compared to them, a propensity-matched cohort of STEMI patients, the in-hospital mortality is normally around 6%, as we all know. The reinfarction rates are much lower, about 2%, and in-hospital stroke rates are also higher. The total length of stay in ICU and in the hospital is much higher in COVID-19 positive patients. Obviously, despite all this, the door-to-balloon times were actually normal, were less than 90 minutes in the NACME registry. So it is not related to the door-to-balloon times, but it is that their outset itself is really bad. In COVID positive, any coronary disease is not well tolerated. So compared to both the person under investigation and propensity matched controls, ST elevation occurred more frequently in Blacks, Hispanics, and diabetic people. COVID positive patients with ST elevation are more likely to present with cardiogenic shock but not cardiac arrest, with the lower left ventricular ejection fraction, more atypical symptoms, and slightly higher in-hospital presentation. And we know that COVID positive patients with ST elevation were more likely not to receive angiography, 21%, and to receive medical therapy, but still 71% received primary PCI, and lytics were uncommon in the United States. No differences in culprit vessel and similar door-to-balloon times were noted. COVID positive patients with ST elevation had higher in-hospital mortality and in-hospital stroke with longer length of stay, as I mentioned. So now coming back, in other types of patients, non-COVID, when should we do PCI? So there are lots of things that have come out in 2020. We look at diabetic patients, Freedom, Syntax, Excel, and left main, DK Crush 5, and the CTOs were the decision CTO, and small vessels, bioresort study, ISR, and what types of stents we should use, what types of debulking agents should we use, antithrombotics, clinical presentations such as ischemia in stable patients and STEMI patients in complete revascularization, and the role of imaging and a functional assessment with the FFR. So all these are really great, and if anybody is interested, I think this is a great paper from European Heart Journal in January 2020 that we can talk about all of these. But let me concentrate on few things in view of time. Is ischemia the answer? In stable ischemic heart disease, ischemia was randomizing patients to invasive strategy versus conservative strategy. So whether they have moderate or severe ischemia, did it make any difference? And ischemia also had another option of ischemia chronic kidney disease. And the same thing with the eGFR less than 30 or on dialysis, patients were randomized 1-to-1 into invasive strategy and conservative therapy with medical therapy alone. But in the main ischemia, in stable, moderate to severe ischemia patients, there's a blinded coronary CT angiogram that was done. And if there is no left main disease, then they were randomized to the two arms. And what it showed is actually that ischemia primary endpoint between invasive and conservative therapies, it's all similar. There is just actually an overlap of one or the other of a primary endpoint of cardiovascular death, MI hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. They were same in medical therapy versus going to cardiac cath. So that says what we know is that even in the chronic kidney disease, the same thing has been seen. When patients who are in stable ischemic heart disease, they do not have to go to cardiac catheterization. Despite there's more severe and extensive coronary artery disease, we know that they have a poor outcome anatomically, but functionally, it did not make any difference. So the severe 3-vessel disease or 2-vessel disease with proximal LAD, even in that subgroup, it did not make any difference. If they do not have acute coronary syndromes, they do not need a cardiac catheterization. So in acute myocardial infarction, whether we should do complete revascularization is something that people have talked about for several years, and several studies gave a little bit of confusing data, and whether it is benefit is there in PRAMI and culprit, or whether it is safe to postpone after primary PCI in multi studies. So the complete study looked at STEMI with multivessel disease and successful PCI to the culprit lesion. Then they are randomized either to culprit lesion only revascularization, 2,000 patients, or complete revascularization in another 2,000 patients, and patients were followed up for 3 years. And these results came out that actually up to 5-year follow-up, people who had complete revascularization had a lower primary outcomes of cardiovascular death or new myocardial infarction at 2.7% versus culprit only at 3.7%. So to conclude complete trial, we can say it is safe to actually do complete revascularization, but treat the primary PCI first, culprit lesion, and then maybe before they go home, within a couple of days, you can go ahead and do the non-infarct related artery and send them home, and you can actually reduce the risk of death and MI. Number needed to treat is about 37. So then we took a look at the cardiogenic shock, whether we should do multi-vessel disease PCI in people with cardiogenic shock or only culprit vessel. Here, the culprit lesion only PCI actually favored, and do not try to do all multi-vessel PCI immediately in cardiogenic shock. This has been presented by Holger Thiel from Germany, and it has really been shown that mortality itself is lower with culprit only PCI in cardiogenic shock at 30 days. So how about using intravascular ultrasound for optimization of PCI? This is the first study that looked at actually angio-guided versus IVUS guided in 700 patients in each arm. And those are de novo lesions for all comers, and looking at a 3-year follow-up. And this is presented again yesterday at TCT, looking at what they have done with the primary endpoint being target vessel failure. So the 3-year clinical follow-up presented by Junji from Nanjing First Hospital has shown that angio-guided is 10.7% was the primary endpoint of target vessel failure, whereas IVUS guided is 6.6%, which is really terrific to know that IVUS does make a difference, and this is the first randomized controlled trial which is very strongly showing benefit of IVUS. Then coming to confusion of optimal DAPT duration after drug-eluting stent implantation, we are always confused. 3 months, 6 months, Onyx one says 1 month, other people say 12 months, and which one should we use? And there's several confusions of whether ischemia versus bleeding, and you have to make your evaluation and recommendation. So here is one study which actually looked at in Twilight, ticagrelor versus a placebo in all acute coronary syndrome patients versus ticagrelor plus aspirin, and they were followed at 15 months, and they're looking at how they did in these patients who were randomized either to DAPT in the red versus monotherapy with ticagrelor in blue. So the monotherapy after 1 month of DAPT has been shown to be beneficial with BARC 2, 3, and 5 bleeding is much lower with the ticagrelor monotherapy than with the DAPT. How about in acute coronary syndromes, death, MI, or stroke? So the efficacy is the ischemia mode. It was no difference at all at the end of a year between monotherapy of with ticagrelor versus DAPT with the ticagrelor and aspirin. So then ISAR React 5 actually was presented. It's a very good study that actually looked at is the benefit only with the ticagrelor. This is one of the first studies looking at head-to-head comparison of ticagrelor versus prasugrel. And in this, actually, it showed that the blue is prasugrel is actually very beneficial. Primary composite endpoint of death, MI stroke is lower with prasugrel than with actually with the ticagrelor. And the bleeding also is lower with the prasugrel monotherapy than with ticagrelor. And the same benefit has been shown in 2020 that diabetics in ISAR React 5 did much better with prasugrel. How about patients who have atrial fibrillation and need PCI? We have several data that actually is in different trials. This is a randomized meta-analysis that looked at all these patients who were enrolled in different trials and presented in 2020. And that actually looked at apixaban with the single antiplatelet agent, dabigatran 110 or 150 with a single antiplatelet agent, rivaroxaban with single antiplatelet agent, edoxaban with single antiplatelet agent. They were all better in terms of lower bleeding rates as compared to a warfarin plus a dual antiplatelet therapy, which is the reference. By this meta-analysis, we can say in patients with atrial fibrillation undergoing PCI, NOAC plus single antiplatelet agent is much better in reducing bleeding rates and also similar MACE and single ischemic endpoints with as compared to warfarin plus DAPT strategy. So this is a good study to support the NOAC plus single antiplatelet agents. As you know, this is presented at TCT today, a prospect absorb randomized controlled trial by Greg Stone, looking at absorb BVS in preventing future heart attacks or with absorb BVS in guideline-directed medical therapy versus guideline-directed medical therapy. But this is actually a study at 25 months looking at the lumen area. So minimal lumen area at the baseline, they were similar. And as you can see, people who had BVS, and they had a larger lumen area, and at the 25 months. And so this is a very important endpoint. Target lesion failures, however, they were similar in BRS versus medical therapy. And the randomized lesion-related MACE is much lower with the 4.3% versus 10.7% in guideline-directed medical therapy. So it looks like the story of BRS is not over yet, but this is not a trial that is powered for clinical outcomes. We need more data to look at it. So what's new in coronary PCI in 2020? My talk, PCI is still recommended for acute coronary syndromes. In stable patients, ischemia, however moderate or large it is, did not show any benefit for PCI, so do not do it. In coronary physiology with FFR, IFR is still strongly recommended. At TCT, there was multiple presentations today talking about even CT, FFR. Plaque modification and debulking of calcium is great. There is Disrupt CAD trial that is also very positive for lithoplasty and lithotripsy. Optimization of PCI with IVUS or OCT is very important. And DAPT dilemma still persists. I would recommend actually at least 1 month of DAPT followed by monotherapy for non-atrial fibrillation patients. But in patients with atrial fibrillation, you can give NOAC plus single antiplatelet agent. BRS looks like it is not dead. We still have to wait for the future. Thank you very much. I appreciate your time.
Okay. Thank you very much for very excellent summary of what the new in the 2019 with a lot result, a lot of the trial, ischemia, complete shock, complete, so on. I think many things to discuss. We will discuss after all presentation. Thank you so much, Dr. Bagati. The next speaker, I don't know, on the virtual session, Dr. Shortly. Can you hear me, Dr. Rosie? The next speaker, we would like to invite Dr. Quan Lee from University of Arizona with the presentation Lifelong Learning with Sky. Please, Dr. Quan Lee. Dr. Quan Lee.
To you today.
Yeah, Professor Dong, I have a pre-recorded presentation and we are waiting to play.
And my topic will be lifelong learning with Sky. I would like to be able to give you some background of what Sky is and the many ways in which Sky has advocated and organized to be able to propagate interventional cardiology lifelong learning.
Learning with Sky.
These are my conflicts of interest.
All right.
Sky was founded in 1977 by
a small group of thank you very much for the opportunity
and were
interested
in
intervention today at the.
They created a committee structure
first
to
Vietnamese
emphasizing
Sky
registration of
collaborative
developing quality standards.
This is the second of the Sky ASEAN series. It's a great
in the last 44 years
here.
Sky has
and before I start, I want to thank
and
the
well-organizers
of the meeting, Professor Dang, the president of the Vietnam Society of
primarily in the United States initially,
Professor
Quang Nguyen. In the last few years,
who's
we've expanded
current
to
Sky ambassador for Vietnam,
many international
Dr. Huy Dinh
partners
from Ho Chi Minh City.
So currently,
Professor
Sky is the only professional
and then the
medical
ASEAN
society in the US
representatives,
dedicated
Dr. Donnie Furman, who's here
cardiology.
on the panel.
We obviously
today
have our
from
big
Indonesia,
sister organization,
Dr. Rajinika Rajagopal from Brunei, and Dr. Ramesh Singh from Malaysia. I think this represents a very important move from Sky
they tend to embrace
try and bring more education to Southeast Asia. COVID has brought us further apart.
Why do people
but it
join
has
Sky?
also made us closer
members
by being
of
able
Sky,
to bring more faculty from all around the
87%
region
rate their membership
to the same meeting, and hopefully
the
we
number
can,
one reason is to stay up to date on the
bring
latest guidelines,
as much
breakthroughs,
education today
the
is
access that people have as part
about
of their
lifelong
membership
learning with
the
Sky.
CCI journal, which is one of the world's
These are my
flagship
conflicts of
journals
interest.
of interventional
So Sky was
cardiology.
founded in
The third part is
1977
really
in the
just
United
to
States
become
by
a part of the
cardiologists
wider
interested in
angiography
interventions.
and interventional
They started
cardiology
off by starting
community,
a
both
committee
nationally and internationally.
emphasizing
And
registration
to
of
also
procedures,
participate continuously in
developing
improving
quality
of patient
standards,
care,
developing
and,
credentialing
number
criteria,
5
as
is
well as
obtaining,
guidelines for training.
F-Sky
In the last
credentials.
43 to 44 years, it has
With a
become
career in interventional
the trusted
cardiology, all of us
home
here
for
today know
interventional
that learning never
cardiologists
stops.
internationally,
You
but
start off
mostly in
by,
the United States.
looking at
And it is
foundational
the
education
only
for
professional
trainees
medical
as they
society
try
in the U.S. currently
move towards
dedicated
graduating
solely
and
to
actually
interventional
becoming
cardiology.
interventional cardiologists.
We clearly have the
And here you
ACC
have
and
to think
AHA,
about
but those societies are
comprehensive
dedicated
curriculums.
to more broader fields.
Then you move
all
on
of
into the
cardiology.
early
And a lot
phase
of the
of your
members
career
of
as
Sky are
interventional
also
cardiologist.
members of ACC.
And as you mature and
AHA
become
leadership.
established interventional cardiologists,
Why do people join Sky? 87% of members rate their membership as valuable. They join because they want to stay up to date on the latest guidelines, breakthroughs, technologies, best practices, and research. They also join to be able to access the CCI journal, which is one of the world's most important interventional cardiology journals, and is part of the membership. And overall, to become part of the wider angiography and interventional cardiology community, both locally as well as around the world. And then clearly as a society, we are also focused on improving the quality of patient care through best practices, etc., and how cath labs run. So we are not just limited to the medical knowledge of interventional cardiology. And then obviously people also join to become fellows of Sky. And I think today will be a very important day for a big graduating day for many Vietnamese new F-Sky fellows. With a career in interventional cardiology, we all know that learning never stops. There's many stages of learning. You have the foundational education for trainees based on a curriculum of overall interventional cardiology. You then become an early career interventional cardiologist where you need to consolidate everything you learn as a fellow. And then once such as adaptive learning, where the teaching adjusts itself to the specific person. All of us learn differently, and the digital platform is going to allow us to do these things in the future. And I think Sky is fully committed to investing in all the infrastructure that will allow you to be able to learn in your own way. So these are many of the things, the benefits of joining Sky. You have discounts on learning libraries, Falls Fellows course, on-demand and Sky scientific sessions. You have access to the CCI publications, and then a lot of information about quality initiatives and clinical documents, as well as the ability to network. Importantly, I think for many ASEAN interventional cardiologists, there's also a chance to participate in many of Sky's committees and advisory councils, so you can start to share the expertise that you can bring from Southeast Asia internationally to the United States as well, so that hopefully there'll be a cross exchange of knowledge. So these are some of the educational offerings. Sky has had a very famous long-standing series of Fall Fellows courses, and this year the courses will be in December virtually. There's going to be courses on interventional cardiology, congenital heart disease, peripheral and structural heart disease. In the past, when the course was in person, Sky would reserve 2 spots for Vietnamese fellows to attend, sponsored over here. But I think this year, with the ability to have virtual meetings, I think we should open up the courses. Dr. Dagubadi, I'm sure, has something to say about this, to be able to have as many fellows from around the world attend as possible. For countries that are struggling to develop curriculum for themselves, for what it means to the, what the boundaries of the knowledge of interventional cardiology is, Sky has over the years published an interventional cardiology review textbook, and it serves in the United States as the basis for which we base our knowledge of what we need to know to become interventional cardiologists. And a lot of US physicians will use this as part of their board review. So we are now in a 3rd edition, and this is written by Dr. Kern and Dr. Sito. It has a full curriculum of everything that you need to know for interventional cardiologists under 9 different sections. Now that we have lots and lots of virtual meetings, Sky obviously has joined the big offering menu, and Sky Shock is the next big meeting that we have on October 29th to 30th, and you're all welcome to join and register. It's a virtual conference talking specifically about shock. Next year, for our normal annual meeting in Chicago in 2021, we will be having the meeting from April 28th to May 1st, and it will be a hybrid in-person partially. Hopefully, we will do better in the United States with COVID at that point, and travel will be more open. But the scientific sessions normally offer networking, collaboration opportunities. There are many dedicated tracks, live cases, etc., and many opportunities for us to collaborate and network. So this year, next year, if people are able to come, hopefully Sky will be able to help sponsor travel from Southeast Asia if that's possible. But we'll see. And if not, we will obviously expand attendance as much as possible virtually. If you go onto the SKY website, there's a new website, and they have started to organize all of their offerings for virtual learning in folders like this. And this is new, and it continues to grow. There are many, many topics. There's complex decision making in STEMI. There's things like coding for congenital heart disease intervention. So it deals with both the medical knowledge, once again, and the operational knowledge that you need to run a good cath lab. And this is an example of what one of these sessions look like. Some of these are free as members of SKY, and some of these as non-members of SKY, there is a fee involved. So this is one of the benefits of being a member of SKY. The American College of Cardiology has a self-assessment module that has a few hundred questions. Some of us learn very well with doing questions online. And many of the SKY members, when they developed CAFSAP, were part of the development committee. And so they also helped to write the questions. As a member of SKY, you get 20% off the access to CAFSAP from the ACC. It is not a cheap module. For members, it's $1,500 US. So I'm not sure how accessible this is to non-US countries, but it also has a very, covers all of the field of interventional cardiology. SKY runs a continuous monthly series of quality improvement tips. And so if you sign up, they will send you a summary every month of a new topic. And they've been very good about it. And these are some of the examples of the topics that have been available. Anticoagulation monitoring during cardiac procedures, rotational versus orbital atherectomy, resuscitation of COVID-19 patients in the cath lab. There have been a lot of COVID topics, and left radial arterial access. And this is an example of the first third of one of the entries on left radial arterial access that I wrote with Dr. Sandeep Nathan and Dr. Trong. As part of the operational stuff, SKY has also helped by developing things that you can use in your own cath lab, so you don't have to go off and reinvent the wheel. This is an example of a cardiac cath procedural checklist that you can also apply locally. About the CCI journal, this is a flagship journal. It was founded in 1975, has an impact factor of 2.044, is published once a month, and it covers, many, many different topics, from clinical basic science research to obviously a lot of interventional cardiology topics, from structural to peripheral and also coronary as well. And there are many case reports in there that are very interesting. SKY has also developed online e-textbooks, and this was developed in conjunction with Abiomed and deals entirely with vascular access management and closure best practices. I think this is probably the best textbook on this I've ever seen before. This is the first of all the textbooks, and soon I think the next one that's coming up is a textbook from SKY on bifurcation PCI. And that's currently in development, but please go online and follow the link and check it out. We are also starting a new process where you can submit cases that will be featured on the SKY website internationally. If you do a case that's very interesting and wish to share it, what you do is you write in and ask for the template, and then if you fill up the presentation and send it back to SKY, it will be reviewed, and if it's accepted, your case will be featured on the SKY website as it begins to grow a library of interesting cases from around the world. Another great resource are SKY clinical documents. SKY publishes multiple of these per year. I think there are about 10 every year, and these are much more detailed than, say, the SKY quality tips. And these are some of the examples of things that they have covered in the past. The expert statement on the use of percutaneous cardiac assist devices, core curriculum for adult and pediatric interventional fellowship training, expert consensus statement. And this is especially useful, I think, in countries that are introducing new procedures where the credentialing and what it means to be able to do these things is not well established. So this can serve as a good baseline for developing for new procedures entering a country, for people to be able to say, what do I need to know before I start doing these things like carotid stenting, PFO closure, left atrial appendage closure, etc. And then there have been many, many documents about COVID-19 considerations. And this is an example of one of those documents. Here, the example is specifically on how to protect the healthcare workers that work in the catheterization laboratory, specifically when it comes to radiation, right? All of us are going to grow old with cataracts and sometimes maybe brain tumors, hopefully not. Sky, for everything, there nowadays is an app. Sky has 2 apps which can help you. There's the Sky PCI risk calculator and Sky appropriate use calculator tools on your phone. And you can get it from the Apple Store and the Google Store. And that helps you calculate the pre-procedure risk of the patient. The Sky on the website has also developed a COVID-19 resource center that's a one-stop shop where you can go if you have questions that you need to know about how to practice interventional cardiology in the era of COVID. And that is the link online. And this is, Sky also has not limited its education to physicians. It has also developed a campaign to help educate our patients, because during COVID-19, what we've realized in the United States and in many places around the world, patients for a while stopped coming to the hospitals. So our rate of acute MI seemed to decrease, but more patients were actually dying at home because they were scared of coming in. What we have learned in the United States thus far, and I'm sure in some other countries, is that the hospitals are not dangerous places to be. We have pretty much figured out how to prevent healthcare transmission, for the most part, in most hospitals. My hospital system has not seen a single case of a healthcare worker COVID acquisition in probably the last 6 months. In the beginning, we had a few, but as we've gotten better with PPE and how to screen patients, it's become very safe. So that's an important message for our patients. So what are the challenges and future directions when it comes to lifelong education, specifically as it pertains to the ASEAN countries? The question is, how do we make it more relevant for you? Do we adjust the curriculum that we would accept for ourselves for countries, say, Donnie, for Indonesia, for example? Do we try and tailor it? Because obviously impeller use is not realistically viable. Can we translate our curriculum and our documents to local languages like Vietnamese and Bahasa Indonesia and Bahasa Malaysia? Can we help develop national training curricula with you? Can we help sponsor participation in US Sky meetings and fellow courses for our ASEAN members? And then how can we increase participation in our friends in contributing cases, their techniques and expertise? I've been a member of an ASEAN chat group of interventional cardiologists for about 2 or 3 years now, and I've learned a lot from my friends. So thank you very much. We have much to learn from each other, and we have much to learn together in the years to come. Thank you. Okay. So I think
you're muted.
Okay, I think the plan at this juncture, was for us as a committee and as a group to discuss the topic of what's next after PCI. That was Dr. Rosley's original topic. Many of us trained a long time to get to the point where we become very good coronary interventionists, but as you all know, it has not stopped at that, right? We've looked at every other vessel and every other structure related to the heart, and taking our skills that we have learned from coronary intervention, we have sat there and said, I think I can also do that. And so over time, especially in the United States, we've had interventional cardiologists start to then move forward to the field of structural heart disease, peripheral vascular disease, and as well as the latest frontier is interventional cardiologists looking again at getting into acute stroke intervention. So I wanted to open up the panel and ask for our panelists' experience and for advice as to what you think is the next frontier. So I think we'll start with Dr. Dagubadi. Dr. Dagubadi, you're a structuralist, so.
Yes. So I think this is a very good point that you're making, Dr. Lee. We do not want to stop with what we are comfortable with. We always, that is the nature of interventional cardiologists, is to push the envelope, learn new techniques, and maybe do structural or stroke. I mean, I have done carotid stenting, and I did not get an opportunity to do the stroke interventions, but I think that is really an interesting area. At the same time, we need to make sure that people are trained well. With the proper training and observing people, apprenticeship, as these conferences or SCI conferences, people should learn from each other, and that kind of a shared platform will make sure that we can get good outcomes and quality can be maintained, because brain is not as forgiving as the heart is, in my opinion. And we can do a lot of slow reflow, no reflow in the heart, and the heart will recover, but in brain it does not. And I think that's why it is better to do a dedicated either 3 months to 1 year. I always recommend 1 year, but sometimes even probably 3 months of dedicated stroke interventions is very good.
Dr. Firman, what about in Indonesia? Are interventional cardiologists doing more than the coronaries now?
Yes, thank you, Dr. Lee. So in Indonesia, we already done several things way years back. Outside of coronary, the mitral stenosis still very much in this area. I think in Vietnam, but in Indonesia we still have that. So we started this program, I think around 25 or 30 years ago by my seniors. And then now for structural, we already started since 5 years ago, TAVR and also MitraClip, and doing it in my hospital. And also some of my colleagues doing peripheral. They're doing EVAR, TVAR or something like that, and they're doing great. And also, of course, the PFO closure, ASD and VSD by tennis. But the thing is interesting how to jump to neurointervention. This is something that, what do you call it, very political. I know what's happened in US, you guys can do that. But of course, we also doing in my lab, if there is some complication happen when you're doing, let's say, PCI or structural heart disease, because we have no neurointervention in our hospital. But for a naive stroke, I think in my country, we still rely on the neurointervention, because our colleague in neuro already started this program as well. And also radiology intervention was done for a few years. But beside that, I think I agree that it's really important and interesting. Of course, as an interventional cardiologist, we can say that we can do that because we're really good in hands. We assume we can do that, but I think it's depend on regulation. In each nation, so it's different. I know in Brunei, Raja, I can sing Raja now. So it is depend on our regulations. So that's all.
Yeah, Dr. Rajagopal, do you have any comments? You're on mute, by the way.
Just unmute. Thank you. First of all, can I say, I've been in touch with Dr. Rosley this morning. He sends his apologies for not being able to give his talk. He's got a family function, and there's been some communication gap. So yes, great points by Dr. Dagubati and Dr. Firman. My training was in the UK, and in the UK, we're very different from the US. We only do coronary. We do not venture anywhere outside the heart. And we do TAVI, but we don't do peripheral intervention, no stroke intervention. It's entirely the realm of non-cardiologists, vascular surgeons or radiologists. I thought no exposure to any of this before I came to Brunei. When we came to Brunei, there was a need for peripheral intervention. And so my colleague, vascular surgeon, and I went to Korea, spent a week there observing peripheral interventions. And we came back to start an AV fistula intervention program. And we've been running it for about 3 years now. We did about 80 cases last year. And it's been absolutely, it's satisfying. It's been a really useful practice because, we could add lives to people's, years to people's lives. As Donnie said, as cardiologists, interventionists, passing a wire, passing a balloon is quite easy. So there were two things I think that made a big difference to me. One is teamwork. I had vascular surgeons and renal physicians telling me, this is the vein. And I see a bunch of veins there. I don't know which one's the main vein, which one's, just, when I don't need to treat. And they're able to tell me where I should be passing a wire and balloon. And then, when you're used to dealing with 2 millimeter vessels, you have a 8 millimeter vessel, it's quite easy. The second is proctorship. I think, we had proctors, vascular surgeons from Singapore. He came to us for the first 1 year. We had Shaiful from and then we got the hang of it, and we were able to still maintain touch over phone. Send them cases, diagnostic pictures, they guided us. I think that really helped us. And for the last couple of years, we've been totally independent, and we do quite a huge number of cases. And we feel it's very satisfying. You're instant. You treat, AV fistula, which is completely occluded, and we get a thrill back at the end of the procedure. Very satisfying. So yes, I think it's possible to venture into new areas. As Donnie said, and Dr. Dagubadi said before that, we need to have, it should be planned. We can't just, okay, let me try put a wire into some strange vessel, which I've not done before. There should be a plan, proctorship, team, and then I think it's quite possible, and it actually yields really good results, and it's very satisfying. That's been my experience here.
Professor Dang, what has the experience in Vietnam been? How much more are interventional cardiologists doing beyond the coronaries?
My answer is the new frontier for the next in the interventional cardiology in Vietnam. We have two important things. The first thing, look like every country, we like to learn to do the new technique, new horizon of the interventional cardiology, such as the robotics or TAVI, microclip, complex PCI. But the second important thing, I think, because look, as I said beginning, the throw of the interventional cardiology in Vietnam very quickly. So by now, we must pay attention. Look like Dr. Ramesh Yuvagasti that train well. It means we should do a standardization for all the cath lab in Vietnam because it grow very quickly. So we need some many training call from Sky.
Yes, those are very important points. I think in the United States, I think for procedures that can only be done by cardiologists, like PFO closure, TAVR, MitraClip, etc., or even TAVR or MitraClip maybe, because TAVR can also be done by a surgeon. There's not that much issue, and we are free to develop our own training standards. But what we found in the United States over the years, when you have procedures that other specialties can also do, then there is a lot of political discussion, fighting sometimes, and it's very hard then to say, because really, if multiple specialists end up doing the same procedure, you can argue that the training for that procedure needs to be the same across all the different specialists. So we often have to also work with vascular surgery, neurointervention, cardiothoracic surgery, interventional radiology to sometimes develop joint training standards. In the United States, some of those battles, despite being 20 years old, have not been won. So we have sometimes had to then develop our own training standards and just
say to the other society, you know, we understand that you don't like us being here, but we show that our outcomes are just as good. So a lot of this also, I think, has to center around the patient. You know, just because we think we can do it, we still have to make sure that the procedures are indicated, right? And that they are appropriate, because many times there is an issue of people trying to make money off a procedure. We can never allow that to take over our primary concern for the patient. And whenever we are moving into a field, the way we validate ourselves is to make sure we have registries where we show that our outcomes are just as good as other people's outcomes.
I also want to add that Sky and maybe of some use for ASEAN regions to have some mini fellowships for a couple of months to train young people or even mid-career people who want to get some special training in such areas such as TAVI, MitraClip, etc.
Yeah. Excellent.
Yeah, in the ASEAN countries, have you had the same problem with the arguments between societies? Donnie is smiling there.
I think that's the beauty, right? In our profession, it's a lot of talk regarding that. You know, we have Indonesian Medical Council, and then, you know, there's this what we call discussion, but it's not discussion, it's fighting, and there's a never-ending story, never a conclusion, like I mentioned before. So every like the cardiology association have their own training, you know, program and their own certificate. We have our certificate, and then also radiologists and also neuroradiologists or something like that. So every society have their own way, but then they must report to Indonesian Medical Council. So it depends on each hospital, you know, which or whom they want to, you know, have some subspecialty like this. So I don't know, it's not national regulation. I mean, it's depends on the hospital finally. Yeah. So I don't know what happened in US or Vietnam.
Okay. I'm sorry, the time of our session is remaining 1 minute. So okay. On behalf of the Vietnam Heart Association, I thank very much for our faculty with the very excellent presentation. And I hope we will see you the next session and the next year. Thank you so much.
Thank you.
Yeah,
I want to bye-bye.
Yeah, I want to make sure before we log off that we thank Elizabeth Burke, who is our Sky representative, who has really helped to put this the US section of this program together.
Absolutely.
Yeah.
Very good.
Absolutely.
Thank you.
Thank you. See you. See you.
See you.
Rồi cắt đi. Đó.
Thầy có thể mở cái thầy có thể
Diễn đàn trực tuyến hot nhất được phát trực tiếp trên các nền tảng trực tuyến của Hội Tim Mạch Việt Nam. Tâm điểm 2020 phát sóng 9 giờ đến 10 giờ sáng, thứ Bảy hàng tuần bắt đầu từ ngày 13 tháng 6 năm 2020.
Ấn phẩm truyền hình hàng đầu của Hội Tim Mạch học Quốc gia Việt Nam.
Tin tức chắt lọc, cập nhật, thấy dịch.
your presentation from your computer, since you can adjust the presentation from our computer.
Các anh phát cái bài mà tôi đã ghi lại và chuyển lên mạng rồi đi.
Thầy có vẻ không
có chuyển slide được không?
Làm sao để cháu chuyển slide được?
Mình này.
Of radial artery that originates from the brachial arteries at the antecubital space. Can impact the catheterization, the small vessel, or absent or remnant, or resistant spasm, tortuosity or loop, and anatomy anomaly. Next, please. This is the anatomy variants that do not obstruct the transradial catheterization with the connection from the radial artery to the brachial arteries at a high level or low level, but we can easily advancement of the catheter. Next, please. But there are also other variants that prevent the possibility of catheterization, like the hypoplastic or complex loop or remnant radial artery. Next, please. This is the variants that we can overcome with the techniques. For example, the radial artery tortuosity or focal radial artery spasm or diffuse spasm caused by our device, something like a wire or catheter. Next, please. And maybe a very complex loop up to 360 degrees. But first of all, the spasmolytic protocol is the most important solution for prevention as well as for treatment of the spasm. First of all, the local intra-arterial coccylytic is very routinely used for every procedure after insertion of the sheath, including the verapamil and nitroglycerin. In case the spasm occurs, we can combine a general treatment with sedation or anesthesia and a local treatment like forearm warming or reacting hyperemia. If the spasm is resistant, maybe we need to do an axillary plexus block or combine with a surgical endarterectomy. Next, please. Now I talk about how to overcome the artery tortuosity or loop. First, for the simple loop or tortuosity, just the wire manipulation can solve the problem. Open 35 guide wire normal is the first choice. But in case of any resistance to the movement of the wire or the catheter, or the patient complains of pain, we should have to stop the wire and the catheters and inject a diluted contrast to verify the vasculature. Then under the guide of the vasculature, we rotate gently the catheter clockwise or counterclockwise along with the loop direction, and that may help to advance successfully the wire first and then the catheter through the segment. If the normal wire doesn't work, we can exchange to a hydrophilic coating. It's easier for us to drive it through the tortuosity, but it's a little bit dangerous. Once it travels across the local segment with the Y, we can advance the Y over the Y, and then we keep or hold the Y and the catheter together, pull back and rotate. And this trick can help to straighten the tortuosity. In case the standard or an hydrophilic over 35-inch Y doesn't work, we can have to use a PTCA Y, very small, to be easier to get through the loop. And then we expand the catheter. And then when the catheter can move successfully, we exchange to a diagnostic Y later. Next, please. There is an image of a complex loop of the radial artery, and we can pass with diagnostic Y. And after that, we pull back the Y, and the Y can help to straighten the loop. Next, please. This is the other case, more complicated with the small radial artery loop and remnant. And then we have to use the PTSA Y and two Ys at the same time, sequentially, and on both the Ys can pass the segment, the loop. Then we advance the catheters, and when the catheters can cross the loop, we exchange with diagnostic Y, and then pull back the assembly of the Y and the catheter at the same time. We can open the straighten the loop. Next, please. There's some notice the arterial spasm may be triggered or worsened by the friction between the wall of the artery and the Y when we straighten the Y. And second is the space between the Y and the guide lumen allows the margin of the catheter tip to cause trauma, irritation, and spasm in the arteries. That is the commonly called a razor effect. Now there is another technique that is called catheter assisted tracking technique, CAT. After advancement of the Y through radial arteries, the spasm occurs very severely. Next, please. And then we use a longer and smaller catheters in the big catheters, and we move both of them at the same time over the Y. Next, please. And the mother and child catheters can cross the artery, the segment, with plastic. We can use another special catheter. It is a child catheters. So there is like the old U-cath catheters with a more taper tip that is longer than normal catheters. Next, please. And you can see the image of the mother and child catheter. Next, please. Another technique is the balloon assisted tracking, BAT technique. This is for the complicated cases. First of all, we cross an PTCA Y through the spastic tortuous segment or a loop, and then we advance the catheter over the Y in the artery, and we stop the Y before in front of the spasm or tortuous segment. Then we advance the compliant balloon over the Y to the tip of the catheter with the protrusion about half of the balloon. The diameter of the balloon is decided by the outer diameter of the catheter with a length of about 15 millimeter. Then we inflate the balloon at the above nominal pressure. And then we advance the entire assembly, the balloon, the Y, over the catheters, over the Y through the spastic segment. On the image, we can see how the pressure in the balloon may affect to the flexibility of the balloon tip. The BAT technique allows for an easy traumatic passage of a flexible and conical tip of the balloon at the catheter tip. And as the BAT assembly is advanced, the balloon tip prevents the razor effect, as you can see on the image, and then it can minimize the irritation and spasm. Next, please. The BAT technique is successful in a high percentage of cases, more than 90%, and reduce the crossover to femoral rate. The artery variants that may require BAT technique is such as a small artery, tortuous loop, resistant, spastic resistant spasm, extensive arteriosclerotic lesions, or complex loop. Next, please. There is some images about the efficacy of the BAT technique in a radial artery tortuosity and loop with the BAT technique. Next, please. This is the first case where small radial arteries that the BAT technique can help to move the catheter through the small artery. Next, please. There is a very extensive arteriosclerotic and tortuous radial artery at the same on the same segment, and the BAT technique is very helpful. Next, please. The BAT technique can help to move the catheters along with the loop, and then we can open the loop with the assembly. In some cases of very severe spasm and responding to spasmolytic, the BAT technique can help to move on the catheter through the segment. But there is also another efficacy of the BAT technique for the case illustration. This is the case with an radial artery perforation by the wire. But with the help of the BAT technique, we can move the catheter across with the segment. And with the existence of the catheters inside the radial arteries, after the procedure, injection of contrast for control that doesn't reveal any perforation. So I have some messages. Radial artery is becoming more popular access for radial catheterization with a more advantage and less complication than the femoral artery. Certain vascular variants of the radial artery may prevent the catheterization success, like a small diameter, tortuosity, loop, and spasm. The aggressive investment of the wire or catheter in such cases can cause the complication. Some tip and technique like wire exchange, catheter assisted tracking, or balloon assisted tracking technique can help us to overcome this radial artery. Thank you very much for your attention. Have you got any question?
I'll ask a quick question. For balloon-assisted tracking, is there a specific balloon you match up the size of the balloon to the tip of the catheter? Do you always use a 2 millimeter balloon, 2.5? What are your equipment choices?
The only role of the balloon is to taper the tip and to prevent the razor effect. So a normal compliant balloon is suitable. The length is about 15 to 20 millimeters. That's just long enough to be half outside and half inside the catheters. About the diameter, we depend on the outer diameter. You'll have the same diameter with the outer diameter of the catheter, and that is razor effect.
That was an excellent talk. Thank you.
Thank you. We now talk with the complications that radio affect with Dr. Sandeep Nathan, please.
I think my talk comes a little bit later. My talk is the last one of this session. So I think it's a different speaker for complications.
Yes, thank you.
I think it's my talk for radial complications.
Yeah.
Review how to deal with radial access complications. I don't have any relevant financial conflicts of interest to disclose. For majority of our patients, multiple randomized studies have shown lower bleeding, both access site and non-access site bleeding complications with radial access compared to femoral access. A recently published analysis of NCDR shows an increase in radial access use in the United States, even though we lag behind the Europe. Even though the access site complications with radial access are rare, it has been well documented in the literature. And one needs to be facile with avoiding and managing these complications. This picture here was adapted from Circ cardiovascular interventions paper that was published in 2019. When you think about complications, generally you can divide them into interprocedural and post-procedural, and in turn into bleeding and non-bleeding complication. For example, interprocedural bleeding complications would include radial artery perforation. And on the non-bleeding side, it would include radial spasm, dissection, and kink catheters. And when you look at the post-procedural bleeding complications, that would include the hematomas and compartment syndromes. And in the non-bleeding side, you would see radial occlusion, pseudoaneurysm, AV fistulas, nerve damage, and infections. Let's review some intraprocedural complications. The first one being radial perforation. This is fortunately a rare complication seen in less than 1% of all radial cases. And majority of the time this is caused by advancing the wire or catheter into a small branch inadvertently. And it's most commonly seen with hydrophilic wires, which is why generally it's a good idea to use J-tip wires with radial access. When you experience any resistance with wire or catheter advancement, it's wise to stop and take an angiography to see what you're dealing with. And radial perforation is most commonly seen with tortuous or small caliber radial arteries, and it presents as pain or swelling in the forearm. Once you have a radial perforation, the way to deal with it will depend on whether you have a wire across the perforation or not. If you had a wire across the perforation, then generally you can exchange your short sheath for a longer sheath or advance your guide catheter using balloon-assisted tracking, and this might seal the perforation temporarily, which would enable you to continue with your planned procedure. And after you're done with the procedure, then repeat the angiography to see if the perforation is sealed. If the perforation is sealed, then all is just compression bandage and observe for compartment syndrome. If you don't have a sealed perforation at the end of the case, then you have to consider reversing the anticoagulation. You could try achieving hemostasis with a blood pressure cuff that's inflated proximal to the perforation to suprasystolic pressures and leave it inflated for a few minutes. You could consider balloon inflations just like coronary perforations. Rarely there have been case reports of covered stent use for radial perforations. You could consider using external compression using compression bandages or manual compression and obtain surgical consultation. If you don't have a wire across the perforation, then you would have to consider reversing anticoagulation, and you could try to achieve hemostasis with the blood pressure cuff, as I just told you, external compression with compression bandages or manual compression, and obtain surgical consultation soon. Balloon-assisted tracking is a technique that comes in very handy when you're dealing with small caliber and tortuous radial arteries. Here, when you advance your guide over the wire, you would have resistance or razor effect. To minimize this, you could use a partially inflated balloon both inside and outside the catheter that would smoothen your transition point, which would then enable you to navigate these tortuous radial arteries much easily. And this is also a good technique to avoid radial perforations. The next commonly seen complication is a radial spasm, and this happens to be the most common complication with radial access. It manifests as resistance to catheter or wire advancement. It's seen in about 4 to 20% of all radial cases, but this is when you think about any radial spasm. Fortunately, the moderate to severe spasm still happens to be rare, seen in about 5% of all radial cases. And there are certain anatomic and procedural predictors for radial spasm. Anomalous takeoff, small caliber radial arteries tend to have more spasm. If you have numerous puncture attempts or multiple catheter exchanges, or if the patient experiences significant pain or anxiety during access, these predict radial spasm. How do you prevent them? Obviously, adequate sedation and analgesia becomes critical before access. And one should try to avoid multiple puncture attempts. You could consider using ultrasound. This was shown to be beneficial in the Ross trial. You should consider using sublingual or topical nitroglycerin to vasodilate the radial artery. Hydrophilic sheets have shown to have less spasm. The most important way to prevent spasm would be to using antispasmolytic drugs, which is usually a combination of a calcium channel blocker and nitroglycerin. In our lab, we use 5 milligrams of verapamil and 2 cc's of lidocaine, plus or minus nitroglycerin as needed. Please also note that you could consider repeating doses in between catheter exchanges if you experience spasm. How do you deal with radial spasm? It depends on what part of the procedure you experience a spasm in. If it's a puncture-induced spasm, then you should consider flow-mediated vasodilation, and I'll tell you what that is. You can use sublingual or topical nitroglycerin. You should use ultrasound for radial access to minimize the puncture attempts. If the radial spasm happens during the procedure, and if it's mild, then most of the time you can get away with more sedation or pain control, or using multiple doses of antispasmolytic drugs that I just showed you. If it's a severe or moderate spasm that results in catheter or sheath entrapment, then you would still consider using more sedation medications and analgesic medications, antispasmolytic therapy as first line. If that fails, then you could use flow-mediated vasodilation using a blood pressure cuff. What that is you would put a blood pressure cuff in the brachial artery, inflate it to suprasystolic, typically 30 to 50 millimeters above the systolic pressure, leave it up for 3 minutes, and then deflate it to cause flow-mediated vasodilation in the downstream radial artery. You could use warm compresses and forearm heating or subcutaneous nitroglycerin injections. There have also been reports of using Viproglide or Rotaglide solutions to relieve spasm. Very rarely you would have to use deep sedation, general anesthesia, or axillary nerve block to relieve severe radial spasm. Another complication that you could run into when navigating tortuous arteries are kinked catheters. When you have a kinked catheter, it's very important to recognize this promptly. And there are different techniques to correct this. The most important way is to fix the catheter proximally, either with external manual compression or with a blood pressure cuff, and then try to unkink it. If that doesn't work, then you can advance a long sheath over the kink segment and then pull it out as one unit. Or you could snare the kink catheter from the femoral approach. And this is how you can advance a long sheath. You have to cut the back end of the catheter, kinked catheter, and then pull the short sheath over the catheter and advance the long sheath to the tip of the kinked segment. Then you could pull the kinked catheter into the long sheath and then pull them both as a unit. And this is a good way to avoid injury to the radial artery. Next, we'll review some commonly seen post-procedural radial access complications, the most common being radial artery occlusion. The incidence of this remains unknown, mostly because of different definitions that were used in different studies, and the timing of when you assess the patency, and the varied hemostasis protocols. The incidence of this complication can range anywhere between 1 to 30%, depending on the study that you look at. Fortunately, majority of the radial artery occlusion cases are asymptomatic. Very rarely you would have to consider treatment such as anticoagulation or endovascular therapies. Just like any other complication, prevention is key. Here, therapeutic anticoagulation has been associated with lower rates of radial occlusion, avoiding spasm, minimizing access attempts, using slender and small caliber sheaths. And the most important way to avoid radial occlusion is by employing patent hemostasis. And there are recent reports of combining patent hemostasis with ulnar compression to improve your radial occlusion rates. Majority of these, as I told you, resolve spontaneously at 30-day follow-up. The most dreaded radial complication post-procedurally is the hematoma or compartment syndrome. The exact incidence of this complication is unknown. Fortunately, it's very, very rare, especially the compartment syndrome. Happens in 0.004% of all radial cases. Prompt recognition and therapy happens to be the critical step. Small hematomas, you can get away by repositioning your TR band or the hemostasis device. If you have a large hematoma, put a blood pressure cuff in the brachial artery, inflate it to suprasystolic pressure, then reposition your device. Close neurovascular monitoring, more manual compression, and consider surgical consultation early in the complication period. There is a grading system for hematomas. Grade 1 is less than 5 centimeter, typically superficial. Grade 2 is less than 10 centimeter, but involves the muscular plane. Grade 3 is greater than 10 centimeter, but it's restricted to forearm. Grade 4 is greater than 10 centimeter, but extends above the elbow. Grade 5 could be any size when it's associated with neurovascular compromise, which is your compartment syndrome. And this is a surgical emergency where they would need an emergent fasciotomy. Radial pseudoaneurysm is another complication which is rare, unlike femoral pseudoaneurysms. Its incidence is anywhere between 0.03 to 0.09% of all radial access cases. Typically presents with a pulsatile swelling at the access site. You could use ultrasound to diagnose it. Rarely needs treatment. The risk factors for radial pseudoaneurysm development include multiple access attempts, supratherapeutic anticoagulation levels, and poor hemostasis techniques at the end of the case. As I said, majority of these are just observed. Very rarely you would need ultrasound-guided compression, thrombin injections, or surgery for larger pseudoaneurysms. Some of the rare complications, I'm just going to name them here. We don't have time to go through each and every one of these complications, but they are fortunately very rare. These include AV fistulae, granulomas, nerve injuries, complex regional pain syndrome has been described after radial procedures, a radial artery eversion where you avulse the entire radial artery at the end of the case when you pull your catheters or the sheaths. These have been reported. And non-occlusive radial artery injury that's typically described on OCT studies of radial arteries. So to conclude, radial access complications are fortunately rare. Majority of them are treated conservatively. Key is early recognition. Most of these complications can be avoided by meticulous techniques. but one needs to be aware of contemporary bailout strategies if you run into some of these complications. I want to thank Sky and the organizers for giving me this opportunity. Thank you.
Thank you. I have a small question. What do you think about the necessity of the Allen test before the radial artery access?
That's a good question. I mean, I think we don't do routinely do Allen's or Barbeau's before we do procedures. I don't think it's very beneficial in deciding whether you want to go radial or not. Or also, it doesn't predict any complications post radial access. So typically, we don't do it at all.
Thank you.
Sandeep, do you guys? What are your thoughts on that? Do you guys do it routinely?
Pardon?
So, you know, when we started our radio program about 12, 13 years ago, we did only because there was criticism about using radial so long ago in the United States. And so just to, you know, cover ourselves and make sure that we weren't increasing complications, we did that maybe for the first 500 cases. The interesting thing is that, you know, the Allen's test or even the Barbeau test is such a simple assessment for such a complex blood supply. And many times, you know, you'll put a radial sheath in during the context of a STEMI. Your waveform will go completely flat and you'll just keep doing your case. And then 10 minutes later, all of a sudden you have a bouncing waveform. So, you know, it took full 10 minutes to recruit palmar collaterals and the patient is fine. You know, Barbeau concedes in his paper, in the discussion of the paper, that they picked 2 minutes for the Barbeau test quite randomly. They just said, you know, they got tired of waiting after 2 minutes, and, you know, in the 1,000 or 1,100 patients that were included in that paper, that was just picked as a nice round number, but I don't think it really describes the physiology.
Yeah, I have some a question for both of you from United States. We all know that the femoral artery access is more access site complication, especially the bleeding, and requires the patient long immobilization and then long hospitalization. It means that is more cost than the radial arteries. That is what is the possible reason why the United States is now after the Europe and especially the Asia in the radial artery access?
Madan, do you want to take it? I've got some thoughts, but please, why don't you go first?
Sure. I think it's just the teaching. You know, historically, it's been femoral access in U.S. And then the rate of crossover, you know, retraining operators and switching back to radial access has been very, very poor. Number one. Number two, people have also, you know, talked about, you know, how do I, you know, when they start doing radial access, the setup takes a little bit of time. The cath lab staff, you know, start complaining about, you know, procedures taking longer. And then, you know, when do you switch from stable coronary disease interventions to acute interventions, potentially doing STEMIs radial access? So I think these are the factors that have, you know, gotten us very slow in this ball game, radial access ball game.
Okay, thank you for your idea. Are you ready for your presentation now? That's okay with the mission? So it's your turn.
Yeah, I have a recorded. Can turn on my recorded? Yes.
Okay.
Thank you, Mr. Chairman. It is great honor for me to be invited to this prestigious Congress. Allow me to congratulate organizing committee of Vietnam National Heart Association in organizing this successful 17th National Congress of Cardiology. My title presentation is Alternative Approach for Vascular Access, distal radial or ulnar. I'm going to talk more about practical aspect of distal radial artery approach, and then at the last slide, I'm touching upon ulnar access. Distal radial artery and ulnar artery are the alternative access for cardiac intervention. Understanding these alternative access can increase options for operators and potentially improve comfort for patients. It is important to understand the basic principle of obtaining access of distal radial and ulnar artery. Let me start with distal transradial access. This access is newly emerging non-femoral access for cardiac intervention, gained increasing popularity among interventional cardiologists since 3 years ago. This transradial access overcomes some drawback of standard radial artery cannulation in several aspects. There are some benefits which can be offered by this access. This is an option in patients with various orthopedic limitations who are unable to supinate their arm, like the patient with frozen shoulder, frozen elbow. And distal transradial access potentially can decrease the incidence of radial artery occlusion. Patients with distal transradial access can mobilize their wrist with no increased risk for vascular complication. This access potentially reduces hemostasis durations. And the proximal radial artery can be preserved for future procedures such as bypass grafting or arteriovascular shunt. Dr. Babunashvili and Dr. Kaladin for Russia were the first to introduce the concept of distal transradial access. Dr. Babunashvili initially used distal access for recanalization of occluded ipsilateral radial artery in retrograde way. Both operators influenced Dr. Rouhani from Iran to attempt distal access because many of his female patients do not want to remove their bracelet that cover the forearm. Dr. Khimeni learned from Dr. Rouhani during his visitation to Iran in 2016. Dr. Khimeni first reported left distal transradial access in the anatomical snuff box for interventional therapy in 2017. Distal radial access became popular because through this access, we can perform procedure via left arm, which is convenient for right-handed patient and improve operator comfort. Regarding the puncture point, there are two, I show you, there are two sides of dorsum of hand can be used as puncture point. The first is this anatomical snuff box. And the second one is the first intermetacarpal space. You can puncture from this side or this side. But as you know that the first intermetacarpal space is very challenging when you do punctures. So the higher failure rate is increased. Then most operators use this side as the puncture point. Use anatomical snuff box as the puncture point. Let's refresh our understanding what is the anatomical snuff box. The snuff box is triangular depression space on the dorsal aspect of the hand. It has three borders, a floor and a roof. At the medial border, there is tendon of the extensor pollicis longus muscle. And the lateral border, there are two tendons. First, tendon of the abductor pollicis longus and tendon of extensor pollicis brevis muscle. The proximal border is styloid process of the radius. The anatomical basement composed of distal radius, scaphoid, trapezium, and the base of the first metacarpal bone. And the roof is formed by the skin and superficial fascia, in where we can find the cephalic vein and superficial branch of the radial nerve. These are the picture of our cath lab during cardiac procedure. At left picture, as you see here, the left arm patient can be brought comfortably toward the right side of the hand, which is difficult when you do left proximal transradial access, because the patient with a supinate arm cannot brought to these positions. So the operator performed the procedure without bending his back. Even the fellow at the right picture able to perform without any problem. The limitation of distal radial access, this is a new route which need a learning curve to have shorter puncture time. Another problem is the catheter difficult to engage ostial coronary for taller patients, because most catheters are designed for conventional puncture size. So this device could not be long enough when the puncture site is about 5 centimeters below the conventional site. The other limitation, the distal radial is a small caliber vessel. The small, this limit the size of sheath and catheter use. The study showed that the median distal radial diameter size slightly smaller than the proximal radial. This may affect success of high complex procedure when we need large catheter. But in selected patients, the use of 7 French sheath is feasible and safe. Let's go step by step the procedure in preparing and puncturing left distal radial artery. In regard arm preparation and positioning to puncture the left distal radial, the elbow has to be resting on comfortable surface, hand to be on the right side of imaginary line of pubis, so it mimics femoral approach, supine, wrist, and flex thumb, because before and during puncture, because it brings distal radial artery to the surface of the fossa. This short video will demonstrate giving anesthesia. Excuse me. You will see here. So this is giving anesthesia. We have to be generous in giving a xylocaine. We can give 3 to 5 cc, even 10 cc. And then afterward, just do a small massage. So the xylocaine goes deep into the tissue. This allows deep puncture and prevent pain when touching the periosteum. Regarding the puncture method, you can use ultrasonography guide puncture or finger guide puncture. We use a finger guide puncture. This brief video demonstrates how we do puncture and sheath insertions. So puncture, preferably using 21 gauge open needle at an angle 30 to 40 degree from lateral to medial direction. The needle is directed to the point of strong pulse, proximally in the anatomical snuff box. A true and true puncture using cannula sometimes can touch the periosteum of the scaphoid or trapezium bones, which can be painful. That's why in our center, we use the open needle catheter anterior puncture. After successful puncture, a flexible wire, as usual, is inserted. So make sure that it goes smoothly, and then afterward, followed by small skin incision. As the dorsal skin of the hand is thicker than the palmar set, some operators suggest making a deeper skin incision. And then after skin incision was done, insert the dilator first before inserting the whole assembly. The reason is to avoid injuring the small distal vessel by damaged sheaths. After inserting the dilator, introduce the whole assembly, dilator and the sheath. And after that, a spasmolytic cocktail consisting 200 microgram nitroglycerin and weight-based heparin is given. So the distal radial access has the potential to become the safest and most convenient access for coronary angiography and intervention due to its location at the hand, directly above the proximal bone. This is trapezium bone, sometimes scaphoid bone at the below, and this is the distal radial access. The bone provides support when hemostatic compression is performed. In contrast, the proximal radial artery lies more parallel. This is the radius bone, this is the radial artery. So that's why the distal radial artery hemostasis is potentially better than the proximal radial artery hemostasis. There are several methods to have patient hemostasis, to have patent hemostasis. This includes applying elastic bandage with gauze roll or other device. And nowadays, there is a dedicated hemostasis device for distal radial artery access available in the market, which provide effective and comfortable compressions. Hemostasis in distal radial access is usually achieved within 3 hours. This is one of our case which we perform PCI of calcified bifurcation lesion using rotational atherectomy and gel balloon strategy via left distal radial artery. He was a 79-year-old male with stable angina and angio, diffuse stenosis of LAD and bifurcation of LAD and diagonal. IFUs demonstrated calcified LAD lesion, so decision was made to do rotablation using 1.75 millimeter burr. And after a balloon dilatation, the 3.538 millimeter stent was deployed from distal left main to the mid LAD. And the diagonal was protected using 1.5 millimeter balloon using a gel balloon strategy. And followed by POT using 4.5 millimeter NC balloon. So as we see that IFUs confirmed the stent was well opposed and expansion, and the angiography demonstrate symmetry flow. This successful procedure was done using left distal radial using Severn sheet, which is a glide sheet from Terumo. Another alternative access is transulnar. Ulnar artery tends to larger, but deeper than the radial artery. That's why it's more difficult to cannulate ulnar artery. Ulnar artery runs closely to the ulnar nerve. To puncture ulnar artery, the wrist should be hyperextended. We can use ultrasound guide to assess, but sometimes you just using a finger guide. 21 G needle, bare needle, or cannula needle. You can use cannula needles as well to cannulate the transulnar access. And the angulation 60 to 80 and depth less than 1 centimeter. Puncture from the lateral side, close to the wrist. The more distal, the better, because the risk of post-procedural hematome is lower when puncturing from the when puncturing the ulnar artery near the wrist skin fold. So the take-home message is mastering variety access, increase the approach option for operator, and improve the comfort level for patient. Every access has its own benefit and limitation. Understand the basic principle of obtaining new access would accelerate learning curve. More data is required in randomized control trial fashion to fully evaluate the advantage of alternative access, especially distal radial access compared to the conventional radial and femoral access. Thank you very much.
Thank you, Dr. Fusi Yaya. for your talk about some alterations for the access from the hand. That is,
Yes.
I think it's maybe more and more practical for the interventionist.
Yes, yes, I think so.
Yeah.
Yeah.
Do you think that we need an ultrasound for the owner access?
I don't think so. But 3 days ago, I have to did a distal radial access using ultrasonography guided, because all the vessels are occluded. Both femoral occluded, and then the right radial already thrombosis by the the operator before. So they sent to me to do that case, and then the single alternative is using the the left radial, which is a left main to diffuse a LED. So the pulse is quite weak, so we are using the guide ultrasonography guided, but mostly we are using the finger guided. But it's better if your ultrasonography available in your cath lab.
Yeah, thank you. Any question from the chairman? Do you have any more discussion about this talk? Well, thank you very much. Now, I invite the next presentation, please.
Thank you very much.
All right, thank you. Perfect.
Welcome to the second Asian Sky Fellow Course 2020 in Vietnam. My name is Do Anh. I'm a interventional cardiologist at Hiện People Hospital in Ho Chi Minh City, Vietnam. Today we are going to discuss on the left femoral puncture. All we know now that radial access is the best choice for PCI, but the femoral access is still needed not only for PCI with complex cases or apparent anatomy, tortuosity, spasm of the radial artery, but also many procedures such as transcatheter valves and peripheral intervention. When compared with the radial artery, the femoral artery is a larger caliper, permitting the larger side catheters, and is that prone to spasm. Next slide. Now we discuss on the femoral artery anatomy with two important landmarks, the inguinal ligament and the femoral head. The first landmark is the inguinal ligament. The femoral artery is the continuation of external iliac artery and cross-developed at the level of the inguinal ligament. And then the common femoral artery passes through the femoral cyst and divided into two branches, the superficial and the profound femoral artery. The second point landmark is the femoral head. The target for the femoral puncture is the midpoint of the common femoral artery. The segment between the inferior epigastric artery and the femoral bifurcation. The segment is usually at the level of the center of the femoral head. Next slide. How to identify the landmark, the inguinal ligament. In clinical practice, the operators utilize imaging line between the two point landmarks, the anterior superior iliac spine and the pubic symphysis to identify the level of the inguinal. The femoral artery cross the inguinal ligament at its midpoint. So we will puncture approximately 2 to 3 centimeters below this point. So puncture above this point often results in high puncture, will increase the risk of the retroperitoneal bleeding. In clinical practice, some operators use inguinal crease as a landmark because they think that it's closely related to the inguinal ligament. However, it's not always the same. The distance between the inguinal ligament and the inguinal ligament is highly variable, and the femoral bifurcation is above the inguinal crease is more than the 75% of patients. So, though popular, the inguinal skin crease should be considered as an unreliable guide in a patient. there may be several skin fold. There may be several skin fold below and above the reason why the inner element. So make it impossible to locate the access site correctly. This often results in low punctures by the superficial femoral artery may be punctured instead of the common femoral artery. Hemostatic after low puncture may be inadequate because the artery cannot compress the femoral head, increase the risk of the femoral hematoma. And the femoral pulse is approximately 2 to 3 centimeters under the emission line. So with the tip of the middle and the index finger, we can feel the femoral arterial position. Next slide. Now the next is the fluoroscopic landmark to visualize the femoral head in clinical practice. After identifying the puncture point, we will check it by fluoroscopy. Fluoroscopy is quickly and easy to confirm the location of the puncture by placing a clamp on the needle to the lower part of the femoral head. We will move it until the ideal location and should take one frame to confirm. The ideal puncture is right in the middle and of the medial 1/3 and the lateral 2/3 of the femoral head. The next advantage of the landmark fluoroscopy is reliable and identify the ideal puncture site, but it will not identify the normal anatomic variant. So even though your shape is perfect in the middle of the femoral head, it also may go to the femoral bifurcation. Secondly, some cases with the femoral vein is overlying the artery, so the cannulation inside may be called the AV fistula. Thirdly, when we put on this landmark, if the patient is thin, it means that not a lot of subcutaneous tissue. We will get the right set, but if your patient with a lot of subcutaneous tissue like the observation, even when we start from the inferior border, it may already too high puncture. Next slide. The femoral artery puncture. We will do the local anesthesia with the light can, and if the skin with the black over the needle on the eye white, and then we will enlarge the intratract with the clamp or large diameter stiff to make the subcutaneous, or we make the subcutaneous tunnel, permitting the blood acid instead of accumulating in the tip. But keep in mind that this approach may not be necessary for the smaller size cyst, and we are careful when making the nick over the soft white so at the high profile to avoid cutting the white. And now, how to do the femoral artery puncture? Unlike the radial, often they use the true and true puncture technique. A single arterial wall anterior puncture is preferred for the femoral approach. This technique reduces bleeding risk from the backward puncture. The needle valve is facing up, and slowly toward the artery, enter the skin at the 30 to 45 degrees angle to cannulate at the artery 2 centimeters superior to the skin incision, and then position slightly more caudal or more cranial for your breast puncture. And note that your needle valve should be inserted through arterial wall, is the luminal artery. If your valve is not fully inserted through the arterial wall, but just enough to get flash of blood, if you don't recognize, your right insertion will go into subintimal state and lead to extension. Next slide. Now we discuss about the ultrasound guidance. Under direct ultrasound guidance can help us identify the artery and bifurcation. Arrange the needle insertion was through the visual plane into the entire wall of the common femoral artery. Adjust the direction of the puncture by fixing the angle of the needle. The advantage when we use the ultrasound is to avoid the cannulation at the bifurcation in artery with the hyperfurcation and use the chance of the AV fistula. But because it's that time to set up and perform, so it's rarely used in critical practice. Just in some special or difficult to access the artery. Micropuncture also offers both potential benefit because arteriotomy size is small and hematosis may be more easily achieved. Retrospective data does show any advantage with micropuncture access compared with the standard gauge needle puncture for PCI. And now, how to do the guide-wide insertion? First, to ensure the immediate spur of the multi-site blood flow before gentle insert your guide-wide without any resistance. After your guide-wide is positioned in the iliac artery, we will confirm the by fluoroscopy and change the cannulation needle or metallic needle. Your firm hand pressure apply over the puncture side with the last three finger to control bleeding. And the first finger pinching the guide wire to secure this wire, your seat is flat over the wire. Next slide. Now we discussed about the guide wire advancement. You can see the two kinds of set guide wire tip, the straight and sinker wire. And the guide wire insert always doing fluoroscopy to check the guide wire movement and smooth guide wire movement and directly to make it going to the iliac artery up into the aorta. What you see on clip A with the straight hyperophilic guide wire advance easily, but it may actually enter into the small branch and cause arterial perforation and retroperitoneal bleeding. Sometimes you feel difficult to advance the guide wire on clip B because your guide wire, because of your total threshold is what you see on clip B. But if you feel any resistance or wire kinking, do not push because your guide wire may be into subintimal or small branch. You should pull out and redirect the guide wire. Next slide. And now I introduce to all of you the simple technique to assess the low or high puncture. One is one artery is punctured and the guide wire inserted. Fluoroscopy without removing the puncture needle. The transition of the needle tip and the guide wire exists. Is also the size of the arterial asset related to the femoral head. Identify low or high puncture. This is cut nothing. It takes only a few seconds but contribute immensely to reduce the femoral complication rate. We are easily acquainted if we recognize low or high puncture. We are easily acquainted by repuncture at the appropriate level. We can see this on the image on the right. The arrow at the point of the guide wire right exists the puncture zone indicate the proper puncture side. But in the left it indicates that the high puncture side. Next slide, please. The next insert. The operator often sit the dilator with the rotatory motion reduce the forward friction while holding the guide wire straight and stable. We will see on photo P and C remove the dilator with the guide wire together and then aspirate and flush the seat through the side arm with the hyperneuralized slide to remove any from any air. And now femoral angiogram is the last step of the femoral puncture. The femoral angiogram is now a routine step performed for all the PCI procedures to identify the site of cannulation to assess any complication. After procedure, this step has to anticipate any problem when using the femoral location device. You should leave the guide wire in the arterial prior to the femoral angiogram to ensure that the system is not pouring into the blood when injecting blood to avoid the femoral puncture. You see on clip A, the cyst is actually in the common femoral artery, not in the small brain and without any local professional complication. Because your guide wire is removed before angiography. So the tip is just look like just your artery wall. Could be you can see the abdominal aortic dissection because by your guide instruction in patient with the severe peripheral artery disease. In general, do everything carefully, having an ideal femoral puncture site with a bony landmark and ultrasound fluoroscopy guidance. Repeat fluoroscopy every time when your guide go in, and then, very important, the final femoral angiogram, the essential step, first step in the femoral puncture. I hope that today, I hope that my presentation makes you gain more confidence to perform the perfect femoral puncture. Thank you very much for your attention. Thank you. Okay.
Thank you, Dr. Doan. Well, after the presentation, the idea of Dr. Nathan, that's why that's why the United States always keep the femoral artery as an important access. We see that we are less and less using the femoral artery access because it is now the preventive access for the Asian patients, or radial, ulnar, distal, proximal. But when we have failures with the hand access, we have to go back to femoral artery. And that's why we have to do it correctly, even though we are less and less using it. Something like we learn to drive a car. We have to learn how to drive a mechanic gear, then an automatic. Yeah, that's the very serious requirement for the catheterist. Now we come to the, you have any idea?
If I could just say one thing. You know, I agree with your comments. I think the challenge for trainees now is that as the United States starts to shift more and more to transradial, right now in NCDR, unpublished data would say that we're about 45 to 50% transradial for PCI in the United States. As we're shifting to transradial, fellows and trainees still have to get stay competent to do femoral, because when we're using femoral, it's for large bore, for TAVR, for TAVI, for mechanical circulatory support, for Impella, for ECMO. And if you can't, reliably get femoral access and avoid complications with 6 French, there's going to be real problems when you're using 12, 14, 16 French. Some of the newer devices that are on the horizon, the first generation is going to be 18 French. And so I think femoral access still becomes a very important skill set to retain.
Yeah, totally very important. Very, very basic access. You have to learn. Have you got any idea, any question? Now we can move to the last presentation of Dr. Sundaram, please.
Actually, I think it's my talk, and it was the recorded one. Thank you.
Pleasure to be with you. Many thanks to the organizers of the Vietnam. Hello, everyone. My name is Sandeep Nathan. It's a pleasure to be with you. Many thanks to the organizers of the Vietnam National Congress of Cardiology for this opportunity to present. My talk today will be tips, tricks, and pitfalls in primary PCI for STEMI via transradial approach. So what are the most important technical considerations in primary PCI? Well, there's timing. We want to know that we can get this done very quickly, and there's a number of factors that play into that. There's guide support to accomplish what we're trying to achieve. Catheter caliber, in as much as we need to know our device compatibilities and be able to change our device strategy as need be. And then finally, bleeding, both access and non-access site bleeding. There are quite a few publications outlining the benefits of transradial. This is a very recent updated meta-analysis of STEMI interventions, transradial versus transfemoral, showing that transradial approach in STEMI in primary PCI is associated with about a 29% reduction in all-cause mortality, 41% reduction in major bleeding, and about 58% reduction in major vascular complications. So certainly there's some great advantages. And this is ideally what it looks like, transradial primary PCI for anterior STEMI. You can see that this young man is having a very large anterior STEMI. The entire LAD is out. And once it's wired, you can see extensive clot burden requiring rheolytic thrombectomy with angiojet spiroflex, followed by anchor wire technique in order to advance balloons and stents, along with deep guide intubation. Periodically, we had to intubate all the way down to the bifurcation of the left main, and then a little bit further beyond at times to get stents into the LAD. And finally, we achieve a very good result. Some operators will question, though, what the timeline of a typical transradial primary PCI case looks like, and are we spending more time doing this from a radial approach than a femoral approach? The last time this question came up, I decided that we would answer this by writing down in real time when we did everything during the case. So what you see here is the actual drape from the case from a different STEMI, starting with lidocaine injection at the wrist at 7:16 p.m. and then conclusion at 7:47 p.m. And some of the key numbers are shown here. It only took us 18 minutes from lidocaine administration to the first balloon inflation. 31 minutes from start to finish, the entire case is done. So this can be done relatively quickly, but there are some important considerations. One big consideration is patient positioning and optimal setup. There may be some small door-to-balloon delays and a slightly long procedure time in the literature associated with the transradial approach, and it becomes critical that the patient preparation and the positioning preferences are communicated to your team. Bilateral femoral prep. Ideally, if you can get this done from the right radial approach, that makes it easier. What about distal radial or snuff box access for STEMI? Certainly the ergonomics and the positioning of the hand is more favorable, but you have to be able to get snuff box access relatively quickly. We use ultrasound for a lot of these cases to facilitate very rapid entry with a slender type sheath. This is a glide sheet slender by Terumo. This is an ideal sheet Prelude by Merit. Other positioning considerations in patients who are receiving chest compressions with an automated device like Lucas, it may be difficult, if not impossible, to actually perform this from a radial approach. And so that's a consideration as well. So I have 5 tips to share with you today. Tip number 1 is imaging-guided persistence usually pays off when it comes to transradial access and catheter manipulation. This is an important paper that was published a number of years ago, defining the different mechanisms of transradial catheterization failure in about 5% of cases out of 2,100 cases studied here. Radial access, radial anatomy, brachial spasm, challenges in subclavian artery loops and angulation, and catheter seating all contribute to this. If you find a radial loop and you find that the wire or catheter passage is difficult, these can very often be straightened out. And even if they can't be straightened out, as in this case, the entire procedure can be performed with a partially tethered radial loop. So it's not a real big deal. Imaging guidance helps a lot. This is a 66-year-old morbidly obese woman who's having an acute myocardial infarction. She's got significant radial tortuosity, 2 consecutive radial loops here, all of which was straightened out relatively quickly using a glide wire as well as a 4 French glide catheter. These untethered loops straighten right out and the catheter is advanced. And once we've advanced past it, you can see that the wire has straightened out completely, and we've got a pretty reasonable vessel proximal to it in the axillary artery. Tip number 2 is that vascular ultrasound can be very, very useful for getting radial access. Real-time ultrasound guidance for needle advancement allows identification of the vessel course, diseased and calcific segments, and it decreases the time and number of unsuccessful attempts. So where does ultrasound access help? Puncturing the impalpable radial artery. Many times, patients who are presenting with a STEMI have relatively lower blood pressures because they've been administered nitroglycerin, beta blockers, sedation, analgesics, opioids, and so forth. And so this is a gentleman who clearly has a radial artery, but we just can't feel it, and ultrasound gains allows us to gain access pretty quickly. Another scenario is cannulating the occluded radial artery. This is a woman who has an occluded radial artery from prior attempts. You can see it's non-pulsatile until we actually get midway up the arm. She does have a large ulnar artery that you see over here, but we wanted to get radial access at this location. And when we finally got it, you can see through the sheath shot that we're actually midway up the forearm. The wrist is all the way down here. The radial artery is occluded, but we're still able to complete the case without any difficulty at all. A third scenario is when you have to puncture the truly pulseless radial artery. This is a patient with STEMI and ventricular fibrillation who's supported on bedside VA ECMO. So bedside VA ECMO was placed because we couldn't get him out of VFib. And he comes to the cath lab with no pulse. Using ultrasound, we're able to get radial access and straighten out the tortuosity and get the case done from a radial approach. And believe it or not, this gentleman actually survived and went home. Tip number 3 is choose more guide support than you think is needed and become familiar with adjunctive equipment and guide engagement strategies. There's a lot of different ways to deeply intubate the guide and gain additional support. As mentioned, you could use deep intubation, you could use buddy wires, anchor balloons, and so forth. Guide extension using a guide liner, Guidezilla, or a telescope catheter are some of my favorite approaches when you don't have enough guide support to deliver the devices that you want to. If you don't have this available, guide extensions function very similar to mother and child technique, and so you can use catheters that you have on your shelf for mother and child guide technique. So here's a case of 58-year-old gentleman with ongoing chest pain and inferior ST elevations. He presented to another cath lab where they couldn't cross, believe it or not, the proximal portion of the RCA with any balloons or stents. And I looked at this and I said, well, we should be able to do this to get down to the culprit vessel, but there is quite a bit of fibrocalcific disease here. We went with 6'7" slender, a 7 French AR2 guide, and we could not get anything to cross here other than a microcatheter. So we did orbital atherectomy with CSI of the proximal RCA from a right radial approach. And then we inflated a balloon here and we advanced a guide liner, guide extension catheter, through there. And you could see that the tip of the guide liner is through here. We've deeply intubated the vessel with a 7 French AR2. And then we're able to complete the STEMI intervention after that with a very satisfactory technical result. Tip number 4 is know guide equipment compatibilities and be prepared for the unexpected. And that usually signals changes in equipment needs. So here is a slide that outlines all of the things that you can do through 5 French, 6 French, 7 French, and 8 French guide access. Fortunately, 6 French guides allow for most complex procedures and techniques. Certainly ones that you would encounter during a STEMI intervention are included here under 6 French, including all coronary balloons, all coronary stents, and a variety of atherectomy tools, aspiration catheters, and so forth. If you want both a larger inner diameter as well as more strength or backup support, you can use an Asahi OCath sheathless guide system. We rarely use this in primary PCI, but it is a useful tool to have if you have access to it. And so here's a case of an infraposterior STEMI that became a whole lot more than just a simple primary PCI. This is a 56-year-old gentleman with 3 to 4 hours of chest pain, diffuse anterolateral ST depressions, and inferior ST elevations. There's a chronically occluded RCA that's collateralized from the LAD and the circumflex. And what we encountered was a heavily calcified Medina 111 left main bifurcation and a thrombotic culprit lesion in the mid-circumflex at the OM bifurcation. Unfortunately, these vessels are also supplying some of the collaterals to the chronically occluded RCA. We got to work. We went with a 6 French right radial approach, 6 French EBU 3.75 guide, double wire the LAD and the circumflex, start working on the circumflex with a PTCA of the obtuse marginal, as you can see here. And things were going fine, but then he started having runs of ventricular tachycardia with the balloon inflation, because now we're jeopardizing the collaterals to the RCA as well. And so a balloon pump is placed and a stent is quickly deployed in the circumflex, at which point he has pulmonary edema. He requires intubation and mechanical ventilation. You can see that he's uncomfortable and moving around. And then we encounter a different problem. The left main starts to thrombose. And the decision was made to stent the left main into the circumflex and then salvage the LAD, at which point there was plaque and thrombus shifted into the LAD, and the patient becomes quite unstable and then sustains cardiac arrest. We quickly put him on ECMO in the lab. We regain spontaneous circulation, but he is in shock. Supported with ECMO and balloon pump, we proceed with the left main intervention. And here's where 7 French access would have been ideal, but we can still fortunately accomplish this. Even with a heavily calcified left main bifurcation, we can still accomplish this from radial 6 French approach. And so we essentially did culotte stenting of the left main in this acutely decompensated patient. We deployed, as you remember, from the left main into the circumflex, fenestrated that, and then put the left main into LAD stent in, inflated that, lost our circ wire, rewired the circumflex, and finished with a final kissing balloon inflation in the left main with a very technically satisfactory result, all accomplished from the right radial approach, of course supported with mechanical circulatory support that was weaned and decannulated a few days later. Tip number 5, the final tip that I would share with you, is know when to accept crossover. Access crossover scenarios can happen in transradial primary PCI, particularly when time is of the essence and patients are ischemic. It is important to recognize that there are some stumbling blocks and know when to cross over. So one scenario is the chronically occluded brachial or axillary artery, and I'll share with you 2 different cases here. One is a prior Sohn's technique cut down that healed as a complete occlusion of the brachial going into the axillary artery, as you can see here. Very well collateralized. We had accessed the radial artery using ultrasound because it was pulseless, but we encountered this, and because time is of the essence and the patient is infarcting, we decided to cross over to the contralateral radial approach. This is a gentleman with prior biceps tendon repair after a traumatic incident, a motor vehicle accident that required surgical intervention here. Unfortunately, the radial artery healed with an occlusion and collateralization. Here again, we crossed over to the contralateral radial. And here's a tethered and severely angulated radial artery that I encountered just recently in a patient with ischemia and ongoing chest pain. We attempted first to cross with a woolly wire, then a soft glide wire with a tapered glide cath, then a whisper wire through a Corsair Pro through a glide cath, and then finally what you see here is balloon-assisted tracking, which didn't really go anywhere, despite the fact that we manipulated the entire course of the vessel medially using surface compression, basically using our fingers to reshape that vessel. We still could not traverse this area. And the reason is that you've got recurrent vessels along with connective tissue that's tethering this S-shaped or Z-shaped vessel in a very, very sharp angle. So best not to fight this if the patient is acutely ischemic, and it is important to recognize when to cross over. So the key takeaway points then are the available data suggests that transradial approach is superior to transfemoral, especially in STEMI patients undergoing primary PCI with significant decreases in bleeding, vascular complications, and possibly all-cause mortality. The 5 tips for greater success with transradial primary PCI I shared with you is immediately take a digital subtraction image of the radial ulnar anatomy. If you encounter any difficulty with wire or catheter passage, have ultrasound available and use ultrasound liberally if possible. Select a supportive guide and have a backup plan for increasing that support if you have difficulty delivering devices. Be prepared for a mid-case shift in strategy and be aware of the equipment needs. And then finally, have some predetermined crossover time points and scenarios to help guide the case in the interest of patient safety. Thank you so much for your attention.
Thank you, Dr. Nathan. So now we have only 5 minutes left before the next section. Do you have any question or comment, Sindara?
That was
I've gone all the way down to the bifurcation of the RCA to deliver things into the PDA, and it's actually, so long as you are methodical about it, I think it's safe. The one thing that we tell our fellows is what I
I'll be as long as am I able to share my screen? Do I have?
Yeah. We have
okay.
The host permission.
Then that's what I'll do.
So,
you want to try it out for him, or you okay?
Good morning. And why do we have the background, the loud noise at the background? From where?
So, I think the host has the live session playing, perhaps on YouTube or on a different computer. So I think that's Sandeep Nathan speaking, giving his talk.
Yeah. I'm very sorry about that. Yeah, I will.
It's all right.
I will mute myself.
It is a good talk.
You will hear each other clearly.
Okay, good. That's better now.
Okay.
Okay, we have a minute to go roughly.
Yeah.
Yes.
Yeah.
It gives us great pleasure to welcome you to the coronary physiology session. I am Gautam Kumar from Emory University in Atlanta. Rajnikant.
I'm from Brunei. I'm a cardiologist here in Brunei, Dar es Salaam. Thanks.
Perfect. We'd like to introduce our panelists and speakers, Dr. Thatchman, who is very well known to you. And he's going to first start off the first talk by kicking off with some very important basic concepts, which are based on how to choose the best angiographic views to evaluate the native coronary lesion. Dr. Nguyen.
I believe that I have the recorded video. This is what I understand.
There we go.
I don't hear anything.
Good morning. I am Dr. Thách. I'm from Indiana, and it's an honor for me to talk at the ASEAN Sky Fellow course organized at the Vietnam National Congress of Cardiology. I would like to thank the organizers of SKY and of the Vietnam Heart Association. My topic today is about how to choose the best angio view to evaluate the native coronary lesion. In this first slide, I like to speak in Vietnamese. Trong cái hình này đó, ở cái view REO codal view thì mình không thấy có left main disease. Nhưng nếu mình nói bệnh nhân hít sâu xuống, lúc bây giờ mình sẽ thấy cái distal left main disease. Qua cái hình số 2, trong cái hình này là cranial view, thì cái distal left main và proximal LAD cũng không thấy rõ, là vì trong cái view này thì distal left main và proximal LAD bị co ngắn lại. Như vậy thì cái view này best cho loại lesion nào? Cái cranial view là best cho proximal LAD and bifurcation between the LAD and the first diagonal. Thế thì bây giờ nếu mình bảo rằng là mình không thấy được cái hình cái bệnh của left main và ostial LAD thì như vậy cái hình nào mình sẽ lấy cái góc nào trong cái hình tới? Rất một nguyên tắc rất là bình thường, nếu một cái hình mình không thấy rõ thì cái hình tiếp theo nó sẽ là 90 độ thẳng góc với cái hình bữa trước. Như vậy là trong cái hình này đó, tiếp theo là areocodal view. The distal left main and proximal LAD có thể nhìn thấy rõ hơn. Trong trường hợp thứ ba này đó là areocodal view và cái proximal circumflex là nhìn không được rõ. Lý do là tại sao? Lý do là tại vì cái circumflex nó bị foreshort. Thì như vậy mình nói bệnh nhân hít sâu xuống để cho cái left circumflex nó kéo dài ra và mình có thể thấy rõ hơn. Có trường hợp thứ tư, ví dụ mình đang làm một cái angioplasty ở right coronary artery, mình thấy là cái gai nó không có vững. Khi đưa các cái equipment vào, nó cứ bị đẩy ra ngoài. Thế là tại sao? Tại vì có thể là cái gai nó không coaxial with the proximal segment of the right coronary artery. Trong hình A này đó, trong cái aerial view, thì mình thấy là cái gai nó nhìn thẳng vào mặt mình. Vì mình thấy là cái ostium của cái gai nó là hình nó là end-on với mình. Trong khi đó cái gai này đó, cái hình B đó, thì cái gai với lại cái RCA nó làm ra một cái góc mà nó không phải là end-on. Thì như vậy là có thể là trong cái view, LDO view, nó nhìn là nó có thể là nó là coaxial, nhưng mà thực sự nó không có. Điều đó làm đến khi mình làm angioplasty thì khi mình đưa các cái dụng cụ vào nó hơi khó một chút và cái gai nó không có stable. Có trường hợp thứ 5, đây là trường hợp này là một cái false magnification của circumflex hay là obtuse marginal. Thường khi làm angioplasty đó, khi mà đặt stent đó, thì là cái hình của, phải để ý ở cái hình của cái size của cái obtuse marginal hay là distal left circumflex. Lý do là khi trong cái hình chụp này đó thì là cái artery nó nằm ở phía sau mà cái gai nằm ở phía trước. Như vậy đó thì khi mà cái hình nó được phóng đại lên trên cái màn hình đó, thì lúc bây giờ là cái gai nó nằm gần cái màn hình, trông nó nhỏ hơn, nó sắc sảo hơn. Trong khi cái left circumflex obtuse marginal thì nó lại là được phóng đại. Điều này rất là quan trọng là tại vì khi mình làm như vậy đó, có thể nếu mình lựa cái size của cái stent nó không có đúng đó, mình có thể cause perforation. Trường hợp này xảy ra hai chỗ, đó là left circumflex obtuse marginal hay là RCA, distal RCA. Đi qua cái case số 6 này đó, thì đây là một cái right coronary artery trong trường hợp STEMI. Thì bây giờ câu hỏi là nếu mà cái trường hợp như vậy khi mình chụp hình thì biết đâu là cái chỗ nào lumen để mình guide cái Y nó về hướng đó. Trong cái trường hợp này lúc nào mà hết ở the curve segment of an artery, the plaque is formed at the inner curve. Và như vậy là cái lumen nằm ở phía ngoài, đó là outer curve. Điều đó để cho mình biết, để mà mình đẩy cái gai nó về hướng đó. Thì bây giờ đó, khi mà làm angiography đó, thì sau khi mà làm tim một hồi không có gọi là select cái right coronary artery được, thế thì nó có thể nằm ở đâu? Thường nếu mà nó cái right coronary artery mình đi từ cái sinus phía bên kia đó, thì nó thường nó next to the left main, anterior and superior to the ostium of the left main. Thì thường khi mà như vậy nó đi từ cái bên kia qua thì nó có thể nó bị cái artery, cái branch, cái segment chỗ đó nó có thể bị ép vào during systole. Làm sao mình biết được? Dĩ nhiên có những cách bằng angiography, nhưng mà có một cách mới nhất mà tôi áp dụng đó, khi mình thấy rằng là khi mà cái đường đi của cái động mạch nó đi từ phía bên kia qua, khi mình chụp hình đó, khi mình inject contrast rồi đó, thì mình để ý ở cái ostium, mình thấy là cái contrast nó bị bật ngược lại, nó bị flush ngược lại vô trong cái coronary sinus. Trong hình này mình thấy ở trên cái arrow màu trắng đó. Tiếp theo đó là mình thấy rằng là cái chuyện reverse flow này nó xảy ra ở những cái chỗ, những cái bệnh như là stenosis, coronary anomalies, thì mình mới coi cái hình trước, hay là trong cái case của hypertensive crisis. Điều này giải thích tại sao những cái bệnh nhân trên aortic stenosis, coronary anomalies, hypertensive crisis or hypertension, họ có thể có chest pain, mà khi làm coronary angiogram thì không thấy có bị một cái lesion nào. Lý do là vì khi mà dòng máu chạy ngược lại thì không đem máu tới cho cái myocardium, or they cause a chest pain even everything is patent. Rồi bắt đầu đến bây giờ thì tôi đã nói tới những cái cách nhìn, những cái angiographic view, nhưng mà thực sự là những cái chuyện rất là cơ bản ở trong interventional cardiology. Thì bây giờ có cái gì mới nữa trong thế kỷ thứ 21 này và năm 2020 mình làm một angiographer trẻ thì có điều gì mới để mà làm? Thì câu hỏi trong đây là một cái right coronary artery và cái lesion nằm ở giữa. Thì câu hỏi tôi là tại sao cái lesion nằm ở giữa mà không nằm ở khúc gần hay nằm ở khúc xa? Tại sao nằm ở giữa? Thì trong cái research mới nhất của tôi là nhìn trong cái flow diagram để giải thích được. Là cái hình đầu tiên hết là mà chụp hình thì là bơm thuốc nó đầy hết cái động mạch xong nó ngưng lại. Bây giờ mình sẽ thấy máu nó đi vào trong cái động mạch và máu nó màu trắng, trong khi nó contrast là màu đen. Ở đây mình thấy nhìn cái tên trắng. Thì cái dòng máu nó sẽ tiếp tục, mình thấy nó đang vô chỗ proximal segment, nhìn trên arrow. Ở đây là cái hình này là những cái hình liên tục 15 hình trong một second, như là 0.06 second một hình. Và mình thấy là hai hình, như là 0.12 second. Mình thấy hai hình cái hình số 3 này. Hình số 3 là nó trong diastole nó đã chạy tới khung giữa rồi. Đây là thường là trong cái khi mà cái flow dynamic là diastole tổng trương đó, máu đi vào thường là 4 hình, tất nhiên là 0.24 second là diastole. Thì thường là nó tới được cái địa điểm mà khúc giữa, và tới đây thì là nó ngừng lại, là vì bắt đầu tới systole. Và khi systole thì đây là mình thấy hình tiếp theo vẫn ngừng này. Tiếp theo nữa vẫn ngừng. Lý do là tại vì cái during systole thì cái contraction của cái myocardium làm cho cái dòng máu đi ngược lại. Và khi nó đi ngược lại như vậy và nó chạm một cái dòng máu đi xuống và một cái dòng máu đi ngược lại, hai cái chỗ đụng nhau gây ra hỗn loạn, và cái chỗ đó là tôi gọi là stop line, và cái chỗ đó là tạo ra những cái lesion nằm ở đó. Lý do là tại vì khi mà nó bị một cái collision như vậy đó, thì những cái bong bóng mà đi theo cái dòng máu đó nó bị vỡ ra, gọi là cavitation phenomenon. Chuyện này rất là thông thường trong cái vấn đề mà gọi là hydraulic ở nhà hay là trong cơ xưởng, các cái ống nước hay là các ống dẫn dầu hay là các ống dẫn khí này kia, nó rất dễ bị bể, bị hư là do cái cavitation phenomenon. Và tôi dùng cái nguyên tắc đó để áp dụng trong coronary arteries, thì mình thấy rằng là cái vị trí mà hai cái dòng máu nó đụng nhau tạo ra cái lesion, đó là nằm ở phía giữa, và chỗ đó là thấy ra các lesion nhiều nhất. Thế thì bây giờ mình biết là một cái khám phá mới đó là những cái lesion happens ở cái chỗ mà cái stop line where có cái collision của cái dòng máu đi xuống và cái dòng máu đi ngược lại. Thế thì bây giờ mình làm angioplasty thì mình thấy cái gì? Thì khi mình làm angioplasty thì đây là bệnh nhân này là đặt stent rồi đó. Thì khi làm angioplasty, cái đặc điểm của cái đặt stent rồi đó là bây giờ mình thấy là dòng máu cũng đi rất là mau hơn nữa, và không có cái stop lại, và không có cái reversible flow. Đó là đặc điểm sau khi mình làm stent. Là một cái khám phá mới là khi mà đó là cái giải thích cái benefit của đặt stent trong bệnh nhân có coronary artery disease. Thì bây giờ tôi tóm lại trong cái phần hôm nay. Điểm thứ nhất đó là khi mà chụp hình muốn tìm cái lesion ở left main mà không bị short, phải nói bệnh nhân có deep inspiration. Điểm thứ hai là nếu một cái hình mà mình thấy không có rõ thì cái hình tiếp theo là lấy cái hình 90 độ thẳng góc với cái hình trước. Điểm thứ ba là trong cái obtuse marginal hay distal right coronary artery, về để ý có cái vấn đề phóng đại của cái hình do cái cách chụp. Thứ tư là trong một cái trường hợp bị STEMI thì nếu là ở bên right coronary artery, cái lesion thường lumen thường nằm ở cái outer curve of the lesion. Mình biết cái đó để mình guide cái wire về hướng đó. Nếu không mình cứ guide cái wire vào trong cái chỗ mà cái inner curve, có thể mình đi dưới, đi sau. We can go below a plaque và cause dissection. Điểm thứ năm là khi mà cái right coronary artery thường nếu mà nó từ ở bên cái left coronary sinus thì thường nó gần cái left main, anterior and superior to the ostium on the left main. Thứ sáu, một cách để biết rằng là có khi mà nó đi từ bên cái sinus bên kia đi qua, nó có bị chèn ép giữa aorta and pulmonary arteries, thì khi mình chụp hình thì mình coi rằng là cái bệnh nhân này đó, cái flow đó nó có bị chảy ngược lại hay không. Và cái số 7 đó là nói rằng là tôi giải thích tại sao rằng là có lesion ở mid coronary artery, là do là cái chỗ đó là cái chỗ collision mà gây ra hỗn loạn và chấn thương ở cái vùng đó và tạo ra cái lesion. Và sau đó khi mình đặt stent thì rất là đặc biệt là cái stop lại cái chỗ mà collision nó di chuyển đi xa hơn xuống phía dưới và không còn reverse flow nữa. Đó là tất cả những cái gì tôi tóm tắt lại trong buổi nói chuyện hôm nay. Thank you very much. Thank you very much. Tôi có đặt cái email ở đây để xem các bác sĩ nào muốn làm research về hydraulic, về các đề tài tôi nói bữa trước, đó là aortic stenosis, coronary anomaly, hypertensive crisis, stop line as a frequent location for lesions, và nhất là what happened to the flow after PCI. Thank you very much.
Thank you, Dr. Nguyen. That's a masterful talk. I didn't get some of these words, but the pictures were very interesting, and I can see the relevance to the fellows. Can I ask you a controversial question? So we have interventionists doing angiograms, and in many hospitals, there are non-interventionists doing angiograms. Do you think there is a difference in the quality of angiograms done by interventionists or non-interventionists? I would like Dr. Nguyen's view and then open up to the panel as well, put you all in the spot.
Sure, for us as interventional cardiologists, when we take the picture, we look at the lesion, and then we look at how to get the equipment across, how to put the wire, what's the access, and how the area of landing, and that one is very important, not just a picture, you see. So to say that are interventional cardiologists better in doing coronary angiogram? I say yes.
Great.
This is my
Fahim,
bias.
can I ask you, Fahim, can I ask you, would you like your heart failure colleagues or your non-invasive cardiology colleagues to be doing angiograms one session a week?
So I'll give you the politically incorrect version. So in our lab, all angiograms are done by the interventional team. And I understand the need for non-interventional cardiologists to want to participate in the procedures. And there is some value to that for the patient when they see their, let's say, their general cardiologist involved in the procedure. But I do think that for a couple of reasons, the diagnostics should be done by the interventional group. One is, of course, that you, as Dr. Nguyen very eloquently pointed out, you get better views that are geared towards the potential intervention that might happen. The other issue is that if there are sort of intermediate lesions and they need physiological assessment, the interventionist can take it on right there and then, rather than have to be called in for it. And then the third, which is just as important, is angiogram is now a very, very safe procedure, but it is not 100% foolproof. And if you have complications, then an interventionalist would be able to take care of it versus having called, at which time the patient may actually do very poorly. So for those reasons, I think that it is a reasonable thing to separate out. Just like there's a reasonable argument to have the imaging, like echoes and those kind of things read by dedicated people rather than interventionalists, even though we can read echoes. And so, that's where the sort of balance has to be struck.
Very fair points, and I agree completely. Dr. Corbin, do you have a different view? Do you agree with this?
No, I completely agree with Dr. Jafari and Dr. Tang. So we also have non-interventionists doing diagnostic angiograms at Mayo. And all 3 points that are brought up by Dr. Jafari.
Can I ask you another question then? You must be training a lot of fellows at your center. Now, over decades, training's changed. There may be these days. Do you think there's a certain number of diagnostic angiograms a fellow should perform and study before attempting even the first intervention or being trained in intervention? What do you think that number is?
Yeah. Do you want me to take it or Gautam?
Dr. Corbin, if you like your views, and we can ask Gautam to pitch in later.
Sure. So the way the system is structured in the US is you have a level 1 fellow as a general cardiology expected to perform a certain number of angiograms. And then the fellows who are destined or thinking of becoming interventional cardiologists, they go along to a level 2 training where you are expected to do another set of number of diagnostic angiograms. And this will prepare the fellow to become an interventional cardiology fellow by their 4th year of training. So yes, there is a set number that is expected to be done of diagnostic angios.
All right. And Gautam, how do you find your trainees these days? Do you think they are really knowledgeable about coronary angiograms when you first start training them in PCI?
So, Rajnikant, I'd like to go back to our very
very first question again.
Yep.
This is like Stephen Covey's 7 Habits of Successful People. You know, if you have an interventionalist doing an angiogram, you begin with the end in mind. Whereas that is not necessarily the case if you have a diagnostician doing the angiogram. Now, going back to your next question about the fellows, I think the important issue there is going to be, yes, there is a certain number that they need to achieve competence. I would actually state that that number is probably at around between 600 to 800 angiograms. When you have done that number, there is a reasonable amount of competence. It doesn't happen at 100, 200, or 300 angiograms. You're barely even getting access. I think when you get to like 600, 700, 800, there is a reasonable amount of competence to at least be able to get the normals in place. And then beyond that, graphs, collaterals, anomalies, and really you get really comfortable when you get to that 900 to 1,000 mark. Thank you.
Great points. Thanks, everyone. Dr. Nguyen, thank you for a wonderful talk. I think we'll move on to the next talk, which is again by my co-moderator here, Dr. Gautam Kumar, who's a cardiologist at Atlanta Emory University. He does very complex PE interventions. I learned a lot from him. And he's also an authority on intracoronary physiology. It's my pleasure to invite him to give a talk on best techniques for FFR measurement in the cath lab. Gautam, it's yours. This is for a pre-recorded talk, so can we have it running, please? Can we have the audio, please? I think the host must be working on it. Just give them a few seconds.
I think I download the wrong versions of the presentation, so would you want to discuss for a while so that we can fix the problem?
Technical problems, so they have to ask us to have a discussion, and then so they can work on the technical problem to solve the technical problem. Now,
Thank you very much.
There is a question you mentioned before. That means you talk about how about an invasive cardiologist doing coronary angiogram for heart failure. This is you mentioned about that. So it's a very interesting this topic, because when I do angiogram for heart failure, I discover that the arterial phase is much longer, 3 times longer than the usual one. If we have only a person just to do the picture and to measure the pressure, it's okay. I remember that in Boston, at Deaconess Hospital, it is a physician assistant to do the angiogram, not cardiologists. You see, so but if, let's say when I remember I did an angiogram for a patient where he had 3 angio already, and all the times the result was borderline lesion. And when I did the case, it showed that the patient had the right coronary on the left sinus. And nobody paid attention about that. Nobody discovered it. And the chest pain came from the compression of the right coronary artery between the aorta and the pulmonary artery. So when we do the picture, when we do the angio, there are many things in there, not just picture and measure, but we have to understand too. So this is why, like I mentioned about the heart failure, I'm sure that Gautam or Michael or Fahim, when you go back to your room or your lab, and you do the angiogram for dilated cardiomyopathy and patent coronary artery, the arterial phase is very long. And this is the cause of the patient with ischemia and dilated cardiomyopathy and patent coronary artery. Now, this is my discussion.
It's a great point. I think either, and it also like brings MPTs into importance. When you do an angiogram, it's always nice to have a weekly angio review meeting where you have the invasive and the heart failure doctors discussing it. That might bring up, if things have been missed, you can bring it up. Great point. I think we have to go live with Dr. Gautam Kumar's presentation because the problem with the pre-recording. Is that okay, Gautam? Can you go live and present your talk? Or
I am trying to make it work.
Share green.
Share screen and pick your PowerPoint.
Yeah, it won't. For some reason, it is not. Oh, wait, maybe now it will.
There you go.
Okay, perfect. Perfect. Are you all able to see this?
Yeah, just go to presentation mode. There you go.
Beautiful. Beautiful. Excellent. Okay, my name is Gautam Kumar. I'm going to be talking about best techniques for FFR measurement. We are going to have a little bit of overlap between my talk and Mishal's talk. So please forgive us for it, Mishal. In terms of disclosures pertaining to this matter, I have no real disclosures. So we are going to talk about the definition of FFR, some of the characteristics of FFR. How do you actually measure FFR? A little bit about the pitfalls in FFR and troubleshooting FFR. And Mishal will go into some of these things in more detail as well. So FFR is basically defined as the ratio of, or the percentage of normal flow in the stenotic artery to the flow in the same artery in the theoretic absence of the stenosis. So if you look at this flow pressure curve, the FFR is actually defined as a point of the ratio between A and C, or A prime divided by C prime. And if you think about that, that particular ratio doesn't really vary a whole lot with hemodynamic situation. So FFR is basically distal coronary pressure divided by aortic pressure under the condition of hyperemia. So normal value of FFR is defined as 1 in every patient and vessel. There is a well-defined ischemic threshold, which is 0.8 in FAME2. It is specific for the epicardial vessel. It accounts for collateral flow. It is independent of hemodynamic changes by and large. It is quite reproducible. It has been validated in non-invasively, and there is good outcome data available, as we all know. In terms of invasive functional indices, now we all know that there are many of these. There are hyperemic indices, and the FFR is the hallmark of those hyperemic indices. Now you also have partial hyperemic indices with contrast PDPA filling that gap. You have resting indices with the full cycle PDPA, which is available in all systems. And you have IFR, RFR, DFR, DPR, and these are all available in different proprietary systems. But here's the good news. FFR in itself is available in every system. So how do you measure FFR? Very simple. First thing you do is you zero everything. When you zero the pressure transducer, you're telling the system, oh, look, this is atmospheric pressure. The next thing you do is you equalize or normalize. What you're doing by that is you're basically telling the pressure wire system that this is aortic pressure. You then advance the wire past the lesion. Usually about 20 millimeters past the lesion would be more than adequate. You don't need to hub it all the way down the distal vessel unless you're trying to do a pullback and assess for distal disease. Then you induce hyperemia, usually with intravenous adenosine. Intracoronary adenosine is also a good option. There are several other options that we can discuss. And then you perform a pullback. The pullback will tell you two things. Number one, if you're far off down the vessel or if there are tandem lesions, it will tell you whether there is a step up. And number two, it can also tell you whether there was drift. So there are a couple of pitfalls in FFR that are coming up. If you think about it, there are pitfalls that happen in calibration, in terms of normalization and equalization. In terms of the measurement, there can be issues with guide catheters, there can be wedging, side hole issues, capillary forces, spasm, and then the pressure wire also causes its own set of issues such as drift, whip artifacts. You can see these spikes in the pressure wire tracing, kinking of the vessel due to the pressure wire, and spasm. There can also be issues with hyperemia. The classic thing that I always like to quote is, you say, okay, start IV adenosine, and then you wait and nothing happens. You ask the patient, you feel short of breath? No, I feel perfect. And then you see and you turn around and look down and you see the IV has been disconnected and the adenosine is running into the floor. And here's another classic one. The IV is running beautifully, or so you think, and the blood pressure cuff goes up at the correct moment. So those are all things to take note of. And finally, errors of interpretation. It's important that the cursor is placed at the correct place when FFR is being interpreted. So I have a couple of questions here, and we can discuss these either as a panel, or you guys can feel free to look and see what the answer is and take a mental note of it, and we can discuss it. So a 70% mid-LAD lesion is crossed, and FFR and pullback are performed. So you are doing pullback from distal to proximal, and the following tracing is obtained. So based on this, you would A, repeat FFR with IC adenosine, repeat equalization of the pressure wire, move the cursor to the correct FFR location, or disengage guide catheter before measurement. So I'm going to give you all about 20 seconds to kind of think through it. And I can have my panelists heckle us if they want.
Any of the panel like to talk about this trace?
Oops. I think it moved by itself.
Oh, thank you. It saved us all. I was wondering. I didn't have anything to say there.
Saved by the bell. That was a trick question. Basically, the cursor has been moved to 1, and basically the FFR is 0.75, for which the answer is here. I don't know if you can see my pointer, but you just have to move it. So the questions you ask yourself is, can FFR ever be actually wrong? Yes, it can be. It can be what you think is falsely high or what you think is falsely low. Now, the scenarios in which it is falsely high, well, let's look at this example. A 70% ostial RCA lesion is wired and IV adenosine is administered, and the following tracing is obtained. Based on this, you will defer PCI as FFR is greater than 0.8, disengage guide catheter and repeat FFR, repeat with IC adenosine hyperemia, or repeat FFR with a new pressure wire. And panelists, go.
Ventricular, as you need to disengage.
Yep. So you don't have the dicrotic notch in the aortic tracing, and you have ventricularized aortic tracing. So that's classic wedged guide catheter.
Absolutely. Michelle is right. So that is a wedged tracing. And basically, you can see that the tracing looks very ventricularized. So you need to disengage the guide catheter and repeat FFR. That is correct. And that may be, unfortunately, a scenario where IV adenosine may work better than IC adenosine as well, because you may not be able to engage with the guide catheter, administer adenosine, and then withdraw the guide catheter in an efficient time. All right, here's another one. Which of the following medications may be used for performing FFR through both intravenous and intracoronary routes of administration? Adenosine, papaverine, regadenoson, nitroprusside. Okay, panelists, have at it.
Papaverine, we use it on and off in our lab. It just
IV
causes...
and IC?
Oh, IV, okay. IV and ICA,
Ah, that's a trick, Fahim.
That's a good one. That's a good one, yeah.
I wonder if use adenosine, IV or IC.
Yeah, correct. The answer is actually adenosine.
Yeah.
And it's, yes, adenosine can be used both intravenous and IC. The others can only be used in one or the other. Perfect. So adenosine can be used IV and IC. Those are the doses that you can see up there. Regadenoson is usually administered IV more often for stress tests. It is very expensive, less commonly used for FFR. Once in a while in an asthmatic patient, you may want to consider that over adenosine. Nitroprusside can be used IC, 0.6 mics per kilo bonus. Papaverine is used IC, as Fahim mentioned, absolutely. But the side effect is that you have to remember QT prolongation and torsades. So we looked at the scenario where FFR can be falsely high. There can be errors of physiology. There can be interpretation issues, technical issues, or actual issues. So when do you think the FFR is too high? It may be a hemodynamically non-significant lesion, and you could have a small territory, old MI, little viable tissue, small vessel, lots of collaterals, severe microvascular disease where you don't get adequate hyperemia. There may be an alternative culprit lesion that affects your interpretation. There could be diffuse disease, non-cardiac chest pain, technical issues where it can be too high or insufficient hyperemia, guide catheter related issues like we discussed earlier, electrical drift, and maybe an actual false negative in MI, severe LVH, and exercise-induced spasm. So when can FFR be falsely low? So let's look at this scenario. 60% mid-LAD lesion is crossed with a pressure wire. The following tracing is obtained prior to hyperemia. Based on this, you would proceed to PCI as resting PDPA is already significant. B, initiate hyperemia with IC adenosine. C, initiate hyperemia with IV regadenoson. Or D, withdraw guide wire to tip of guide and re-equalize. What do you guys think?
Drift.
Yep.
Yeah. So the answer is D, which is withdraw the guide wire to the tip of the guide and re-equalize. And that would basically take care of the drift. Absolutely. The key thing to note here is that if you see this dicrotic notch looks very normal in the distal pressure, those are high frequency changes that if there is a lesion, usually that will be abolished. So you should not be getting a beautiful dicrotic notch that is transmitted into the coronary artery waveform if there is a lesion. So therefore that's drift. So in general, this explanation for this tends to be a physiologic explanation or a technical explanation. Physiologically, FFR can be too low. You may have angiographically misassessed this lesion. It is actually hemodynamically significant. This can be a collateral supplying vessel to a contralateral vessel, which is a CTO. For example, if the LAD is 60% supplying collaterals to the right, there's a larger territory that's supplied. So that's one issue. You may have coexisting vasospasm. That's why it's always a good habit to get into giving about 100 to 200 mics of nitroglycerin, drift, and of course, pseudostenosis due to the guide wire. Finally, I just want to take a little step back and think about different techniques of pressure measurement. Pressures can be measured with the piezoresistive system, which is used both in the St. Jude Abbott system and in the Volcano Phillips system, as well as an optical system, which is used by OpSense and Boston Scientific, which has supposedly slightly less drift. There's also an assist RXI catheter that you can use with a microcatheter based FFR that you can also use. The nice thing is you can use your friendly wire. So we talked about the definition of FFR, characteristics of FFR, how do you measure FFR, pitfalls in FFR, and troubleshooting FFR. Thank you very much.
Very nice.
Thank you, Gautam. That's a great talk. We are a bit behind schedule, and since Dr. Corbin's talk is also going to be on FFR, shall we just move on to the next talk, and then we can have a discussion about FFR after Dr. Corbin's talk? Okay. Are you talking live, or do we have a pre-recorded talk, Dr. Corbin?
It's pre-recorded. I don't know if the technical issue has been resolved or not.
Sorry. They're putting it on there.
Yes, they are doing it now.
Hello, everyone. I would like to first start by thanking Dr. Kwan Lee, the course director, and Sky International Committee for the opportunity to present to you today this talk about the distortions and common pitfalls. Hello, everyone. I would like to first start by thanking Dr. Kwan Lee, the course director, and Sky International Committee for the opportunity to present to you today this talk about the distortions and common aortic valve stenosis. Is FFR reliable in these conditions? And the answer is that systolic coronary flow and hyperemic coronary flow are reduced in severe AS, and therefore this results in an erroneously higher FFR value. And if you look at this graph, you can see the FFR pre and post aortic valve replacement, where you could see a significant decrease in FFR from pre to post and release of high microvascular resistance from pre to post aortic valve replacement. Now, the second clinical condition in which FFR could be distorted is acute decompensated severe heart failure, where, again, the FFR equation is simplified to PD over PA when the PV, which is the central venous pressure, is near zero. And therefore, if the central venous pressure is high, meaning more than 10 to 15 millimeter of mercury, then we have to account for the central venous pressure, measure it, and subtract the RA pressure from the PD and the PA in order to obtain an accurate FFR measurement. Now, of course, we not very often that we do PCI on those patients who are so sick with acute decompensated severe heart failure and elevated central venous pressure. This is rarely an issue in stable management of CAD, but this is important to keep in mind. Now that we have talked about common clinical conditions that may result in FFR distortion, now let's talk about technical pitfalls during FFR measurement. Now, before we measure FFR, first we need to make sure that the PA transducer is at the same level as the heart. Now, when the PA transducer is at the same level of the heart, that's good. If the PA transducer is high, this is higher than the heart, this will result in a lower PA pressure and therefore erroneous FFR measurement. Now, if the PA pressure transducer is lower, this will result in higher PA pressure and therefore, again, a distorted FFR measurement. The second thing that we need to make sure of, do we have a good ECG signal? Most current machines default to a single beat measurement of FFR. Now, mind you that in atrial fibrillation and in cases with large swings with respiratory variation, there is beat-to-beat variability, which may artifactually change the FFR value. And therefore, a useful tip is to change to a 3 to 5 beat average for FFR measurement. This will reduce the effect of a single beat variation. Next, did we flush the guide wire in the hoop? Did we take out the needle introducer? And did we flush the guide catheter? Now here it's important to note that FFR should always be measured using guiding catheters with no side holes. Next, we have to make sure that we have a good adequate waveform and that we normalize the PA and the PD before we go ahead and measure the FFR. And what is a good adequate waveform? This is a representation of 3 elements that need to be present: an anacrotic notch, a peak pressure, and a diacrotic notch. When we see these 3 parameters, this identifies a good quality waveform. Now, this before we talk about the technical pitfalls of FFR measurement, we have to understand and actually memorize what a adequate pressure tracing for FFR measurement of severe stenosis looks like. Now, if you look at this tracing, you would see a good adequate PA pressure with a preserved diacrotic notch and a typical appearance. And then you would see a ventricularized PD across an ischemic lesion. And this is an adequate tracing of a severe stenosis FFR measurement. Now, the first pitfall in FFR measurement that we're going to talk about is aortic pressure ventricularization. This happens in 5% of FFR measurements. This is where we have loss of the diacrotic notch of the PA tracing, and we have ventricularization of the PA pressure, which is represented by this deep diastolic dipping of the aortic waveform. Now, the causes of aortic pressure ventricularization is guide catheter damping or wedging in an ostial lesion as represented in this angiogram, or a guide catheter sucked in to the coronary artery with increased flow post-adenosine. Other causes would be large guiding catheters and small vessel size and deep guide catheter engagements. Now, the remedy for an aortic pressure ventricularization is to ensure the guide catheter is disengaged during equalization and FFR measurement, and to keep a hand on the guide to prevent it from getting sucked in during hyperemia. This is a schematic diagram representing guide catheter wedging, where the coronary pressure proximal is not equal to the PA pressure anymore. Therefore, the PA pressure in this case will be lower, and this results in an erroneously higher FFR measurement. Now, this results in an underestimation of the stenosis severity. This is again a representation of a deep guide engagement resulting in aortic pressure ventricularization with loss of the dicrotic notch and the deep diastolic dipping of the PA pressure. This is the same tracing after the guide catheter was withdrawn. Now you see restoration of the dicrotic notch and a normal diastolic decline. The second pitfall in FFR measurement is aortic valve aortic waveform, distortion, and this happens in 4% of FFR measurements. Now, this is a schematic representation of what the aortic waveform distortion looks like. You will see a loss of the dicrotic notch, you will see a lower amplitude of the aortic pressure waveform, and a kind of a sinus-like pattern PA tracing. The causes of aortic waveform distortion are residual contrast or blood in the guiding catheter or in the injector system, small guiding catheters, luminal obstruction by device, whether it's a second wire or a balloon in the guiding catheter. The remedies are flushing the lines in the guiding catheter with saline to remove contrast residue and ensure adequate waveform. This is a representation of a sine-like pattern of aortic wave distortion with loss of the dicrotic notch, lower amplitude, and again the sine-like pattern of the aortic waveform. And this is again what a normal waveform should look like. The third pitfall in FFR measurement is pressure drift. Now, what is pressure drift? It is the loss of equalization between the PA and the PD, not related to of the stenosis. It is typically noted post-FFR measurement when the pressure wire is pulled back proximal to the lesion, and then we see that the PD is not equal to the PA anymore. The cause of pressure drift is changes to the wire piezoelectric sensor, and the remedies would be is to flush the wire with saline before use while still in the hoop. This will minimize pressure drift. And mandatory final pressure pullback to assess drift post FFR measurement. And if drift is present, then re-equalize and then recross the lesion and measure again the FFR. Now, this is two examples of a signal drift, where in the upper panel you see the PD is decreased by 0.05 compared to the PA over time, whereas in the lower panel you see the opposite, where PD is increased by 0.05 signal drift compared to the PA over time, and in both cases this will lead to FFR distortion. Now, the fourth pitfall in FFR measurement is submaximal hyperemia achieved. Now, when submaximal hyperemia is achieved, this leads to underestimation of the gradient, this leads to overestimation of the FFR, and therefore underestimation of the stenosis severity. Now, a word of caution when and how to achieve maximal hyperemia. Using IV adenosine, 140 mics per kg per minute is the gold standard to achieving maximal hyperemia. However, it comes with its own disadvantages of being higher cost, systemic side effects, and cumbersome administration. This can be solved by using IC adenosine, but here we have to be very cautious with the dose of IC adenosine needed to achieve near equivalent maximal hyperemia compared to IV adenosine, and this is 200 mics of IC adenosine injection for the left coronary system and 100 mics injection for the right coronary system. A word of caution regarding drug interaction with adenosine: if the patient has taken dipyridamole, carbamazepines, methylxanthines, or coffee prior to FFR measurement, this might affect achieving maximal hyperemia, and therefore a distorted FFR measurement. The take-home points. Now, clinical conditions associated with potential FFR measurement distortions are severe microvascular dysfunction, ST elevation MIs with global CMD microvascular dysfunction, large non-ST elevation myocardial infarctions, and again, global microvascular dysfunction, acutely decompensated severe heart failure with a central pressure greater than 10 to 15 millimeters of mercury, severe aortic valve stenosis with reduced systolic and hyperemic coronary flow, in addition to HOCM, HFpEF, and cardiac amyloid in cases with elevated LVEDP. Now, technical pitfalls during FFR measurements and the remedies. Aortic pressure ventricularization, the remedy is to disengage the guiding catheter. Aortic pressure distortion, the remedy is to flush the lines in the guiding catheter. Pressure drift, and this requires mandatory check for drift after measurement of FFR and re-equalization if this happens. And then last is make sure to achieve maximal hyperemia. And if submaximal hyperemia is encountered, then use IV adenosine 140 mics per kg per minute, or alternatively IC adenosine 200 mics for the left main and 100 mic RCA, 100 mic injection for the RCA system. I will end with this panel, and I will give you a few seconds to think of what might have happened here. This is a proximal LAD lesion being interrogated. The first half of the panel shows a stable IV adenosine infusion at 140 mics per kilogram per minute. Now, what happened during the second half of this FFR measurement? So what happened is that the FFR wire has flipped into the LV. Now, what we're seeing is PD ventricularization. The PA is okay. And therefore, the reason for that gradient seen is because the pressure wire has flipped into the ventricle. Whenever you see this pattern, it is very important to check the position of your FFR wire. Thank you for your attention, and always remember FFR before your PCI. Thank you, and we will open it now for discussion.
Thanks, Michelle. That's excellent. Since we're running a little tight on time, I would like to move on, and we will hold the discussions to the end, and we will have my colleague and friend, Dr. Fahim Jaffrey from Tan Tock Seng Hospital in Singapore. Please tell us about his talk on, I think you're going to talk about PCI optimization, right?
Correct.
Perfect.
Okay. All right. Thank you, Gautam. Can you all see my slides, and
yep.
Can I be heard also? Just want to make sure before we do that.
Yep, perfect.
Okay. So, I'd like to thank everybody, the organizers, for the opportunity to present here. And I'm certainly, very grateful for the invitation. It's hard to follow some really outstanding talks that we've just heard today in this session. So my job is to talk briefly about how to ensure good PCI results. And, I don't have any disclosures related to this. The background is that we've been using angiographic guidance for decades to assess your result. I mean, that's how I trained actually before all the other bells and whistles were available. But we know that angiography has significant blind spots, vessel sizing, complications, knowing where the good landing zone is. All of those makes angiography have its blind spots. And we also know that a lot of patients, as many as 38 to 40% after PCI, end up still having some chest pain. And while all of them didn't get a bad PCI, but some of them actually got a PCI but didn't get relief of the flow limitation. So there's that aspect to intervention that we often ignore. When you talk about decision nodes in the PCI cycle, where do you need aid to making decisions? Well, of course, in the pre-PCI state, you need information as to whether or not you should be doing the PCI. And as Michael just very eloquently stated, don't do PCI without FFR. So that part's already been nailed. But also during the PCI, you need information about stent sizing, stent length, plaque morphology, and how well have you modified the plaque before you go in and put in a stent. And that's certainly not the subject of today's talk, but it is related to today's topic, which is post-PCI, where you're trying to answer a simple question: have I done a decent job in doing this PCI? And when you look at what are the questions you're trying to answer, you're really trying to answer a few. Is my stent adequately expanded? Is my stent adequately opposed? Are there any edge dissections that I can't really pick up, which could lead to stent thrombosis? Have I left behind segments of disease, which could then predispose not only to thrombosis, but also restenosis? And then a little bit about, has the coronary flow actually returned to a physiological level? So the first few questions tend to be answered by imaging, and the last question is answered by invasive physiological assessment. So I'm going to try to touch on these very quickly in this talk. Now, to answer the question, is the stent adequately expanded for fellows? I think it's important to sort of, step back and have a few words about how we size stents to vessels. And up here is a kind of a classic schematic of an artery where you have a tapering vessel with a positively remodeled vessel with plaque in the middle. And you certainly have a distal reference, you have a proximal reference, and you have a lesion site. And of course, during angiography, you look at the lumen, you don't look at the vessel wall. And most of the time, people look at the luminogram and base decisions on what the distal reference size is, what the proximal reference size is. And more often than not, they eyeball and make a guesstimate, sometimes comparing the vessel size with the guider. But when you then consider the possibility of imaging and IVUSing, you have to appreciate that there is a distal reference, which is often the distal lumen if it's a normal vessel, or somewhere midway between the distal vessel and the mid wall if it's a diseased vessel that you're landing your stent in. There is a proximal reference. You have your lesion site, which is positively remodeled with a lot of plaque. And when you talk about sizing a stent, you kind of have to look at it in context. And you would say, well, I'm going to size my stent to the distal lumen, or the distal reference lumen, particularly if it's a normal landing zone. I'm going to post dilate proximally because I'm going to be undersized, and you're going to post dilate to the proximal lumen. And in the middle, you have this area which is positively remodeled. And here you're going to post dilate not to the vessel size because the vessel is huge, but you're going to post dilate to the expected vessel size in this spot, which is going to be somewhere between the distal and the proximal. And so what I'm trying to show in this example is that if distally you're 2.5 and proximally you're 3.5, and in the middle the vessel is 4.0, you're not going to post dilate to 4.0 because this vessel is positively remodeled. You're going to size it to somewhere in between these two based on what your imaging tells you. And so when you talk about whether the stent is adequately expanded, it's important to understand that when you have plaque, which you don't see on the angiogram, when you have plaque, especially distal, but also within the lesion site, it resists stent expansion. And so what then constitutes optimal stent deployment, which you're going to assess in the post-PCI phase? And I draw your attention to this very, very important and great paper published in European Heart Journal about about optimization of coronary interventions. And this is sort of what you are looking at to decide if your stent is optimally deployed. You're going to look at minimal stent area. You're going to look at dissections, edge plaque burden, protrusion, and malapposition. And I'm going to touch on these very briefly. But the most important of all of these is the minimal stent area. How big is your stent? And there are various ways of looking at it. You can look at an absolute number, or you can look at the minimal stent area relative to other reference segments. The absolute number is the best predictor, and it's also the easiest because it's a number. And most IVUS studies suggest that anything between 5 and 5.5 millimeters square discriminates whether you're going to have events or not. This is by IVUS, and by OCT, the numbers are a bit smaller, and that's about 4.5. Keep in mind that this is for non-left main disease, and for left main, those numbers are about 7 millimeters square for the distal left main and 8 millimeters square for the proximal left main. And these are the numbers that we use most often. Of course, you can use relative sizing, which is you compare the minimal stent area to either a proximal or a distal reference or the average. And this is relatively less standardized, but the most widely suggested metric is the minimal stent area compared to the distal reference lumen, or you take 80 or 90% of the average. And when your minimal stent area is more than the distal reference lumen, you have an event rate of about 1.5% per year, which is very, very, very good. And for left main, again, the numbers are a little bit different, but it's kind of 90% or 80%, depending on what you read. And if you look at the Korean literature, they talk about having an 8 millimeter square minimal in the left main. But the point is that there are some numbers that give you an idea of whether your stent is well expanded, and you use that in the post-PCI state to decide if you've done a good enough job. As I said, you're also interested in knowing if your stent is adequately opposed. Are there edge dissections, and have you left behind segments of disease? And as illustrated over here, a dissection is important, and you may or may not pick up on them on the angiogram, but on imaging you will. And what, a dissection can be left behind if it is small, less than 60-degree angle with the flap limited to the intima, and less than 2 millimeters in length. But anything more than that, especially a medial dissection, especially at the distal stent edge, you want to make sure you stent. Edge plaque burden is something that is often overlooked because on the angiogram, you cannot tell if there is plaque over there. You can only tell that on imaging. And we know from a lot of data that if you leave residual plaque at the stent edge more than 50%, or if it's a lipid-rich pool over there, your probability of a recurrent event is significantly higher in the sense of both restenosis and also stent thrombosis. It's important to know if there is extensive protrusion, especially when you're stenting an acute coronary syndrome lesion. When there's a lot of protrusion, it may put you at risk of stent thrombosis. And malapposition, which is common, especially in the proximal segment, when you've sized to the distal, it's just important to understand that if there's a lot of malapposition, it may lead to problems in the future. Although stent malapposition that is mild, defined as less than 0.4 millimeters and less than 1 millimeter length, tends to be something that you can overlook because they will usually heal up. I think the bottom line is if you see malapposition on IVUS, you should probably fix it. If you see malapposition on OCT, you only fix it if it is significant, more than 4.4 millimeters. Keep in mind that stent malapposition as such doesn't have a close relationship with outcomes, but it can cause you trouble if you go back in for some other intervention. Your wire can go behind the stent, so it's important to not leave too much of malapposition. It's also important for fellows to understand that there is a difference between expansion and apposition. Up here in this cartoon, A is a well-expanded stent with a good area and well opposed. It's stuck to the vessel wall. B is a well-expanded stent, good area, but it's malopposed. It's not stuck to the vessel wall. Whereas C is an underexpanded stent, only 3.6, a lot of plaque behind it, but it is a well opposed. It's stuck to the vessel wall. And D is somewhere in the middle where it's reasonably well expanded. You have an area that's over 5.5 and it is well opposed. So your objective is to get something like this where you're well expanded and well opposed. One of them is not enough. Now, the ultimate trial, which was published very recently, suggested again that when you have a stent area more than 5 with the edge plaque burden less than 50 and no dissection, your outcomes are extremely good with a 1-year event rate of 1.6%, which is outstandingly good if you get optimal PCI. And this was just recently, an extension of the study was just presented 2 days ago at TCT, where the outcomes remain good in the IVUS guidance group versus angiography guidance, with a reduction in stent thrombosis by 88%. So substantial benefit of imaging to assess your PCI result. What about physiology? We've heard a lot about physiology right now. So in the next 3 or 4 minutes, I want to cover that quickly. We know that when you look at physiology, often, we've known this for quite a while, that if your FFR post PCI is more than 0.9, the outcomes are good. And if the FFR is less than 0.9, the outcomes aren't so good. And it is not uncommon. Up to 10 to 20% of patients have a residual FFR that's abnormal. The question is whether physiology is a treatment target. And I want to just point your attention to this paper that was published not too long ago, which again showed that when your FFR is abnormal, you can reduce it or improve it substantially from 20% to 8%. But then the question is, how often do you see that? And this is the defined PCI study that looked at, did a blinded IFR in people who underwent a PCI with apparently a good result. And as many as 25% of patients had a post-PCI IFR that was less than 0.9. And the interesting thing was that 80% of these abnormal IFRs were due to a focal problem, either in the stent or beyond the stent or proximal to the stent, rather than diffuse disease. So it is common to have an abnormal IFR as well as an abnormal FFR post-PCI, and a lot of the time it's due to something focal that can be rectified. In other words, actionable information. This study was, the outcomes of this study, there was just presented again at TCT a couple of days ago, where they were able to show that when your post-PCI IFR is more than 0.95, you have a substantial reduction in death, cardiac death or spontaneous MI, or clinically driven TLR. So a post-PCI IFR of more than 0.95 was associated with less cardiac death, spontaneous MI, or TVR, which was statistically quite significant, leading to the question that maybe post-PCI IFR is a target. Now, we don't have that data yet, but it is being studied by the defined GPS trial, where they are going to now treat according to IFR and see if the outcomes improve. The previous study was basically just looking at what happens in most PCIs, and a lot of PCIs end up with residual ischemia by IFR, but they did not treat according to that because the IFR was blinded. So the defined GPS will look at that, and we will know those results in a couple of years. I also want to point your attention very quickly to the target FFR trial, but that was just presented yesterday, where they did something similar to, they tried to answer the question that can the proportion of patients with a post-PCI FFR more than 0.9, can you improve on that by a physiology-guided study? It was not an outcomes-based study. It was designed to say, can you improve FFR post-PCI? And there were some important things that showed up. In the interest of time, I'm just going to skip this very quickly. But what they showed was that, and again, these are people who've gone through a PCI. The operators are happy. They're all done. Then they do an FFR. And only 1/3, so just 1/3 had an optimal FFR of more than 0.9. The others, in about almost a 1/3 distribution, had an FFR that was actually ischemic, less than 0.8, and then the other 1/3 were somewhere in the middle. And what they then did was they optimized further, and they were able to show that there was a trend towards improvement in final FFR, although it was not significant. And so this raises some of the questions that I earlier raised, that when we know that a lot of IFRs are abnormal, can we use that as a treatment target? In this study, we're seeing that, yes, you can improve a lot of FFRs, but it took a lot of time and effort to do that, multiple runs of adenosine, multiple runs of evaluation. So it's not clear whether IFR or FFR is a target. Maybe IFR will be a better target. That's something that we have to wait for the defined GPS study to show. So if I was to conclude, ladies and gentlemen, in the current day and age, PCI with just angiographic assessment is clearly suboptimal. And the data indicates very clearly that there is an improvement in outcomes with post-PCI imaging, particularly with IVUS. The OCT data is coming with Illumin 4. We will see that, see what that shows. But it is likely that it will be significantly better than just angiography alone. I think every interventionist needs to have familiarity with an imaging modality, whether it's OCT or IVUS, that's your choice. Post-PCI residual ischemia, as defined by an abnormal IFR or FFR, is fairly common, and it is strongly associated with outcomes. Post-PCI residual ischemia may eventually become an additional treatment target, which means not only should we look at it with IVUS, but we may also need to put a pressure wire and see if we've actually eliminated the flow restriction. That's something that time will tell. Ladies and gentlemen, thank you very much. I'll be happy to answer any questions from this point onwards.
Okay, thank you very much, Fahim. I think in the interest of time, we'll move to our last speaker, Dr. Rajikant Rajagopal from Brunei, who is going to be telling us on what to do with challenges to evaluate in-stent lesions.
Thank you, Gautam. Right. Great talks already this session. I think we've had a beautiful series of talks starting with angiographic assessment of coronaries, then FFR, and optimization. I think my study sort of follows on from that. I think almost everything that applies to de novo lesions applies to stent lesions as well. But in addition, there are specific aspects that are unique to stent. So we'll talk about stent failure. Oh, my talk's moving on its own. So stent failure, so which refers to instant restenosis and stent thrombosis. And in addition, sometimes you have acute stent problems just during or after PCI, things like plaque prolapse, thrombus, malapposition. These are things we need to address that are fairly unique to stents. So assessment of stent failure always starts with angiography, with the initial diagnosis that you get an angiography, but it's often unlikely to explain the mechanism of stent failure, except under expansion sometimes, especially on stent boost. Physiology can establish the significance of the lesion, as in de novo lesions, but imaging is what really is significant when you're addressing stent failure. And the topic is challenges in assessing. I was thinking, what are the challenges? I think there are two challenges. The first is understanding what we are seeing, and the second is applying this to guide our treatment. So if you're looking at a patient who's had ISR or thrombosis, these are the possible things you could look at. So starting at 12 o'clock and moving clockwise, you might find either an OCT or IVUS. You might find neo-intimal hyperplasia. You might find neo-atherosclerosis, which is a little bit different. You might find late acquired malapposition. Under expansion is a major problem, and Fahim just explained the difference between malapposition and under expansion. Evagination is not much of a problem, really. Stent deformation, stent crush can be seen, and edge dissection. So these are what you will be looking for when you're imaging a vessel where there is stent failure. And these are the ESC guidelines that tell us what exactly we are supposed to do with what we see. So we can try and understand the mechanisms of failure. And this is the most important point that I've highlighted here. We need to provide tailored treatment strategies based on the exact failure mechanisms. I'll explain what that means. This is my own sort of practical approach to treating stent failure. So if I have a patient with stent failure, a significant lesion, either on an angiogram or plus or minus confirmed by FFR, I would do OCT. I tend to do mostly OCT. And that tells me what is the mechanism of failure. And that will dictate what I do next. If it is just neo-intimal hyperplasia, I would balloon the lesion. I might use a scoring or cutting balloon. And in most cases, I would try and get away with a drug-eluting balloon instead of a drug-eluting stent, unless it's required. Again, my last decision between a balloon and stent will also be decided by OCT. If there is significant plaque burden left behind and the flow is not good, if there are many dissections, I might have to put in a second drug-eluting stent. Otherwise, I'll try and get away with a DCB. If there is neo-atherosclerosis, the initial part is the same, but subsequently, I'm more likely to put in a drug-eluting stent. But there are times where we might get away with a DCB despite the presence of neo-atheroma. See, under expansion just needs balloons. So I would go with an NC, a compliant or a non-compliant balloon as much as possible. If required, I tend to use the OPN super high pressure balloons, which you can take up to 35 or 40 atmospheres. And then often that might be adequate. If, however, there is some neo-atheroma, then I might deploy a DEB just to reduce the risk of future instant restenosis. Undersizing, again, similar to under expansion, you start off with NC balloons and OPN balloons, but sometimes if there is gross undersizing, the vessel's 4 mm, and you put in a 2.5 mm stent, which can never get to 4 mm, you may have to ablate the stent and then deploy either a drug-eluting stent or a DEB, depending on how much damage you've done to the old stent and how the vessel looks. Edge lesions usually quite straightforward. If it's a significant edge dissection or residual disease, you just need to put in another drug-eluting stent. So I'll try and explain this further with some case examples. So the first patient was a 46-year-old lady who presented with ACS. She had previous PCI to left main bifurcation done by a colleague about a year earlier. She had a 2.5 mm stent in the left circumflex, and the stent is self-expanding 3.5 stent in the left main to LAD. The technique was kind of a reverse T technique. And the left main stent had been post-dilated with a 4 mm NC balloon. And this was my first angiogram when she came to me with an ACS. You can see on the roof of the left main LAD junction, some kind of irregularity and almost certainly some thrombus. The picture on the right, so I think there's a problem there. The picture on the right just shows you that old stent is stent. They have this little markers of the proximal and distal edge, and you can see the drug-eluting stent in the circumflex. So I did OCT from the left main to the LAD. The stent in the LAD looked, in the mid LAD looked quite well expanded, well endothelialized. But as we came back to the proximal ostial LAD and to the left main, you can see stent deformation. You can see it on both the pictures here and in the 3D reconstruction. Just for explanation, when you look at the longitudinal view at the bottom of the OCT snapshot, all the white struts are well opposed and the red struts are not well, they're malopposed. And that's what you're seeing in the cross-sectional views and in the 3D reconstruction. I'll show you slightly bigger pictures. There we are. So you can see in all these three frames, the stent struts are protruding into the vessel wall, sort of huddled together. And that's clearly stent deformation. And the most likely reason that happened is because of the catheter during the original procedure diving in during the post-dilatation. There are other possibilities as well. Regardless, no, OCT is shown as what the problem is, and we knew what to do to fix it. I wanted to IVUS or OCT or IVUS the left circumflex, but could not get any catheter through. And knowing there was stent deformation, I did not want to be too aggressive trying to push anything through. Instead, I post-dilated this left main LAD stent, put in a new 3.5 stent, and took it up to 4.5. I subsequently finished with the kissing balloon inflation. And that was the final result. And both an angiogram and OCT, you can see a well-expanded new stent. You can see two layers of struts between about 6 to 8 o'clock. And the old and new scans, and it was a good result, and patients done well. So how did imaging, and this is again a scan rendering PCI. You can see the 3D reconstruction showing that the scans are all well deployed here. So like I said earlier, OCT is not about the pretty pictures, it's about how it helps your procedure. So in this case, I think it helped me identify the problem with the stent deformation. It helped me understand the mechanism and therefore guided my treatment in terms of putting in a new stent and post-dilatation. Okay, the next patient was a 46-year-old man with dialysis, came with recent onset angina. He had previous CABG and PCI. His problem now was it's his left circumflex. He had PCI from the left main to the circumflex about 6 months earlier. And this time around, he had severe in-stent restenosis. Sorry, my computer keeps jumping forward. I'm trying to keep it in control. And there was also a distal CTO. So after some pre-dilatation, I did OCT that showed a couple of things. It showed disease in the main, where the ISR was. I'll show it later. But on the frame on the right, you can see there is dissection of the ostial left main, probably catheter induced. I had to keep that in mind and make sure I cover it by the time I do the stenting. But the interest really is about the in-stent problem. Although the previous procedure was done by a colleague, he used to 3.5 on stent, which was I think good, and the final result looked good. We can see that in the middle frame there is significant malapposition in the ostial circumflex. And as you move proximally from there, you can see severe NIH, neodymal hyperplasia in the left main, disrupted a little bit by the pre-dilatation. So we knew that the problem of the malapositions. I was able to then go and post-dilate and put in a 4x23 stent, which again with OCT guidance, I post-dilated to 4.5 mm, and the patient had a good result and remained well since then. So how did imaging help? Helped me understand the mechanism of ISR, helped me identify and assess the malaposition, spotted the dissection in the ostial left main, and thus I could easily make a decision that I'd put in a new drug-eluting stent. A drug-eluting balloon wouldn't work here.
gì trong dòng thác thông tin,
kiến thức chuyên sâu,
giá trị thực tiễn,
tâm điểm 2020,
đồng hành, đồng sứ mệnh.
Hội Tim mạch Việt Nam trân trọng giới thiệu chuỗi hội thảo trực tuyến về tim mạch.
Tâm điểm 2020, nơi cập nhật những tin tức mới nhất về chuyên ngành tim mạch học.
Nơi trao đổi, tương tác đa phương tiện với những chuyên gia tim mạch hàng đầu về những chủ đề khoa học và thực hành mới nhất của chuyên ngành.
Nơi tổng hợp những kiến thức về tim mạch học cho các bác sĩ và bệnh nhân.
Đồng hành, đồng sứ mệnh. Tâm điểm 2020
hứa hẹn sẽ là diễn đàn trực tuyến hot nhất được phát trực tiếp trên các nền tảng trực tuyến của Hội Tim mạch Việt Nam. Tâm điểm 2020 phát sóng 9 giờ đến 10 giờ sáng, thứ Bảy hàng tuần bắt đầu từ ngày 13 tháng 6 năm 2020.
Ấn phẩm truyền hình hàng đầu của Hội Tim mạch học Quốc gia Việt Nam.
Tin tức chắt lọc, cập nhật, thấy gì trong dòng thác thông tin.
Kiến thức chuyên sâu,
giá trị thực tiễn.
Tâm điểm 2020.
Đồng hành, đồng sứ mệnh.
Năm 1992, Hội Tim mạch Quốc gia Việt Nam được thành lập, đánh dấu bước phát triển mới của ngành tim mạch Việt Nam.
Hội Tim mạch Việt Nam là nơi tập hợp các bác sĩ trong chuyên ngành tim mạch để cùng nhau chia sẻ kinh nghiệm, cập nhật những cái thông tin mới nhất trong lĩnh vực chẩn đoán và điều trị các cái bệnh lý tim mạch.
Hội tập hợp hơn 1.300 hội viên với hàng trăm giáo sư, phó giáo sư, tiến sĩ. Gần 50 hội viên danh dự là các giáo sư, chuyên gia tim mạch nổi tiếng trên thế giới. Có hội đồng khoa học uy tín với thành viên là các chuyên gia đầu ngành trong lĩnh vực tim mạch. Thành lập được 4 phân hội chuyên sâu bao gồm phân hội tăng huyết áp, phân hội siêu âm tim, phân hội tim mạch can thiệp và phân hội nhịp tim Việt Nam.
Hội Tim mạch Việt Nam là một cái hội nghề nghiệp. Chúng tôi rất chú trọng đến cái công tác chuyên môn và nhất là công tác đào tạo cán bộ.
Hội đã tổ chức hàng ngàn cuộc hội thảo khoa học với các đề tài chuyên sâu có giá trị thực tiễn. Nhiều báo cáo khoa học đạt giải thưởng cao tại các hội nghị trong nước và quốc tế. Ứng dụng nhiều kỹ thuật mới trong chẩn đoán và điều trị tim mạch, trong đó nổi bật là kỹ thuật tim mạch can thiệp và kỹ thuật ghép tim. Mở hàng trăm các khóa đào tạo về chuyên khoa tim mạch định hướng cho các bác sĩ tại nhiều địa phương. Biên soạn bộ tài liệu cầm tay về các khuyến cáo dùng cho điều trị. Đặc biệt trong vòng 10 năm qua, tạp chí Tim mạch học Việt Nam ra đời trở thành tài liệu tham khảo đáng tin cậy của các bác sĩ tim mạch.
Song song với đó, Hội Tim mạch Việt Nam luôn chú trọng đến việc giao lưu, hội nhập quốc tế nhằm nâng cao cái vị thế của ngành tim mạch Việt Nam với bạn bè quốc tế. Đến nay thì Hội Tim mạch Việt Nam đã chính thức có cái quan hệ hợp tác quốc tế với 42 các cái hội tim mạch trên thế giới.
Yeah. 5 years ago, when I was training, it's the same thing. Attending tried their level best to avoid atherectomy. Still.
So in Tucson, do you guys have you been in any shockwave studies or?
I've used it for peripherals when I do my TAVRs, a few cases, but I haven't used it yet.
Yeah, I missed the presentation today. You know, they said that there weren't complications, but everybody's been alluding to the arc of calcium that they needed to be effective, and I didn't know if it was definitive or not, or whether it was really a reflection of who was admitted into the studies and such. So I'm still trying to figure out the technology and, you know, how I think the ease of use compared to rotoblader, the adoption would be very high if there's benefits. So I think it's really that point. Okay.
Live.
Dr. Noah, are you, what are we doing here? What time do you guys have? Oh, we're supposed to be starting. Around this time, but I don't know sure if we're being televised yet.
Hi, Dr. Atali. I'm Asri Ranga from Malaysia. Nice to meet you again.
Hi. Yes, thank you.
This session has been televised.
Hi, Dr. Ranga. Arka.
Hey, hi, Arka Chatterjee. Hi. What time is it there? Midnight?
It's for me, it's only 10 p.m.
Okay.
But I've been getting at 5 a.m. to watch part of the TCT, so it's been a long day.
Okay.
In doing cases, but no, that's great. It's always fun to be part of these programs.
Yep.
I'm getting messages that we're live, so I think we should start.
Okay. Well, for our audience, this section is called The Challenges in Calcified Lesions. I'm Dr. Arthur Lee, one of the chairpersons. Want to introduce yourselves?
Hi, I'm Asri Ranga from Malaysia. Hi, welcome everybody. It's a privilege to be here. Thank you.
Hi everyone, I'm Dr. Hong from Vietnam.
Hi everyone, I'm Kechi Jama from Mayo Clinic Health Systems in La Crosse, Wisconsin. It's a pleasure to be here. Thank you so much.
Hi, it's Arka Chatterjee from University of Arizona in Tucson, Arizona. Thanks for inviting me. And again, hopefully we'll have a good session.
Okay, so I guess we might as well proceed with the talks, Dr. Ho. I believe you are our first speaker. Your topic was how to evaluate calcified lesions and when to do rotoblader, if I recall. So meeting organizers, do we have his talk to run?
Okay, we can see it on the screen.
Yeah. You can see my slides?
Yes.
Hello everyone. Today I present the topic entitled How to Evaluate the Calcified Lesion When I Need to Rotablate. Heavily calcified coronary lesion always accompanied with the low success rate, high risk of immediate complications, late failure due to span expansion and malposition, poor clinical outcome as well. Good characterization of calcium distribution multimodal imaging is important to improve the treatment of this kind of lesion. So mechanism underlying the development of the atherosclerotic coronary calcification. Dysmorphic calcium precipitation is relating to chondrocyte and inflammatory factor. The primary cause is related to the death of inflammatory cells and small muscle cell. An intense inflammatory response is related to collateral deposits caused under the endothelium, lead to the development of microcalcification. So coronary calcification as the predictor of events. Calcium score on MSCT is an independent predictor of coronary event in both asymptomatic and symptomatic individual, according to MESA study. Spotty calcium calcification associated with the unstable plaques and acute coronary syndrome as well. Coronary calcification is the marker of advanced atherosclerosis correlated with multivessel disease and the presence of complex lesions. The prevalence of moderate and severe calcific lesions is about 18 to 26%. So how to evaluate the calcified lesions? Calcified lesions on angiogram is just around 40% on angiogram. So MSCT is a good imaging tool as well. Tactile feeling, we can feel the resistance during the wiring the calcific lesion or advancing the devices through the lesions as well. IVUS and OCT are excellent tools for the evaluating calcification and distribution as well. So we can evaluate the calcification on the MSCT, on angiogram, and IVUS and OCT. So on the IVUS, we can see the arcs of calcium here, and the OCT as well very clearly that the 360-degree calcification around the vessel circumference. So this is one of the sample that the clip A is the very tight lesion at proximal to mid RCA, and the clip B is the CDO of the OM. So we can see very clearly the calcification on the clip B, but not very clear on the clip A. But we can feel that when we wiring the lesion like this, we put the device in and it keep bouncing back. And on the clip B, the patient number 2 is the CDO, and we wiring the lesion, and then we put the small lead balloon 1.0 millimeter cannot cross the lesion. So it is another example of the calcification. We can feel there is a lot of resistance when we are wiring the LED lesion. So we put the IVUS in and we see 360-degree of calcium around here. So indication of the rotational atherectomy can be the severe calcified lesion, uneligible or chronic lesion, diffuse long lesion, small vessels, instant restenosis, bifurcation lesion, arterial lesion, etc. Treatment of calcified lesions, so we can use the non-compliant balloon with high pressure, cutting balloon, angioscope, orbital atherectomy, rotational atherectomy, laser, or IVL, intravascular lithotripsy as well. So this is one of the algorithm that some doctor can use in order to deal with the calcification. With the patient with mild calcification, so we can use the balloon in order to predilate that. If it's open, so we put the stent in, and then we use the IVUS OCT in order to optimize the result. If it's not, it is suboptimal, so we use the thinking about the lithotripsy. And with the moderate to severe calcification, so we use the IVUS or OCT in order to assess the calcium arcs. The calcium arc from 180 to 270 degrees, so we give 2 points. And more than that, it's 3 points. And the calcium length about more than 5 millimeters is 1 to 2 points. And the thickness more than 0.51 points. So if the calcium is 1 to 2 points, so we use a very high pressure NC balloon in order to inflate that. And if the calcium is 3 to 5 points, so we may use the lithotripsy in order to prepare the lesion. If the lithotripsy balloon cannot cross, so we think about rotational atherectomy or orbital atherectomy. And after that, we use the IVUS OCT in order to optimize the result. If the lesion, very tight lesion, like the example I just showed on the presentation, patient that the balloon or device cannot cross. So we think about the rotational atherectomy or the orbital atherectomy, and then we after that we use the IVUS or OCT in order to optimize the result. So back to my patient. So the first patient is chanted out with the floppy rotor wire, and then we rotablate that, and on the right side the final result. And the patient number 2 is the CDO. We use the anchoring balloon as here, but the smaller balloon cannot cross, and with the very strong backup of the guiding catheter as well. So we thinking about the rotablades. We have to exchange it out with the rotor wire, and then we rotablade that, and then we put the 2 stand for the bifurcation. So with the patient number 3, so we use the rotablade 1.5 in order to rotablade that, and then did the final result on the right side with the little bit residual stenosis. And we can use the high pressure balloon to optimize the lesion after rotational atherectomy. This is one of the patient like this. So picture A, the very tight lesion. So we indicated the rotablade placement at first, and then after rotablade we use the high pressure balloon, but still have very tight weight up at the middle of the balloon, and then we use a higher pressure in order to open it up a little bit more, and then this is the final result with a little residual stenosis acceptable. And we can use rotational atherectomy for bail-out in some cases. So this is one of the patient like this are very tight here. So at first we don't think that we have to use the rotational atherectomy. So we use the high pressure balloon. We use the normal balloon first, and then a very tight here. So we open it a little bit more, and we cause a lot of dissection at the proximal and distal to the very focal calcification position. So we exchange it out with the with the floppy wire, and then we rotablade that. This is the final result here. And this is my take-home message. The calcified coronary lesions are still challenging, and they need to be properly evaluated and approached. And rotational atherectomy is one of very useful adjunctive devices besides heavily superficial calcified lesion. And optimal strategy and techniques that are crucial to control the procedure and avoid any potential complications and have a better outcome. Thank you very much for your kind attention.
Very nice, Dr. No. You know, I've been going to Vietnam for the last 5 years, and we've seen a slow uptake in rotoblader, mostly because of the economics of and the cost. How much rotoblader are you doing in your practice now?
Actually, I did the I have performed the rotor for almost 10 years, Professor. Yeah, almost 10 years now.
That's good. Yeah. Well, you know, when your case is there after dissections, in the early days of rotoblader, one would always say you should never do rotoblader, but it really, you know, as you become more experienced and we understand what we're doing, you know, sometimes that's what you need to do. You still can't get a stent down after dissection unless you take a burr down.
Yeah. Yeah, very scary when we do the ballooning, and then it got a lot of dissection. But in this situation, we use a high pressure balloon, very high pressure balloon, but it still cannot cross the lesion. So that's the reason why we have to use a rotablator.
Yeah, my practice, I think I would start off with rotoblader, and we wouldn't have to create that challenge.
Yeah, that's the reason why. Nicely. Yeah, Rob, that's the reason why I put at the take-home messages that we have to evaluate the lesion first, and then we draw up like that. Otherwise, we have to bail out the procedure, so it will be very dangerous for the patient. This is one of my patients at the first year of practice, rotablation atherectomy.
Dr. Chatterjee, you mentioned that in the last few years, people have been doing a lot more atherectomy. How have you seen your practice with rotoblader?
Same, previously we used to struggle for half an hour and then, postpone the case and then bring them back in a few weeks after the dissection has healed. But nowadays, at the first sign of trouble, we just switch out to an atherectomy strategy. And usually that, even before we get any decent sized balloon in, so that, avoids all this trouble. But I was going to ask, if you do get into this situation, into a dissection, which modality do you feel most comfortable using at that point? And, do you still postpone cases? I mean, depending on the type of dissection, we would still postpone at some points, right?
I think it depends on the flow. That was a pretty small vessel. I don't think you could postpone it. I think there'd be a good chance of thrombosis.
Vessel closure, yeah. But would you rather use a, non-physical atherectomy mode, like a smaller laser catheter, than atherectomy in that type of situation?
Any other speakers have any thoughts about using laser after dissection?
In Malaysia, we don't have lasers. I have no experience in that. Sorry.
Although lasers are always kind of mentioned as one of the options for atherectomy. My experience in highly calcified lesions is that it actually causes dissections often. So to use laser in a dissected vessel, I'd have some hesitation, though I've not done it myself, to face the consequences for better or for worse.
I mean, it's go ahead, Kechi.
No, I said I would agree. In the setting of a dissection, you want to be cautious about the use of laser atherectomy.
Yeah, the other thing is, even with the other worrying is the orbital atherectomy. So if I have any dissections, I rather use a rota than an orbital CSI, even a small dissection.
Yeah, all great comments. I believe I'm the next speaker. Are they able to pull up my talk today?
I think you can, Natalie. I think you can go ahead.
Oh, no, there's my talk right there. Go ahead and play it. So I'm speaking. That's my talk. Can you guys hear it?
No, actually. Not yet. It's pre-recorded nicely.
Okay, meeting organizers, you can try one more time. If that doesn't work, we'll go live. The organizers of this ASEAN series. Okay, I'm invited to talk today. The topic they gave me was avoiding rotoblader complications. When I started thinking about this talk, the question is, what are the complications that we worry about and how often they occur? I have no conflicts. You can see most complications of rotation atherectomy are common to PCI procedures. And the worst complications, perforations with tamponade, have been explored extensively with the CTO era. So therefore, we're talking about rotation atherectomy specific complications like flow disturbances, burn entrapment, rhythm issues, dissections, and perforations. How often do these occur? I looked at this report from the JPCI registry. And from January 2013 to December 2014, there were over 400,000 procedures done, of which almost 13,000 had rotational atherectomy, about 3% rate, which is about the rate in the United States at this point. You can see that the incidence of complications, death, cardiac tamponade, and emergent surgery were 1.3%. What did they learn from this registry? They found that patients who had renal dysfunction, previous MIs, had higher risk, as well as patients who had complex multivessel intervention. Additionally, they found that rotational atherectomy complications with 4 times the rate of emergent PCIs, or elective PCIs, excuse me, and the risk of complications was less in high volume institutions. As many of you know, there's a new version of rotational atherectomy. However, despite the fact that the controls are now on the handle, the mechanism of atherectomy remains the same. But it has led to increased use of rotational atherectomy, and this is Asia and United States. And you can see that China is also growing, but Japan is staying flat. So the question is, rotoblader, what's your fear? What's keeping you from doing it more often? Is it the arrhythmias, a heart block? We've talked multiple times in the past about using aminophylline bolus or temporary pacemakers. Slow flow is something you experience in QDMIs. And hemodynamic compromise now can be treated with Impella, in procedures known as rotopella, or as I've done with immediate neosynephrine rescue and balloon pumps. So things we're really concerned about are entrapped burr, perforations, failed procedures, rotor regret, and loss of bifurcation side branches. Technique. This is the typical LED lesion. And this is what I would call good technique, where there's contact time 2/3 of the time with gentle withdrawal of the burr back to allow some flow. This is in contrast to the rapid darting you see often with very little contact time on the lesion. What about speeds? We talk about this often. The Japanese like to use 200,000 RPMs. I use 140 and 150 RPM. That stems from the days when we found that platelet aggregates were less with slower speeds. However, we know that we can block platelet aggregation with new contemporary antiplatelet regimens. And then if some operators are still concerned about perforations, so they actually argue for use of these agents after procedure, which isn't really very helpful. But Cangalore, because it's short half-life, actually is a very good option. So is there a reason for high-speed rotational atherectomy? Well, this is a study out of Japan, and they did 3 different speeds: high-speed rotational atherectomy, low-speed rotational atherectomy, 110,000 RPM, and a combination first fast followed by slow. And you can see the MLD and the MLA were both greater with the hybrid approach, but the slow-speed rotational atherectomy didn't do bad. They also did this in humans, and you see that that the reference vessel was actually larger in the high-speed rotational atherectomy group. But again, the high speed followed by low speed still gave better results. So I think there's room for discussions about what speed we should be using at this time. How about burst size? Complications were very high in China when I started teaching there several years ago. And it turns out they use a high percentage of very small burrs, 1.25 burr. And over time, you've seen a shift from 42% down to 28%. And with that, there's been less entrapped burrs and less perforations. So I do believe that burr size is important, and technique with a 1.5 burr is probably the safest. In terms of burr entrapment, I think that sometimes it just happens. It happens to me. The good news is that people come up with many different ways of actually extracting the entrapped burr. So here's a typical case where rotoblade is really necessary for that mid lesion. However, look at the tortuosity. It is a high risk for complications. You can see that use of a rotor floppy wire does not change the conformity of the vessel. However, what happened is that the burr could not pass through that area. So how do we address this case? Well, the tortuosity is always a problem, but so you want to protect the tortuosity from the burr. And what I do oftentimes is advance the burr quickly through the tortuous segments. And sometimes people now use guide extensions. certainly avoid stiff wires with associated pseudo lesions and wire bias. For those who cannot cross the lesions, better guide support, use of body wires, guide extensions, and larger guides. But again, multiple times, I've just used better technique and have been able to cross despite the use of smaller burrs and higher speeds by previous proctors at the same institution on the same patient. Article about the buddy wire technique. But as with everything else, there's always a surprise. In this case, the burr detached. The good news, there wasn't a perforation, but if you look at the angulation, as the burr comes across this curve, there was a risk that if you just left the burr in that position, that it would push against the wire and cause a wire fracture. But in this case, there's no wire fracture, and you can see the burr was successfully retrieved just by pulling back on the rotor wire. However, you still had to deal with the mid lesion. What do you want to do now? Given the non-passage of the burr, do you use a smaller burr, use stiffer wire, or use better guide support? The choice was actually to use a stiffer wire, and you can see that it did cross the lesion. However, look at the distortion of the curvature compared to original curvature of the vessel with the rotofloppy wire. This is what happens. You get perforation because of the wire bias. Fortunately, this was treated easily with the covered stent. So the question is, did they need to go back and cross the lesion completely? There's now some proponents of the halfway technique, where actually instead of going through the lesion completely with the burr, as you see as ABC, you actually just go through the lesion halfway and then finish up with the balloon. That way, hopefully avoiding perforation. Was it successful? 90% of the time they could dilate with the balloon after the halfway technique. And you can see there were no perforations with the halfway technique as opposed to the traditional approach, going completely through the lesion. So in this case, complication burr, how do you avoid it? Gentle advancement, but it may be a manufacturing issue. Burr non-passage, we talked about, you could use higher speeds, smaller burr size, better guide support. However, I believe if you use good technique with increased contact time, you do fine. And with perforation, avoid wire bias. Use the rotofloppy wire. Use rapid transverse across angulated areas. You can use guide extensions, although I have not used that technique. And the good news that good lesion prep previously prior to perforation allows for easy covered stent delivery. So there is some benefits. Another case, complication case from 2002, looking back, what can I do to prevent this? You can see a bifurcating circumflex OM lesion. This is rotor blade bacchinosis with 175-215 burr, and you can see still indentation on the balloon. We decided to balloon aggressively at that time, and you see what happens, perforation. This is successfully covered with a covered stent, you should see here, but there is still additional disease, which was then approached with another rotoablation technique. And as you can see with the hand here, the outcome was not so good because we had the same indentation on the balloon. We ballooned aggressively, not learning from our previous experience. We had a dissection and perforation, which then had to be treated with a second covered stent. So what would I do differently now? I think using a balloon post-rotoablation to make sure that you get adequate plaque modification. And if you don't, you should probably use imaging to understand what's going on. We talk about failure of a procedure is actually loss of major side branches. This is common now when we deal with left main distal lesions with osteal LED and circumflex disease. The question is, how do you protect these two major branches? Historically, we say that rotablation does not lose the side branch. And I would treat the circumflex first because it's easier to get back into LED. However, those who are not as confident can use this guide extension sleeve technique, protecting the LAD by putting a wire and then making sure that wire is not caught up in the drive shaft of the rotoblader by putting a guide extension over the rotoblader. And you can see all the measurements of the different guides and the guide extensions. A modification of this is using a microcatheter over the wire and then protecting the wire and then just using your rotoblader as is through the guide catheter. So different techniques. So how do you avoid complications with rotoblader? You actually have to plan your procedures and think of what your options are. But more experience will certainly lead to refinement of your techniques, knowing when to push and when not to. And nowadays, in the 2 decades since that first complication in 2002, intravascular imaging is really very, very helpful. There are always new tricks and tips to learn. The halfway technique, I think, is very good. And recognize that some complications are avoidable or not, and some are not. But good technique will always decrease your complications. So looking back on the JPCI registry, in terms of rotational atherectomy, it's like walking a tightrope. It relies on the skill interplay of moving forward, but not overstepping in everyday clinical practice. And areas that will help improvement are invasive, imaging-based understanding of the mechanism of rotational atherectomy, and also further refinement in the techniques. So technique, overcoming your fear, and gaining more experience is the best advice I can give you for avoiding complications. So thank you from the United States. Wish I was there with you. It's been over a year. Please submit your questions for this discussion. Thank you.
That was a great talk. I really like the fact that you highlighted for the fellows listening ways of avoiding complications. And if you do get complications, how to deal with them. I think that was really great advice presentation for the fellows and for everyone listening, especially how you described, the entrapped burr, how to deal with that, and also dealing with tortuous vessels when you're trying to do the rotational atherectomy. And the halfway technique, I hadn't heard of that. So that was a great thing for me to pick up too. So great talk.
Thank you. I like the halfway technique because sometimes we get trained to say we got to do a certain way, but sometimes you don't have to make things perfect to, make things good.
Yes, I think Dr. Arthur, the halfway technique is something we have to maybe start getting used to. And I will show in my case, I had a complication trying to get through a band. So yeah, very useful tips and techniques.
How does think about osteal lesions? Does everybody use an extra support wire for that, or is it 50-50?
Yes, about the extra support. So I use for the outcome of the LED or RCA, and when the vessel is straight with the very curly vessel, so we use the floppy wire.
Actually, I almost never use the extra support wire. Most of the time, I use imaging to guide, and you know where is your bias is. So most of the time, I hardly use that. Yeah, almost zero.
Yeah, actually, I think rotoblader is markedly underused for RCA osteal lesions, and those I do use a rotoaxial support, and I also have a technique of using an IMA guide so that I can actually drop it below the ostium and burr from below, and then pull the guide up and burr from above, so it could have more of an effect on the osteal calcification. But why don't go ahead with your talk, Dr. Chatterjee, so let's try to stay on time and take some questions at the end.
Good afternoon. Thank you to Sky, to the Vietnam National Heart Association for giving me this opportunity to present. We will be discussing the alternatives to rotational atherectomy for calcified coronary lesions. However, I would like to start by pointing out that the most important skill in dealing with this lesion subset is to be very proficient with intravascular imaging, whether it is IVUS or OCT, that depends on your choice. Let's start with orbital atherectomy. These are the things that are in the setup. Here's the electrical pump, which rotates the catheter. Here's the catheter and the console. The console has this button, which moves the crown back and forth. These are the two buttons which choose the speed. And then this is the brake. Here's your Viper slide, the lubricant. As you can see here, the crown is not at the tip of the catheter like with rotational atherectomy. However, it's kind of in the middle and it's eccentrically mounted. So the mechanism becomes the centrifugal sanding. So the differential sanding, because of the centrifugal kind of force and it does shave off the calcium, but theoretically it does not affect the normal part of the vessel. There's only one crown for coronary, 1.25 millimeters. The speeds are preset, so you don't have to test. 014/012 wire. You can wire directly in some simple lesions. However, mostly we would switch out after wiring with the workhorse. The size of particles released is theoretically smaller than that with rotational. And then because it does not ablate front on, theoretically it causes less vessel occlusion or ischemia. Then there's the added recent feature of glide assist, which is like your Dynaglide on Rota. And the crown rotates at 5,000 RPMs in that mode and makes device delivery very easy. Just a quick comparison. So with rotational, you have multiple equipment needs. You need the gas tank, you need the pedal, although with Rota Pro, the pedal has gone away. With orbital, there's simpler to set up. There's just the electric motor console and the infusion line. The speed, you have to choose between 160 and 200,000. It's faster. Orbital is slower. Rota creates a channel with the nose of the burr. Orbital sands in a centrifugal manner. With Rota, you have to make quicker passes in a pegging motion. With orbital, you have to be very slow. And that is the key, that you have to go at 1 to 2 millimeters per second and not faster. Only forward ablation with Rota. Orbital, you can also do backward ablation. That kind of helps because sometimes in the rare circumstances that you get stuck behind a lesion, you can ablate backwards and get out. The Rota, you have to choose different sizes based on the vessel caliber, and that requires different sizes of guide catheter. With orbital, it's the same crown. Increase the speed if it's a very large vessel. For example, 5 runs at high speed will give you a lumen of 1.85 millimeters. This is a representative case. You can see the calcified lesions in the proximal mid part of the vessel. The referring actually tried with balloon angioplasty, and you can see the balloon is underexpanded in the proximal part, and hence he stopped and referred the case. So we chose to do orbital atherectomy on this. Please note that the speed of the device is very, very slow as you go in. We made about 4 passes. You can see the balloon expands pretty well. So we were able to deliver and deploy our stents. You can see the final result is nice, well-expanded stents. What is the evidence for orbital atherectomy? Orbit 2 trial is the biggest study so far. It's a single-arm, multi-center prospective study. Inclusion criteria: severely calcified lesions by both fluoroscopic as well as IVUS criteria. Exclusion: prior stents, recent MI, advanced CKD or hemodialysis patients, and patients with very low EF. The primary endpoint was freedom of 30-day MACE, which was set as 83% based on prior studies in calcified coronary lesions with ROTA as well as other devices. The results, the freedom from 30-day MACE was 89.6%, and the procedural success, which was delivering and deploying a stent without major residual stenosis, was 88.9%. Both of these markers hit their criteria. Important to note that there were a few major complications like severe dissection, perforation, slow flow. However, these were few and are kind of expected in this lesion subset. We do have some extended follow-up from the Orbit-2. So these are the 3-year results. So the total MACE after 3 years is about 23%, which is lower than in the rotational atherectomy studies, although there is an era difference between the trials. And the target lesion revascularization rate is only 7.8% at 3 years, which is pretty good for complex calcified lesions. The randomized Eclipse trial is almost halfway through. They're randomizing 2,000 patients, 1-to-1 to orbital atherectomy versus regular angioplasty. There is an OCT imaging cohort in this one also, so we'll get some imaging insights from this. There are multiple small imaging studies, mainly with OCT, which suggest that there may be a small benefit of orbital atherectomy over rotational in terms of how much plaque is modified, especially the calcified plaque. You can see here, calcified plaque modification is a little bit higher in orbital atherectomy as compared to rotational atherectomy. You should be very wary of doing orbital atherectomy in in-stent lesions because of the eccentric centrifugal mechanism. There is a chance that this can get stuck within a protruding stent strut. This is a case report where the operators got lucky and the device came out. I have been referred patients where the device is stuck and torn inside the stent. The patient has been referred for urgent surgery. Let's move on to laser atherectomy. Used to be very popular a couple of decades back. However, it's making a comeback. 3 mechanisms by which it ablates: the photochemical, directly with the UV light; the photothermal, by creating the vapor bubbles in the heat; and photomechanical, which is these bubbles bursting and disrupting the plaque. So you need to have a generator, which uses a noble gas to create short wavelength laser beams. The Spectranetics or Philips version we use uses xenon. These laser beams have a short distance of tissue penetrance, only 50 microns. So it ablates the plaque, but theoretically does not affect the media, the externa. A steady stream of cooling fluid is required as the vessel is treated. So you have to have a saline infusion during the on phase. Really beware of large angulations because the laser beam is not a bend. Hence, with greater than 60 degrees, or some people say even greater than 40 degrees, you have a greater risk of perforation. This is the generator. It needs about 5 minutes to warm up. And you have to point the catheter to the calibration. You have to advance the laser catheter to the site, clear the guide of blood or contrast. It has to be a saline column at least to start. Then ablate. You have to choose your fluence and energy. Can vary from 30 to 80 millijoules. And the frequency of delivering pulses can vary from 25 to 80 pulses per second. Here's your catheter choices. This is what we commonly use, the 0.9 millimeter catheter, which goes up to 80 millijoules and 80 pulses per second. Can go through a 5 French, but we usually use a 6 French to go through. You have all these options also. How about the settings? So we always start on low settings because we do not want to deliver a whole lot of energy in one go and then have a complication. We start with 40 on fluence and 40 on frequency. Usually increase the energy or the fluence first, so go to 60-40, and then the frequency go to 60-60. And then if you have to go to max settings, we can go to 80-80. Ablation with contrast, it does help. When you put contrast or blood in the mix, the energy generated is more, tissue gets heated more. However, we only use it if there is no expansion with max settings with saline. You can use it in razor PCI where initial atherectomy is not able to pass through the lesion and you want to create a channel. However, noted that the dissection perforation rate is more when you do contrast or blood ablation. Here's some data from the BCIS database. So previously, laser was used more for thrombotic lesions, for STEMIs, and you use glycoprotein B2B3 inhibitors, etc., and grafts. Nowadays, it's more and more used for calcified lesions. So out of almost 700,000 PCIs, it was only used for 1,470 cases. So it's a rare occurrence even now. Again, previously used for thrombotic lesions, but now more and more it's used in cases which are likely calcified. The cases with laser do have higher odds of dissection, perforation, slow flow, and reinterventions. There is no difference in death or MACE. So the more common use for laser atherectomy is for in-stent lesions where you have underexpanded stents and peristent calcium. This is a European series with 81 patients with peristent calcium and in-stent restenosis, 23 treated with laser, 58 without laser. There was more calcium fracture with laser and a higher resultant MLA with laser. Also, laser with contrast caused a deeper calcium fracture. So you can see these calcium fractures on OCT. So here's a case. This case was actually sent to us from the OR. Patient was having a lung biopsy, had stopped his plavix and had stent thrombosis during induction. You can see that the balloon does not expand at all at the proximal edge of the stent. Stent is grossly undersized and underexpanded, and there's peristent calcium. We use the laser catheter to treat this, even with contrast. And so after that, the stent was able to be expanded. You can see over here. You can also use laser for difficult native calcified lesions, especially when it'll be difficult to deliver the traditional atherectomy devices. This is a case of an anomalous right coronary with diffuse calcification, as you can see. With a guide liner and a guide, we were able to get a laser catheter all the way down to the distal bend. And then we were able to get a good result. The relatively new kid on the block is intravascular lithotripsy, where you deliver a balloon to the lesion. The balloon has lithotripsy emitters spaced 12 millimeters apart, creates these sound waves which propel the fluid column and generates these pressure waves across the lesion, hence breaking the calcium causing fractures, as you can see in the OCT pictures here. The data so far is small. The Disrupt CAD1 and the 2 studies, 60 and 120 patients, severe calcific lesions, mostly successful with 30-day MACE rate of 5 and 7% only. So how do we choose which device or technique to use? Again, based on imaging, if possible. Sometimes the imaging catheter will not cross a very tight lesion, in which case you have to choose depending on the fluoroscopic appearance. However, if you have deep calcium, the intim is not calcified, you can use your cutting scoring balloons, and it usually works fine. If you have nodular eccentric calcium, a more physical atherectomy approach is suited. If you have superficial calcium, which is in a ring, either of the atherectomies or the intravascular lithotripsy are well suited for this. The subset of peristent calcium with underexpanded stent, laser atherectomy is probably the most suited for that. Thank you. I'll take any more questions.
So day to day, you have multiple choices. Shockwave lithotripsy is not yet approved in the United States, and it's available for use in the periphery. So, how do you choose between orbital and rotational atherectomy? I think those are kind of the two head-to-head technologies.
For me, the choice is more about whether it's a diffuse lesion and how tortuous the vessel is. So if it's a short focal lesion or an ostial lesion, usually go with rota. If it's a longer lesion, if it's a bendy circ, I feel more comfortable using orbital because I can cross the lesion and then I have more control pulling the crown back rather than going forward. So I don't have a jump across the lesion. Those are my usual kind of deciding points between rota versus CSI. Also, if you have a bigger vessel, there's at least a theoretical benefit that you can sand more and use the same crown instead of having to upsize your rota bar to go there.
So I have a question for you. How about the proximal, for example, proximal LAD or proximal RCA with very severe calcified superficial and deep calcifications? So how about the indication of the IVL for this kind of patient? Because it's very dangerous when we put the balloon there and then we stop the flow. So what is the mechanical support in order to support for the procedure?
I mean, it depends on the patient, right? So if you have a normal EF and normal EDP, if you're doing an ostial RCA and the left side is good, then I don't think you need any mechanical support. But if you're doing a case where, the LAD is gone and the RCA is the last remaining vessel, or the circ is diffusely diseased and you're doing the RCA and the EDP is 35, then yeah, you probably do need mechanical support for that. You have to be quick. I have only done one case of coronary IVL, and that too kind of off-label using a small peripheral balloon. So not that experienced in it, but I don't think it'll be any different than you doing your usual. You'd probably give a few pulses and not try to give a whole lot of pulses in one go if you're dealing with that sort of.
Coming to orbital atherectomy, my issues with it is, especially in those with fluid overload, end-stage renal failure, and things like that, the fluid infusion rates are quite fast, pretty high. And it's not like a rota infusion. And especially when you have a long lesion, it takes you very long to, bring down, and you have a lot of fluid, 2 bottles will finish, before you know it. Any comments on that? So I tend to prefer rota in this group of patients.
When I started using CSI, I used to use the amount of drip that the reps would give us, with a lot of fluid, as you're saying. But nowadays, I've slowed it down. I don't use as fast a drip as I used to. I kind of use it the same way as I use rota, but I do stop more. I do not go 4 centimeters in one go. I would go slowly and find if there's 2 lesions, and I'll treat one with a couple of passes back and forth, and then stop, then go to the second one and go to
Yeah, with all these techniques and technologies, the longer they're around, the more variations in technique that you're going to find. And I think the greatest thing that's happening now is the emphasis, so that we really know what we're doing with this. So can we move on to the next talk? I'm afraid we're going to fall behind and not have enough time for discussion at the end.
This 10-minute presentation, Managing Stent Regret, or welcome. To this 10-minute presentation on managing stent regret or underexpanded stent and calcified lesions. My name is Kechinyere Ijama. This presentation will discuss off-label use of intracoronary devices. For this 10-minute presentation, we'll review a short case presentation. We will look at etiologies and clinical scenarios for underexpanded stents. And finally, we'll review a management algorithm for underexpanded stents and calcified lesions. Once again, this presentation will mention off-label use of percutaneous coronary interventional devices. So here's a case presentation which was performed by one of my colleagues. An 87-year-old woman presented with worsening shortness of breath in the setting of aortic stenosis. As shown in video A, there is a heavily calcified lesion in the LAD. The operator recognized this and performed rotational atherectomy of the LAD with a 1.25 millimeter rotational atherectomy burr. Post-rotational atherectomy, balloon angioplasty with a 2.75 millimeter non-compliant balloon was performed as shown in video C. Look at the balloon in video C. There is dog boning of the balloon. The operator decided to proceed with deployment of a 3.0 by 16 millimeter drug-eluting stent, as shown in video D. Look at that stent balloon in video D. The stent balloon is underexpanded. Not shown in the video images, the operator subsequently performed post-dilatation of the stent with a 3.5 by 8 millimeter non-compliant balloon, and the balloon would not fully expand. The final images, as shown in video E, show an area of stent under expansion. Question: what would you do about the stent in video E? Would you say, good result, treat medically, or would you perform further lesion modification techniques? So let's talk about the potential causes for an underexpanded stent. The first, unrecognized calcium. The second, fibrocalcific lesions. The third, suboptimal plaque modification of a heavily calcified lesion as demonstrated in our case presentation. The fourth, stent deployment in a non-dilatable lesion. Pre-PCI imaging, whether with IVUS or OCT, can assess the extent or burden of calcific or fibrocalcific lesions, and this information can guide lesion modification techniques prior to stent implantation. It is important to recognize that the risk for an underexpanded stent is a dog boning balloon, just as seen in our case presentation. I'm going to repeat that. It is important to recognize that the risk for an underexpanded stent is a dog boning balloon, just as seen in our case presentation. So here's a management algorithm for underexpanded stents in calcified lesions. The first strategy is a non-compliant balloon. The second strategy is atherectomy, and this can be rotational atherectomy or laser atherectomy. The third is intracoronary lithotripsy. Now, before we do a deep dive into the management algorithm, I'd like you to think about the underexpanded stent as potentially presenting in two clinical presentations or scenarios. The first clinical scenario is a freshly deployed new stent that would not fully expand. Remember our case presentation. The second clinical scenario is a previously deployed old stent that is not fully expanded. And these can present either as in-stent restenosis or stent thrombosis. So let's return to a management algorithm for the underexpanded stent. The first strategy is a non-compliant balloon. Take a non-compliant balloon, either the same size as a stent or just slightly bigger in diameter, and watch out for the length of that non-compliant balloon, and post-dilate the stent at high pressures of about 20 to 24 atmospheres of pressure. Watch out for coronary perforation, coronary dissection, or balloon rupture. You may ask, what about cutting and scoring balloons? Can these be used for managing stent regret? For atherectomy balloons, that is, cutting or scoring balloons, these cause direct fracture of luminal calcium, and ideally these should be used prior to stent implantation in order to provide maximum contact between the cutting balloon and the plaque surface. Outside of the US, super high pressure non-compliant balloons are available. These super high pressure balloons are designed to deliver very high pressure inflations of up to 35 atmospheres of pressure, and these super high pressure balloons can be used to manage stent regret. The other management strategy is atherectomy. For the underexpanded stent, there are two ways of doing this. The first is a rotational atherectomy, and the second is laser atherectomy. For rotational atherectomy, this uses a diamond-tipped burr which comes in different diameters and under high-speed rotation debulks calcified lesions by fracturing plaque calcium. Watch out for burr entrapment, which can occur from the stent struts. When doing rotational atherectomy, it is important to use slow, gradual pecking movements, less than 30 seconds per run of the burr, as this helps reduce the risk of burr entrapment. Also watch out for excessive stent damage, as rotational atherectomy can cause partial removal of the stent struts. Also watch out for distal embolization and no reflow phenomenon due to microvascular embolization of plaque debris. Remember, rotational atherectomy is relatively contraindicated in thrombus-containing lesions due to the potential risk of distal embolization and no reflow phenomenon. The other option for atherectomy is laser atherectomy. This uses catheter-emitted pulses of ultraviolet light to modify the lesion. Unlike rotational atherectomy, the laser catheter does not need to cross the lesion, neither does it need to come into direct contact with the lesion to cause plaque modification. Laser atherectomy can be performed without contrast, or it can be performed with simultaneous contrast injection. When performing simultaneous contrast injection, the thermomechanical effect of laser atherectomy is magnified, and it is able to modify the calcified plaque beneath or underneath the stent struts, even without coming into direct contact with the plaque. Watch out for coronary perforation when performing simultaneous contrast injection with laser atherectomy. If performing simultaneous contrast injection with laser atherectomy, we recommend using a small 0.9 mm laser catheter to minimize the risk for coronary dissection or perforation from the cavitation of bubbles. Laser atherectomy can be used in lesions containing thrombus. The third management strategy is intracoronary lithotripsy. This is an off-label use of this device. Intracoronary lithotripsy is a new technique which uses a balloon catheter system to deliver high-power acoustic shock waves or sonic pressure waves which disrupt calcified lesions. The balloon catheter delivers one cycle of 10 pulses for a total of 8 cycles per catheter. It is not yet FDA approved in the US. It has the advantage of differentiating between soft tissue and calcium. It can act on both superficial and deep calcium. It acts on the calcium beneath the stent struts. Once again, this is off-label use. And another advantage is that it reduces the risk of distal embolization by entrapping the fractured calcium within the vessel wall. So in conclusion, prevention is better than cure. Optimize calcified lesions prior to stent deployment. Intracoronary imaging is your friend. Use it. Know your tools for modifying calcified lesions, non-compliant balloons, atherectomy, and intracoronary lithotripsy. Thank you for listening to this 10-minute presentation on managing stent regret or underexpanded stent and calcified lesions. I would like to acknowledge my mentors. Thank you.
So can I ask a question? So can we use the IVL for the recently stented segment, especially with the DES? And if yes, what is the effect of the IVL on drug-eluting stent?
Great question. Once again, this is an off-label use of this device. It's not meant for managing stent regrets, but based on case-based reports, it has been used. I've not yet seen in freshly deployed stents, but it has been used in underexpanded stents. So I can't give you a very clear answer as to if newly deployed stent, if you can use it, because once again, it's also off-label.
Thank you.
Some of my colleagues in some of the countries like Singapore used it, and there is a worry of polymer rupture. I've not heard of any stent being fractured, but there's a real worry because the amount of force delivered can be up to 50 atmosphere, the shock wave. So there is a worry, but sometimes you have no choice.
Yeah, again, with all these new technologies, we can report successes, but there is that concerns about what it does to the polymer of the drugs. And also, I think that we really need to look at the lesion types and really understand what lesion types and how each of them responds to the different technologies. We talk about that further. Why don't we finish up your talk, Dr. Ranga, and then we'll have a full discussion.
Okay. Can you see my slides?
Yes.
Okay. I will go quite quickly how to deal with complications of calcified lesions. I'm from Sedang Hospital, Malaysia. It's a public hospital. We do about 3,500 PCIs per year. And this is my new building. Hopefully it will be up. Now we have 3 cath labs. I personally do about 120 rotas per year and maybe about 30 orbital arterectomies. And the key to success in arterectomy is like what Dr. Lee has mentioned just now, and I have a lot of overlap with his lectures, is proper planning and patient selection. Imaging is pivotal, IVUS, OCT, proper technique, and of all things, avoid complications. And the complications of rotablation can be enzyme leak up to 4 to 6%, dissection 5 to 10%, which also includes abrupt closure and slow flow. And the worrying thing is perforation is about 0.5%. And the other thing is burr entrapment, although they say it's rare, but if you do enough, you definitely see more. And sorry, I'm trying to go to the next slide. And complications, well, you have AV block, you have slow flow or no flow, which can be a collective of spasm, dissection, embolization, perforation, burst stuck, or the Caucasus phenomenon. But sometimes you can have one, if you're lucky, or all of them simultaneously. Sometimes when your burr gets stuck, it also perforates, and you have slow flow, and that can be a real nightmare. So AV blocks in the past, whenever we do RC or circumflex rota ablation, we worry about that. We used to put in a temporary pacemaker to preclude bradycardia and so on. But you must be aware of, I've seen perforation from the pacemaker catheter. Although people say you can use a low profile tip pacemaker catheter, but nowadays we actually more experienced, and I hardly have used for the last 3 years any pacemakers. So you can actually circumvent this by burring at maybe lower speeds, shorter burr time, and you can actually give, I usually treat with atropine. I give 0.5 milligram before burring, or you can use aminophylline infusion, and most of the time you do not need any temporary pacemaker. And as I mentioned earlier, shorter duration is important, because what I realize is the longer the burr time is, you generate a lot of heat, and with heat you can have slow flow bradycardia. And although a lot of them talk about packing technique, for me sometimes it can be quite aggressive when I see people packing. Like what Dr. Lee has mentioned, I now use what I call a gentle touch and go touch, contact slowly, and then you'll get to know your lesion. The other thing is slow flow, no flow. It's mostly due to technique. So arteriomatous debris embolism is quite marked in prolonged rotor ablation. So use small burr sizing, intermittent ablation, avoid significant decelerations. Of course, your optimal DAPT is important. TP2B3A I use sparingly. And of course, the usual treatment for with vasodilators, bradycardia with atropine. And the other thing I like to mention is when you have hypotension, in a poor EF or poor LV function, you might consider upfront impella LVAD. We do not have this in Malaysia or this region. I basically use intra-aortic balloon pump. So try to preempt this if you do proper patient selection. So when it comes to dissection, I think like what I mentioned, operation technique influences dissection rate greatly. And the presence of dissection is not an absolute contraindication for rota. Over the years, I realized if you have no choice, you can dissect. You can rotablate in dissections, but be careful. Large dissections can be contained perforations. And I actually avoid guide wire bias by using a floppy guide wire most of the time. I don't use extra support, and the management is similar to the other conditions you see. When it comes to perforations, most of the time it could have been avoided. It's oversized spurs, guide wire bias, severe angles, improper technique. Now with, and most of the time it's not the burr which causes the perforation. Sometimes it's the balloon, post-dilatation with a large balloon causes perforation. So trying to remove the burr, leaving the wire in place can be difficult. Most of the perforations, the burr gets stuck. And here I'll usually do ACT. If it's a bad perforation, I'll actually consider heparin reversal on the spot, monitor hemodynamics, make sure your covered stents are nearby. Whenever I do high-risk difficult cases, I actually keep my covered stents nearby. I don't go and at that time go and look for it on the shelf and things like that, and be very adept at doing pericardial synthesis. And tortuosity and rotablation. Whenever you have tortuous calcified lesions, it's an ominous, dangerous combination. Wire bias can occur, as you can see in this cartoon, increase the risk of dissection, perforation. I have a case like this, I'll show you, but thank God it didn't perforate. So although they say differential cutting doesn't cut the normal tissue, but ablation does occur if the tension of the wall exceeds the elasticity of the vessel. So this is a case published looking at the RCA. You can see there's a lot of wire bias, 3 points of bend, and they actually went in with a 1.25 millimeter rotablator, and you have perforation. This operator was pretty quick. He managed to actually put in 3 covered stents, as you can see in the middle, proximal, distal, and then he actually used another 2 more bare metals. And what's interesting is, if you see at 2 months, basically he just created a new conduit across. The RC is just, the original RC is just a shell. I can tell you this is a miraculous save. Most of the time you're not that lucky. I'll just show you a case by one of my colleagues where, you can see a straightforward, not straightforward, but a straight LED, heavily calcified, tortuous. So they went in with rotablation. This is the initial run of rotablation 1.5 burr. And you can see in the next picture, what happened. You can see here the sudden rotablation jump, and then he got stuck. He jumped and he got stuck. And this operator did not take subsequent shots, and he actually went and continued ablating happily. And then the patient became hypotensive, and this happened. So most of the time we tend to use 6 French, but if you're new and so on, use 7 French so you can inject more. And here all hell can break loose. So you have to be careful. So this is what we also worry about, guide wire bias. So when you don't do imaging, the burr actually follows the guide wire, preferentially cuts the inner wall of the vessel. With imaging, you can exactly see where the burr is going to travel. So one way is when you have very extreme tortuous vessels, you might consider pulling back the wire to decrease the wire bias. But this sometimes decreases your pushability, and it'll be more difficult to push the burr down. So it's a give and take, how you want to do it. So this is an angulated case I did about 3 weeks ago. You can see the LED, there are a few humps. And my IVUS catheter couldn't pass the first lesion. It's very tortuous. And then I wanted to reach here. So in the end, used the 1.5 millimeter. But you look at, it took about 10 burr to just reach here. It's quite prolonged. But look at the jump. And if you look at the jump, it just went straight. But if you look at the vessel, it's actually angulated. And I was praying at that point of time, nothing bad will happen. The patient was stable. And this was the next thing. We can see it. Some people can say it's a bad dissection, but I think it's a contained perforation. I was just lucky, I escaped with the white of my teeth, you can say. And this is the final results. I managed to get the stents in, a patient was stable. So these are the things we worry about. And I think Dr. Lee has talked about halfway rotablation is something to consider in these type of lesions. So entrapment of the rotabler burr is like basically a nightmare. And this is when your manual traction is unable to retrieve your burr. And basically the simplest method is to retrieve burr is just pulling. And pulling means what you're comfortable with. Nobody knows what force you use, but do not snap it. You can use diagonal, intermittent bursts and so on. So if this is not successful, but remember, you might perforate the proximal segment, extreme forces might fracture the shaft of the burr. You can actually cause the guide catheter to actually jump in. So you have to be very careful of this. The other thing I'd like to point out, the burr that gets stuck the most is the 1.25 millimeter burr. You know, maybe it's because of the shape. Look at it. You know, it looks like a bullet. The rest looks like a rugby. And most people think using the smallest burr helps them by not getting stuck. But so now in my practice, 95% of my burrs are at 1.5. And when the burr gets stuck, you must understand the back portion doesn't have any diamond particles. You cannot cut backwards. So why that happens? When you cross the lesion with too much force, you pack too hard, you know, presence of acute bend before the lesion. The presence of mild stenosis before the target lesion, sometimes the burr goes through, but the shaft can dig it like a cheesecake effect. Or when the rotor wire alters the vessel morphology and spasm, all this can happen. How to avoid a trap burr? Proper attention. Never force a burr down. Do not have high deceleration more than 5,000 RPM. Keep your burring short, less than 15 seconds. Once, if you find you're comfortable, you can actually go longer and longer. But usually I'll keep my burr 10, 15 seconds or less. Mild stenosis, beware. And also the burr might get stuck even after final ablation during polishing if you have bends. So be careful. So there are various algorithms. What happens is you can actually use a ping pong, getting a second guide catheter in. But if the patient is unstable, you need to do things quickly. You need to actually cut off the shade, the drive near the drive console, and try to recross and put a balloon. So the first thing is try to pull back the system, fix the advancer node at the right end, open the TUI, slightly rotate the guide. So whatever force you're comfortable with, if that fails, try to give some vasodilator, dilate the vessel, try to insert another wire along the burr, or deep engage the guiding catheter so this catheter and burr is more coaxial. And then I'll tell you how to do the mother and child technique. There are various ways, but you must cut the system if it's not an 8 French guide. And you can advance a microcatheter. Most of us now advance guide extension and so on. Some people even use snares. So this is what happens in 8 French. You can actually get another balloon and guide catheter in. But in 7 French with a drive shaft, you cannot do that. And that's why you need to cut as close as possible to the console, take the sheet, and then you can actually advance the guide extension whatever over this contraption, and then you can get it in 6 French or 7 French as a bailout, you know. And most of the time, my 6 French, I use a Medtronic EBU, which is 0.071 inch. So you can even get technically 1.75 through a 6 French if you use that. The other thing I like to caution you is wire complications. So beware when you can't see, sometimes the wire is so tiny, you don't see the loop, and then you go dynaglide in, you can actually cause the thing to cut and also injure your ostium. The other thing is I've seen wire complications inside the coronary, you push too hard, you get a kink here, and then this can even cause perforation and so on when you actually get a guide in. So these are the things. So these are the ways of removing entrap burrs. You can use a conquest wire. You can use the ping pong technique, you know, and this is using a snare by disassembling the rotablator like what I showed you earlier. And if all else fails, final answer, you have to get the surgeon in. So you have to actually preempt the surgeon. It's going to be nasty and so on. So take home message, proper planning, patient selection. If you don't go for the high-risk patients, imaging is pivotal, proper technique, and avoid complications. Thank you. Okay, I'm done. Yeah, any questions?
So I have a question that just a comment about the communication, because when we pulling, I saw one of my colleagues that it caused a lot of dissection at proximal LED and left main, and I had to put the standing. So when we pulling the device out, So we have to keep in mind that the gradient can suck it in and cause the dissection at the proximal vessel. And another technique mainly used in the entrapper is they put the wire in underneath the burr, and then we do the dilatation in order to make it bigger at proximal, and then pull it back. That also the good technique for taking up the entrapper.
Yeah, the problem will be is trying to deliver the balloon and the wire in the same guide, and if you use 6 French, you'll be crying. 7 French, maybe a bit lucky. So, bringing the ping pong guide and things like that.
Yeah, we use the ping pong technique. Yeah, ping pong.
Yeah. So, and sometimes when you pull hard, especially with the perforation, the other thing is you also tend to lose the wire. Happens, sometimes in bad dissection. So these are the realities. And these complications don't happen one at a time. They happen all at one go, trap perforation, slow flow.
Yeah. Agree.
Well, it's late where I am, but your talk woke me up with all the complications, got my eyes wide open. I kind of miss seeing the fellows in the room or who's attending, because I'm sure their eyes are wide open too. These are all the things that have happened with rotablader and scared people from performing rotablader over the last, 2.5 decades since it's been here. So has every complication happened to me? The answer is yes. Let me just tell you, I've never sent anybody to the operating room to remain a trap burr. I've always gotten them out. I've gotten called by many people across the United States by the reps. Says, what do we do? And we could spend a whole session just on terms of different techniques, and you cover them really quickly. And I think it's hard to remember all of them. It's good to have a Boston rep available when you're doing a case and get someone you can call, and somebody like myself, they can contact to kind of talk you through it. Nowadays, with
Hội Tim mạch Việt Nam trân trọng giới thiệu chuỗi hội thảo trực tuyến về tim mạch.
Tâm điểm 2020, nơi cập nhật những tin tức mới nhất về chuyên ngành tim mạch học.
Nơi trao đổi, tương tác đa phương tiện với những chuyên gia tim mạch hàng đầu về những chủ đề khoa học và thực hành mới nhất của chuyên ngành.
Nơi tổng hợp những kiến thức về tim mạch học cho các bác sĩ và bệnh nhân.
Đồng hành, đồng sứ mệnh, Tâm điểm 2020.
Hứa hẹn sẽ là diễn đàn trực tuyến hot nhất được phát trực tiếp trên các nền tảng trực tuyến của Hội Tim mạch Việt Nam. Tâm điểm 2020 phát sóng 9 giờ đến 10 giờ sáng, thứ Bảy hàng tuần bắt đầu từ ngày 13 tháng 6 năm 2020.
Ấn phẩm truyền hình hàng đầu của Hội Tim mạch học Quốc gia Việt Nam.
Tin tức chắt lọc, cập nhật, thấy gì trong dòng thác thông tin.
Kiến thức chuyên sâu,
giá trị thực tiễn.
Tâm điểm 2020.
Đồng hành, đồng sứ mệnh.
Hội Tim mạch Việt Nam trân trọng giới thiệu chuỗi hội thảo trực tuyến về tim mạch.
Tâm điểm 2020, nơi cập nhật những tin tức mới nhất về chuyên ngành tim mạch học.
Nơi trao đổi, tương tác đa phương tiện với những chuyên gia tim mạch hàng đầu về những chủ đề khoa học và thực hành mới nhất của chuyên ngành.
Nơi tổng hợp những kiến thức về tim mạch học cho các bác sĩ và bệnh nhân.
Đồng hành, đồng sứ mệnh, Tâm điểm 2020.
Hứa hẹn sẽ là diễn đàn trực tuyến hot nhất được phát trực tiếp trên các nền tảng trực tuyến của Hội Tim mạch Việt Nam. Tâm điểm 2020 phát sóng 9 giờ đến 10 giờ sáng, thứ Bảy hàng tuần bắt đầu từ ngày 13 tháng 6 năm 2020.
Ấn phẩm truyền hình hàng đầu của Hội Tim mạch học Quốc gia Việt Nam.
Tin tức chắt lọc, cập nhật, thấy gì trong dòng thác thông tin.
Kiến thức chuyên sâu,
giá trị thực tiễn.
Tâm điểm 2020.
Đồng hành, đồng sứ mệnh.
Từ năm 1992,
Hội Tim mạch Việt Nam trân trọng giới thiệu chuỗi hội thảo trực tuyến về tim mạch.
Tâm điểm 2020, nơi cập nhật những tin tức mới nhất về chuyên ngành tim mạch học.
Nơi trao đổi, tương tác đa phương tiện với những chuyên gia tim mạch hàng đầu về những chủ đề.
Hội đồng khoa học của các kỳ đại hội tim mạch thế giới. Năm 2008, Hội Tim mạch Việt Nam đã tổ chức thành công Đại hội Tim mạch ASEAN lần thứ 17 với hơn 3.000 đại biểu tham dự, được cộng đồng tim mạch trong khu vực và thế giới đánh giá cao. Bên cạnh đó, Hội còn tích cực tham gia các hoạt động tư vấn, giáo dục sức khỏe cộng đồng trên các phương tiện truyền thông đại chúng. Tổ chức các hoạt động đi bộ đồng hành hưởng ứng Ngày Tim mạch Thế giới, thu hút hàng ngàn người tham gia hướng tới mục tiêu vì sức khỏe tim mạch.
Hội Tim mạch Việt Nam
cùng chung sức chung lòng vì những trái tim khỏe.
Năm 1992, Hội Tim mạch Quốc gia Việt Nam được thành lập, đánh dấu bước phát triển mới của ngành tim mạch Việt Nam.
Hội Tim mạch Việt Nam là nơi tập hợp các bác sĩ trong chuyên ngành tim mạch để cùng nhau chia sẻ kinh nghiệm, cập nhật những cái thông tin mới nhất trong lĩnh vực chẩn đoán và điều trị các cái bệnh lý tim mạch.
Hội tập hợp hơn 1.300 hội viên với hàng trăm giáo sư, phó giáo sư, tiến sĩ. Gần 50 hội viên danh dự là các giáo sư, chuyên gia tim mạch nổi tiếng trên thế giới. Có hội đồng khoa học uy tín với thành viên là các chuyên gia đầu ngành trong lĩnh vực tim mạch. thành lập được 4 phân hội chuyên sâu bao gồm phân hội tăng huyết áp, phân hội siêu âm tim, phân hội tim mạch can thiệp và phân hội nhịp tim Việt Nam.
Hội Tim mạch Việt Nam là một cái hội nghề nghiệp chúng tôi rất chú trọng.
Nào lên hình thì em bảo thầy bắt đầu.
Should I start, Dr. Rajgopal? Or...
Okay, should we start?
Yeah, it's 2:30. Hello, I'm Tanvir Rab from Emory University in Atlanta, and thank you very much for the invitation from your society for co-chairing this meeting. My co-chairs are Dr. Hui and Professor Shaolin Chen from Nanjing, China. And we want to be very much on time. So without much ado, our first presenter is Dr. Hui, who will discuss the 1 or 2 stent approach for corneal bifurcation lesions. Dr. Hui.
Yes.
Asia Pacific. Hello, my talk today is 1 or 2 stent approach for bifurcation lesion. So my talk based on the 14 consensus document from the European Bifurcation Club and also the Asia Pacific consensus document on bifurcation intervention. So the EBC principle includes keep the procedure simple and safe. Second, understand and respect the original bifurcation's anatomy. Third, optimize the flow and function of bifurcations following the intervention. And the last one, limit the number of stents which should be well opposed and expanded with minimum overlapping. So the first question is that the bifurcation lesions, is it a true one? Based on Medina classification, must be a 111, a 101 or 011 classification. And this is the definitions of a complex bifurcation lesion. Must be a true bifurcations with lesions in both main and side branch. The burden of a severe arterioma extended of more than 5 mm from the side branch osteum. The large side branch, at least 2 mm in diameter and supply a large viable myocardium. This is the apex recommendations for bifurcations intervention. Patient factors should be considered for the holistic approach. Selection of bifurcation strategy should be systematic, and the significance of a side branch will be based on anatomical, physiological, clinical, and prognostic aspect. And this is some issues of intervention. First is the complexity of patients. Is patients a diabetes? The LV function is good enough or not? And patient is in high bleeding risk or not? Second thing is how complex is the lesion? Maybe based on the syntax score. Third one is complexity of procedure, the angle between the main and the side branch, the number intended to implant, the size of the stent, and is there any risk of stent failure, of the rupture of the vessel during. One of the most important one is the competence, the skill of the operator. So back to the question of 1 or 2 stent for bifurcation lesion. This is the data from the BBC study 10 years ago. You see in a simple approach, 1 stent, the primary endpoint of death, MI, and TVF is only 8%, compared with 15% of the complex one. And the conclusions from the BBC study is that two-stent techniques result in a higher rate of in-hospital and 9-month MACE, largely driven by MI. The procedure of two-stent is longer and X-ray dose is higher. And the one-stent technique should remain the preferred strategy in majority of cases. With the 5 years result of Nordic bifurcation study, conclusion is that after 5 years of follow-up, the clinical outcomes of a simple stenting means one stent technique at least equal to the complex strategy, means two stent for both main and the side branch. So if you have a big side branch, it means at least 2.75 mm in diameter. Makes any sense? This is a 2 years result from the Nordic Baltic bifurcation study 4, with the primary endpoint of 6-month MACE and also angiographic in 8 months follow-up. The stent used in the study is rather old. In first half, patient is cypher-selectless, and after that they use a Zymes-V, the first generations of family. So at 8 months, the two-stent technique looks better in angiography. 5.2% in the side branch re-narrowing in compared with the 20% of the one stent technique. But if you see MACE, the composite endpoints of death, MI, TLR, and stent thrombosis, the difference is not significant. 8.3% in two stent and nearly 12.9% in one stent. And even death, cardiac death, MI, stent thrombosis or TLR, there's no significant difference in between one or two stent techniques in bifurcations lesions with big side branch. This is the pool analysis of Nordic bifurcation study and also the BBC. The composite endpoints almost the same in between the two techniques. The conclusion is that the complex approach does not appear to be beneficial in more anatomically complicated lesion. So far, the only technique makes difference in between the two stent or one stent technique is decay crush. When you see this is left main interventions, and in both simple lesions or complex lesion, the TLF at 1 year's follow-up of decay crush is significantly lower than one stent provisional stenting. We'll put all of bifurcations study together in a meta-analysis. You see mortality. The two stent technique is higher than the blue bar of one stent technique. And this is also, we see the components of MACE. MI, TLR, stent thrombosis is not significantly different in between the two strategies. The 2018 guidelines of ESC put the 1A indications for one stent provisional stenting for bifurcation lesion. So if you have bifurcations, you need to decide if your side branch is important and with or without complex disease. If side branch is important and the disease is not complex, the standard approach is provisional stenting. If the side branch is important and complex, then you can consider of using an elective two-stent strategy. When you assess the side branch, the importance of a side branch is the length of more than 73 in CT scan, like first diagonal or the OM, because mostly it supports of at least 10% of myocardium. The important side branch is a large one, and complex disease is defined as significant stenosis of the ostium of the vessel, the S10 disease of more than 5 mm into the side branch, and it is difficult to wire both branches. You should wire the lesions, you should wire both, because you will have to change the angle of bifurcations, and you can keep the side branch open. In case of occlusions, will mark the side branch positions. The more difficult lesions should be wired first in order to avoid the wrapping of the wire, and try not to pushing the wire too far in the main branch, because you want to maintain the shape of the tip, so that you can use after that to recross the side branch again, and also reduce the risk of dissection or perforation. So if you have a gel wire, it can have functions of anchoring to help to intubate deeper of the guiding to support balloon or stand to cross into the vessel. In some cases, it can use as a rescue procedure. When you pass a very small, very low profile balloon, dilate the side branch to have some flow when the branch is occluded during the main vessel standing. The main vessel should be pre-dilated first to decide the length of the stand for a safe port after that. For the side branch, the routinely pre-dilatations of side branch is not recommended unless your side branch test is very difficult, or you have calcified lesions there. You may need a rotablator, or the flow in the side branch is compromised after your wiring. After after pre-dilate, then how to choose a stand for the main. The stand diameter for the main vessel should be selected according to the size of distal main branch based on the Murray's law. And after you inflate the stand, you can optimize the proximal segment of the stand with the port technique with a Nancy balloon, like the picture in the right hand side. So why you need a port? A port help you to optimize the stand deployment, restore the geometry of the vessel. You can widen the stand strut at the side branch ostium and facilitate the rewire side branch. And then it also prevents the side branch wire from crossing behind the main branch when you rewire the side branch. In some operators do not only one port, but also the report. So they put a stand here, like in the B, after port, and put a balloon in the side branch, after then finish the procedure with a report, a second plot with a compliance balloon. And this one have early short-term outcomes, good one. When you treat the main branch, sometimes you see a pinching into the ostium of the side branch, and normally you don't need the second stand. You only need a kissing and then port, and or after that you do a report balloon in the side branch, and after that report in the main branch. And also the recommendations of the apex, you the kissing balloon technique only perform when the clinically important side branch is compromised during the standing. In some cases, you may need a second stand. After your port, your import, your report, the flow of the side branch is still poor, and you may need a second stand. You can use a T-stand technique, tap technique of culotte based on the wiring. So the take-home message for my talk is that if you have an important side branch and the lesion is not very complex, the provisional stenting should be the default strategy. You should wire both branches, do the pre-dilatations of the main. After that, stand the main vessel with the stand diameter selected based on the distal main branch. After that, the port is a must. And then in some cases, you may need a kissing port, a side port, a second stand. Thank you for your attention.
Thank you very much, Dr. Hui. That was pretty comprehensive. The one thing that we'll go into discussion, we'll take points from your talk. about how you really define complexity. So Dr. Chen is having difficulty. He just sent me an email connecting. So can your technical support group connect with him? Somehow we cannot get onto the link. So Dr. Raj Gopal will be the next speaker. He'll talk about challenges in evaluating side-branch stenosis post-provisional bifurcation stenting.
Thank you. Let me just get my slides up. Right, thank you. Hui, that is a great talk. So my talk follows on very nicely from Dr. Hui Din's talk earlier. He very eloquently explained that provisional side branch stenting should be the default option in most patients with bifurcation disease. So my talk is going to be on challenges in evaluating the side branch stenosis after you have stented the main branch. So we are in this position. We have already wired both the branches. You've decided that you don't need an upfront two-stent strategy. The main branch has been stented and you optimize with a pot in the main vessel. And at this point, we need to decide if we need to do anything at all about the side branch. So we need to evaluate it and decide if we need any further intervention. And these are the challenges that I can think of in this situation. We need to assess the significance of the side branch stenosis, and we need to make a decision based on the stenosis as well as the vessel that we're dealing with. And we have to come up with the right treatment strategy for each situation. So we'll go through each of these. So first, we need to look at the significance of the side branch stenosis. It could be angiographic, physiology, or imaging. So the first thing you say is if there is TIMI3 flow or not. If there is less than TIMI3 flow in a significant vessel, and if the patient, if you ask the patient if there is chest, if he has chest pain, and you look at the monitor if there are any ECG changes. If we have less than TIMI3 flow, chest pain, ECG changes, you are mostly compelled to treat the side branch. It could be just side branch dilatation with kissing balloon inflation, or if it's a bigger vessel with longer disease, you may have to put a stent in. When there's TIMI3 flow, then you look at the significant stenosis. If it is significant, you do not always have to intervene. You need to think about it a bit more, and we'll talk about that. So angiography is your first stop. So you need to make sure that you got the right views to assess the side branch osteum. We have to remember that this is a 3D structure, and we need to avoid foreshortening. We need to avoid overlap. So there are different views that are suitable for different parts of the coronary anatomy. There's a left main bifurcation. We have to have an RAO caudal or a spider view, LAO caudal view. Sometimes a PA caudal is good as well. For an LAD D1 bifurcation, if steep PA cranial is quite good, you need to go about 35 degrees cranial at least to get, sometimes to get a good view of the diagonal. Depends on where the location of the diagonal bifurcation is. For the circumflex OM bifurcations, most caudal views are quite good. And if it's a dominant circumflex with a very distal significant OM, the cranial views are good as well. And for the RCA, of course, for the distal bifurcation, we use a PA cranial view. So once you've got a good angiographic view and you're still worried about it, you could consider FFR. So if you think that it's more than 75 or 80% ostial side branch stenosis, you can think about FFR. Often, as you know, this is carina shift, and this could be temporary. I mean, often once you've done ballooning and stenting, you could have some vascular wall edema, you could have minor intramural hematomas, you could have some plug shift as well, but some of this could improve with remodeling later, so you don't always have to jump in to PCI. This is a well-known study from Dr. Koo in Korea, where he looked at patients with jail side branch with stenosis compared with FFR. So looking at this, what we know is of all the stenosis with more than if the stenosis was less than 75%, they all had a negative FFR. So you don't have to worry about a 50 or 60% stenosis. Even if you had a more than 75% stenosis, only about 27% had a positive FFR. So only 27% had functionally significant stenosis. This could be explained by the oval shape of the side branch ostium, where in some views it looks narrowed, but the overall lumen area may still be adequate. And of course, the significance, the FFR also depends on the myocardium supply, not just the vessel size. And so this has actually changed practice significantly, and we have been less aggressive with intervening on side branches when they are pinched. So to summarize about FFR, if the FFR is more than 0.8, meaning to say it's negative, we can safely defer. If it's less than 0.8, we can consider intervention. We'll talk a bit more about it. But keep in mind that crossing a side branch strut, through the struts into the side branch with an FFR wire can be difficult and has to be done cautiously. Also need to make a point here. If you check FFR before the main branch stenting, and if it's negative 0.8, it does not mean that after the main branch stent, it will still be negative. You may have to recheck because with all the carina shift and plaque shift, the FFR may become positive, and you may want to do repeat the FFR to make sure there is no significant stenosis in the side branch if you're worried about it. Imaging is usually done as a part of side branch intervention. It can tell you about the severity of stenosis in the side branch, about the lesion characteristics and how aggressive you need to be in terms of treating it. And it can exclude dissection, which is quite important. Again, like FFR, we need to be careful not to disturb the stent struts. Generally, OCT gives better images than IVUS, but it also comes at the cost of more contrast. So whatever you're comfortable with, OCT or IVUS, it could help us plan the intervention better. So that tells us about the stenosis significance, and we need to use the data to make our decision. So we need to look at the significance of the side branch itself and decide if you need to treat the stenosis or not. So the top part, we are very clear. Forget about the TIMI reduced flow, you probably have to intervene. But if it's TIMI3 flow and there is significant stenosis, you need to make further assessment. And these are the principles that should govern your decision making. After bifurcation stenting, long-term clinical outcomes are determined by the status of the main branch. Optimal results in the main branch are more important and should take priority over optimizing the appearance in the side branch. Simple words, main branch is more important than the side branch. It makes sense, right? So this is a very useful study by Dr. Kim et al. What they've done here is looked at something called the fractional myocardial mass in major coronary arteries and their branches. On the x-axis, you have all the major arteries and their branches, the LAD and its branches, circumflex, RCA branches. And on the y-axis, you have the percentage of the LV myocardial mass supplied by each of these arteries and the branches. For instance, the left main, if there is a lesion there, it can affect 80% of the myocardium. A proximal LAD can affect 48.8%. A circumflex proximally can affect about 30% and so on. The branches, even the major side branches, the diagonal can affect 11%, and most of the side branches, OM, PL, PDA can affect 11%. You can imagine if that's the case, ramus intermediates can only affect about 6.4%. So in that situation, like a second diagonal or a small OM is unlikely to actually affect a significant part of the myocardium. So this shows us very clearly that the focus should be on getting a really good result in the main major coronary arteries and perhaps the bigger side branches, if at all. So the reasons to intervene on a side branch would be reduced flow or significant stenosis in a major side branch, usually more than 2.5 millimeter, but 2 millimeter and more could be considered, especially if it's supplying a large myocardial territory. So once you've decided it's significant, we have to come up with the right treatment strategy. You've seen the slide by Dr. Huidin before. So this is the process, thinking process. Once you have a good result in the side branch and it's open, you can leave it alone. If the jail side branch needs further intervention, you could think about rewiring and doing a side branch dilatation with a kissing balloon inflation. If you get a good result, you stop there. And if it is still suboptimal in the side branch, you could consider bailout stenting. And this is very important. I think Dr. Huidin made a reference as well from Ormiston's original study in 2006. When you open up a side branch, there is distortion of the main vessel stent in the opposite wall to the carina, and you have to do a kissing balloon inflation to reset the stent and get good apposition everywhere. So never do side branch dilatation without kissing balloon inflation to follow. But the more frequent question these days is, should you routinely do kissing balloon inflation after provisional stenting? It's debatable. There are a few studies that have been looked into it, and they got mixed results. You get generally, sort of looking at all the studies, you get slightly improved results in the side branch, but at the cost of disturbances in the main branch stent. You can have distortion of the stent. You can have the polymer integrity getting disturbed. The drug distribution can be disturbed, and there can be intimal injury. So I think kissing balloon inflation is best reserved for reduced flow and for left main bifurcations because you have a circumflex involved there. And if you do it well. You need to recross to the discal strut, use NC balloons, limited protrusion into the main vessel, and simultaneous deflation. You've got alternatives like mini kissing balloon inflation or a port side port, which is represented here. And Baylor stenting should be reserved for situations where there is less than TME3 flow, significant dissection, long lesion in a large vessel. And you have different options. You have T-stenting or a tap or a clot. So the common options, T-stenting where you have a T shape. If you have a Y shape, you can try a tap or clot. Internal crush is an option. If there's an acute angle where you can't do a T-stenting, size mismatch, you can't do a clot. And if you don't like tap, you can try an internal crush. Final port is mandatory in all these situations. And you have to be extra careful when you've done a tap because you don't want to disturb the neocarina. So drug-coated balloons are a new option now in provisional stenting. They're a good option in significant vessels. You can avoid a second stent, but also theoretically reduce the long-term risk of side branch stenosis. It's often employed before the main branch stenting, but then you might need a final kissing balloon inflation after the main branch stent. If it's done after the main branch stenting, we need to make sure that we use a strut with a pre-dilatation balloon. You don't want to push a drug-coated balloon straight through the stent struts into the side branch, and you have to finish with the final kissing balloon inflation and a pot. Last question, should left main bifurcation be treated special? The answer is yes, because the left circumflex is not a side branch. It subtends a large area of myocardium, so we should have a lower threshold for imaging or FFR and lower threshold for at least a final kissing balloon inflation in the ostial circumflex. So key points. When evaluating a side branch after provisional stenting, the long-term outcomes depend on the main branch. You have to treat the side branch if there is reduced flow. Consider treating the side branch stenosis if it is a large vessel and it's supplying a large area of myocardium. FFR can help establish significance. Imaging can help with planning strategy. Port is crucial, and optimize results in circumflex and left main stenting. Thank you.
Thank you very much. We leave the questions and discussion to the end. I'm pleased that my co-chair, Dr. Xiaoliang Chen, has finally been able to connect. Welcome, Xiaoliang. So, Dr. Hui, would you mind introducing the next speaker?
Yes. So, our next speaker is Dr. Anuruk from Bangkok, Thailand, and his talk will be using of imaging to improve bifurcation outcomes interventions. Dr. Anuruk, please.
Thank you. I think committee already have my video presentation, so let's do it. Thank you. So why we you need me to do live? It's okay.
We need to increase the volume because we can't hear.
Yeah. Hi everyone, my name is Dr. Anurak Jemnukungkit from Thailand. Today I have a topic to present to you is the imaging the bifurcation region, bifurcation PCI. I have no conflict of interest for this talk. So why we need the intravascular imaging? We have to use the intravascular imaging for the pre-intervention assessment. We can get the information of the plaque composition, identify the reference segment, and choose the stent size. After that, we can choose the normal to normal for the stent length and determine the expansion and minimal stent area for the prognosis. And we detect the complication like the malposition, tissue prolapse, a dissection, and also the lethal reference segment. For the randomized control trial, the IVAS XPL showed the benefit at 1 year of the IVAS guided better than the angiographic guided PCI. The number need to treat is quite quite good for we can save one event in the 34 procedure. It's better than the statin, diuretic, beta block for the hypertension, and also ASA, aspirin for the stable CAD. And the benefit of the ayahuasca still consists for the 2 years based on the ADAPT-ES database. In the bifurcation, we can use their imaging for more. We can predict the chance of sideband close from the carina or plaque shift. In this case, this is a case example that I choose for today. Is the multiple disease, the triple vessel disease. We plan for 5 palliative PCR at the LAD, but because from the diffuse disease, we cannot see the good landing zone, the good stent length, and we cannot see the bifurcation clear. So that's why all of these things we can prove it with the intravascular imaging. Like from the static view of this, we can saw that it was quite a fight the critical stenosis, and we cannot pass the IVAS or OCT catheter through this. So we do the rotational atherectomy, and you can see that it's quite difficult to pass 1.5 burr because we do many times the diamond at the tip of the burr was gone. So I have to change to the 1.25 and successful crossing the lesion with this burr. After we successfully pass the lower burr, we do the OCT, and we can identify the normal segment for landing of the stent. We can see the plaque morphology, that we have the adequate bulking or not, and we can see the proximal reference. Other things we can do is we can measurement the osteal length of the lesion, which is the one of the parameter of the sideband loss in this patient. And other things for these three bifurcation, we can see many morphology and predict the plaque shift from here. Other parameter that we can choose is a CT angle, is a carina angle, is the carina tip angle. We based on the Watanabe data, they show that if we have the sideband length less than 1.75 millimeter, and also the carina tip less than 51 degree, it have a chance for crossing the sideband about 82%. Like this case, we measurement 2 parameter at 3 lesion. The distal lesion, the CT angle was 92, and the BP to CT length, the carina tip, and the bending tip is about 0.71. The chance of crossing is about around 30%. And the second lesion, the second lesion, they have the 0 chance, and the circumflex lesion is also 0 chance. So we decided not to protect the sideband with any wire, and we stent it. And this is the final result, and the OCT show that all the entry point of the sideband is still there, not gone. Like this one, we put the 3.0 because the 3.0 by 28, and seconds is a 3.528. So this is the OCT one. It shows that the stent is have the malposition in some area, and we can do the post-dilatation after we see this kind of malposition. For the aneurysmal chain, we can do nothing more than this, but in some area we can do better with the post-dilatation. And after we do the post-dilatation, this is the final result. For the stent sizing, we have to use the information from the intravascular imaging for guiding the the stent size, because when we do the provisional stent, we have a chance to lose the side branch from the carina chip. So we always choose the stent from the distal reference, distal main branch reference, and inflate at the low pressure or under nominal pressure, because we want to avoid the plaque chip like this. And even though we inflate with the low pressure, we have a big position at the proximal part, but we can do the pot to collect this. And this is the provisional technique, and we can use the IVAS guide to have the precise size of the reference vessel. The pot can collect the under expansion and help us to facilitating to pass the wire to the side branch, and also help us to successful kissing balloon. And another thing that we choose the reference vessel, because the angiogram we always estimate the size of the vessel, but OCT we recommend to use the EEL. But for the bifurcation, for the provisional stent we have to choose the lumen, because if you choose other things, we can choose the bigger stent than the lumen and cause the plaque chip. We will lose the side branch from that selection. And another things, when we have the side branch osteo, we have to pull back from the side branch to evaluate the diameter of the vessel, not do the main branch pull back, because we will have the false negative information of the side of the side branch osteo, because it have the IVAS information will get the bigger lumen from this kind of things. Another things that we can use the IVAS is to predict the levi. Like this case, we have the osteo circumflex lesion, and when we put the BVS in this case, we want to pre-cross the line and do the T-stent technique, and we don't want to cross the wire through the start of the BVS. So we can use the 3D software to reconstruction that which area that we cross the wire to the.
I'm sorry to interrupt, but we're going a little over time. So
balloon of the LAD to the left main. Another things of the IVAS is the optimization. We don't have the standard optimization for the bifurcation lesion, but we still use the routine parameter as the IVAS information, like the expansion. We will happy to get 90% stent minimal stent area for the proximal reference in the for the proximal reference lumen for the proximal part of the stent, and for the distal part we also accept the 80 to 90% of the distal reference lumen, and for the side branch we also accept the 90% of the side branch reference. And the other things like the landing zone, we have to normal segment or less plaque burden than 40% and absent of the hematoma, because sometimes we have to aggressive do the dilatation. For my conclusion, intravascular imaging using the bifurcation for pre-PCI assessment and post optimization have a solid evidence base for the better clinical outcome. The imaging of the bifurcation lesion helps us to predict the side branch compromise and help us to choose the stent length. The provisional stenting recommend to use the imaging for the distal reference and followed by pot to prevent the position and under expansion. The special feature of the OCT, like the 3D OCT reconstruction, can detect the malposition and help us for the rewiring to the distal start of the stent or less, and check for the recrossing wire for the outside stent. Thank you very much for your attention. So I think we can discuss after this.
Yes, yes. So in the interest of time, I think we need to keep moving. Shaolin Chen, do you want to introduce the next speaker?
Yeah, thank you, Terry. I think I could not find the agenda. So can you
okay, sure.
Can
So next speaker is Dr. Rasi Moran from USC South Carolina, who is going to discuss how to get the best results with DK crush technique. Rasi?
Do you need me to do a live presentation? Let's give them a minute. Greetings. Thank you so much for Sky for giving me this wonderful opportunity. I will be talking about unprotected left main PCI, basically distal vessel bifurcation. My patient is a 72-year-old male with known AAA, which measures about 5.6 centimeters, comes to the with unstable angina. He has a history of a diagonal stent placed in 2017. Echo shows an ejection fraction of 45 to 50% with apical and anteroseptal hypokinesis. Aortic root measures about 4.5 centimeters, sinus of Valsalva measuring about 5.1 centimeters. Because of his aortic aneurysm, when he came in with chest pain, a cardiac CTA was done to rule out any dissection. The aortic aneurysm was stable at 5.1 centimeters. Moderate left main stenosis, multifocal severe LAD stenosis, moderate stenosis of the ramus, and severe ostial circumflex stenosis was noted, along with multifocal RCA stenosis. He has multiple comorbidities. He's a diabetic with a hemoglobin A1C of 6.2, obese with a BMI of 39, stage 2 renal dysfunction, liver dysfunction with a thrombocytopenia of 100K, and as I had mentioned before, thoracic aortic and an abdominal aortic aneurysm, obstructive sleep apnea. He's also extremely frail with a frailty score of 6. Here is his diagnostic angiogram. You can see the distal LAD disease. And along with that, in the next shot will be our caudal shots. You can see the severe disease in the distal left main, which kind of extends to the ostium of the LAD. The circumflex kind of looks suspect, but the ramus also looks pretty severe. Our right coronary artery, kind of moderate to severe vessel in the distal RCA. After this, we went for a heart team approach, talked to the surgeons, and also talked to the patient. This syntax score showed mortality, cumulative event rate of 36% with PCI and 25% according to the syntax 1 score. With the syntax 2 score, with mortality between CABG and PCI was about the same. However, the STS score was extremely concerning with regards to renal failure, prolonged ventilation, length of stay, and the higher chance of a long length of stay. Based on these, and given the patient was extremely frail, we decided to go with high-risk PCI. Obviously, the pre-procedure planning is key in this situation. He is an unprotected left main, Medina score of 111, mildly depressed ejection fraction. He had an elevated left ventricular end diastolic pressure of about 35 millimeters of mercury during the diagnostic cap. But however, during the discussion times, he's been on medical therapies with long-acting nitroglycerin and diuresis. And he also has the aortic aneurysm, which has to be taken into consideration when thinking about mechanical circulatory support. Of course, access. Again, thoracic aneurysm, aortic aneurysm. Does he need bifurcation? What kind of bifurcation strategy would he need? Does he need atherectomy? These were the questions which we were thinking about during the pre-procedure planning. So the plan was we'll try right radial. His right radial artery was not very pulsatile during the diagnostic, we went femoral. So we thought we'll reattempt right radial and go with a 6-7 French more slender sheath and maybe get a 7 French guide. Check his LV EDP. If the EDP was above 20 millimeters of mercury, 15 to 20 millimeters of mercury, we may have to think about mechanical circulatory support. He has significant size discrepancy between the left main and the circumflex, so we did not think he would be a candidate for culotte. And given the severe osteogenesis in the circumflex, I thought we had to cover the ostium of the circumflex. So my plan was to do a DK crush. So right radial artery was was non-pulsatile. The right ulnar artery was very small. So we decided to do a 7 French right femoral. While we got femoral access, we noticed the aorta was extremely tortuous. We switched to a 45 centimeter 7 French guide, 7 French sheath. And then we tried several guides, XB, LAD 3.5, EBU 3.5, EBU 4. None of the 100 centimeter guides could even reach the aorta because of the tortuosity. Therefore, we switched to an 8 French 45 centimeter femoral guide, and then I was able to get a 6 French EBU4 close to the left main. These are the steps of the DK crush. You can go through at your leisure. And in this picture, you can see what I'm talking about. I could not get close enough to the left main, but I was close enough where I could float a wire, a BMW wire, into the coronary artery. At this time, I just wanted to get into the coronaries, then I could use guide extension catheters or whatever as need be. So my plan was to wire the LAD, wire the circumflex, treat the distal LAD, and then handle the bifurcation. So this is wiring of the main vessel and the side branch. The ramus also got wire. I'm IVUSing the left main, and the LAD, and IVUS of the circumflex was also done. I have to apologize, I don't have the IVUS images. Based on IVUS findings, we put a 2,538 drug-eluting stent into the distal LAD lesion. That was post-dilated with a 3012 balloon. And then we decided to go ahead and stent the left main into the circumflex with a little bit of the stent strut extending into the left main. We put a 3012 drug-eluting stent, again based on IVUS imaging. And then I took the 3020 NC balloon, which I had used to post-dilate my stent, and used it to crush the circumflex stent. After that, we used a choice PT wire to recross, and a 2520 balloon in the circumflex, and a 3020 NC balloon in the left main to the RCA. We decided to do a first kiss. And then I took a 4038 drug-eluting stent and deployed it into the left main LAD. And after this, I had a lot of trouble getting back into the circumflex. So much so, multiple wires were tried, hydrophilic wires, Miracle, Miracle 3, Miracle 6. Then I had to finally, I pretty much lost all wire access except my LAD wire. And I had to use a twin pass TARC, which is a dual lumen catheter, and use a Miracle 3 wire to recross. And I was able to do that. Before I even got to that point, I had to do a part with a 5.8 NC balloon. This is when I realized my mistake. I should have crushed with a bigger balloon. The 3020 NC balloon was nowhere close enough to crush my stent. And because of this misstep, I had a lot of difficulty. And after this part with the 5.8 NC balloon, I was able to rewire and proceed with my case. As you can see, now I have a Miracle 3 wire, and then we did a second kiss with a 2530 and a 3020 NC balloon. Then a repeat iris was done, which showed excellent expansion of the left main LAD stent. The left main had expanded really well with the 508 balloon. And here is my final angiogram. So DK Crush in summary, advantages, it has the best data right now. The DK Crush trial, the clinical outcomes following coronary bifurcation PCI techniques, definition 2 trial. You can do it successfully with 6 French axis. The disadvantages is the rewiring. It can be difficult. In my case, it was more difficult because I didn't crush the stent with an appropriate size balloon. I should have used a 1-to-1 balloon, so maybe a 4.0 or even a 4.59 compliant balloon to crush it would have made my life much more easier, lessen it. The recrossing wire choices, usually I start with the hydrophilic wire, choice PT, Fielder FC, then move on to penetrative wires, Miracle Brother family or Judo family. With this, I thank you all for the opportunity and hope you all enjoy this wonderful session. Goodbye.
Thank you very much. Dr. Hui, do you want to introduce the next speaker?
Yes. So thank you very much for beautiful presentations on DK Crush, Dr. Maran. So our next speaker will be Dr. Al-Fazil Omar from KL, Malaysia, and his talk will be about the second technique that we can go with the 2-stent strategy, this is culotte. So Dr. Fazil, please, how to get the best results with culotte technique.
Hi, thanks, Hui. Okay, let me share my slides. Okay, so I hope you can see my slides here. I'm talking about culotte stenting. Okay, so let's go about culotte. So I think culotte is mostly known as a 3-pot technique in which you need to prepare your vessels, like we discussed earlier. And then you would either do a main branch or side branch stenting, then you do a pot, and then a side branch stenting, and then a pot, and a final pot. And I think the last speaker just highlight nicely the importance of doing a pot, because pot corrects the under expansion, and because once you have all the stents crushed, it's a very important procedure that sometimes we take it for granted. So I'm going for step by step, show you a cartoon first, and then later we'll have an actual case. So you can see here that when you consider a culotte stenting, you would actually prefer to have a bifurcation that is similar or nearly a similar size vessel, because what's going to happen is that you're going to put a stent across the main branch and also the side branch. So typically, you will stent the more angulated branch, and typically it might be the diagonal, sometimes it's more angulated, or the OM branch. But what happens is that, number one, is that even though you're supposed to have the similar size, most operators, sometimes they undersize a little bit, and you can see very clearly here that the side branch is nice, but the main branch is underexpanded. The second tip I want to give is that make sure that you have enough landing zone proximally in the main branch, because later you want to do the pot. So it's important to have the enough landing zone when you stand across the side branch. So what you do here, and this is a very important step. So culotte or DK Crush, I know they're all step by step, but culotte is a bit more unforgiving. So this is, I think, the most crucial step, is that when you have to do a pot, and in this pot, you correct the under expansion. Don't worry about the side wire. If you're very concerned about the side branch wire, you can remove it, because we've never had any problems ever. I don't know about other operators of getting a wire trap just because of the stent. So what you do now is that you pull back your wire in the stented area, and then try to cross it, and you cross it at the distal cell. And this should be quite straightforward. Now that you have a stent in the side branch, you don't have to worry about the flow to the side branch, just focus on the main branch now. And then you insert the second stent across. And then you do a pot here to correct the stents, and because you have two metals in the main branch. And then you do a casing balloon between the main branch and the side branch, and then final pot. So in total, I mean, if you do a culotte, all you have to remember is that there's going to be a 3-pot, very important. The first pot is probably the most crucial, because if you get the first pot wrong, then your wire can go in and out the stand strut. You can't get your balloon down. You can't get your stand down. You start sweating. So first pot is important. Second pot is to optimize. And your third pot is to get you a good result so that, you know, he doesn't have any recurrence for the next many more years. So, so this is the final results for a culotte stenting. So straightforward. And this is the step-by-step here. So the only thing that sometimes compared to decay crush is that we have to rewire back the main branch. So there will be a few seconds or a few seconds where you don't have a wire in your main branch possibly. So if the flow may be slightly compromised, but other than that, it's quite a straightforward technique. Okay, so let me show you a case here that we had, that we did, actually me and Raj did. This is a 68 years old lady. She's breathless. Her ejection fraction was quite depressed. She had a CTO of the LAD and a moderate right disease. So we went for PCI to the LAD first, to the hybrid approach. And actually, we were quite keen to go retrograde for this approach. So let's have a look at the angiogram. So you can see here, it's got quite good collaterals, fairly short CTO, mild calcification, but maybe the only challenging part here is that the entry point is quite ambiguous. So I think we were very prepared and very happy actually to go retrograde for this case. However, well, fortunately or unfortunately, the anterograde wire cross with the Gaia 3 wire with the fine cross, and it actually went into the diagonal artery. So what we did is that, so we took it up. I mean, since the wire has gone to the diagonal, we took it, and then you can see a flow to the LAD here. And then what we did is that we used a dual lumen catheter here. And you can see that we use it to wire to the LED. Okay. So this is the wiring to the LED. All right. So after 2 millimeters of balloon predilatation for this case, you can see the diagonal is quite a large area, and his stenosis is quite long as well, as more than 5 millimeters. So this is what we did. So we discussed this case, because this case was, me and Raj did this case, and we were discussing whether we go for a provisional stenting, or we go for an upfront 2-stand, or even a sort of a POBA or DEB. For this case, we've decided, since the diagonal, you know, it looks quite large, and so we size it, and it may be looks appropriate for a culotte stenting as well. So we actually went for a culotte stenting here later on. So basically, we predilated further with a 2.5 balloon. And then we did an OCT run. So the lesion length was about 35 millimeters. Diameter was 2.5 to 3.2 millimeters. Okay, so this is the OCT images. Some dissection from the balloon. Because you can see here as well, the landing zone proximally and distally as well, with not much calcification. So here we implanted the main branch. So it was, the LED was more angulated. So we took the LED, in this instance, we stented the main branch first. So it's 2.75, 34 millimeters stent. And then what we did was we did the pot. So I think the pot is very important. So we take a 3.25 pot, a short NC balloon, so a 3.25, and we pot the proximal stand. So this is very important because you know, this first step here is that to prevent any stand under expansion. So once stands are fully expanded, then you can rewire the LED if you want to, and then we will insert the stand to the diagonal or the side branch here. So now then predilated further. So in this case, we decided to do a culotte. So what we did is that we put in a resolute stand 2.25 times 30 millimeter stand from the LED to the diagonal. So it's like an inverted culotte technique. And then and what we do is that we will rewire back the wire that's been trapped. So you try to wire to the distal cell here. And then before you wire to the diagonal, make sure you do another pot. So this is the second pot. So this, let's go back here. So it's important to do a pot here before you wire to the diagonal branch. So after the second pot, you do a final kissing balloon from the LED and to the diagonal artery. And this is very important that once you do your second your final kissing inflation, that you do your last pot. Okay. So this is the final image. So this is your stand. So it's a culotte stand. So you got a stand from here going all the way down here, and also a stand going here all the way to the main branch with final kissing balloon and the third pot. So I think this is the OCT run after that as well. So you can see that we did it and the stands are well expanded. So we're quite happy with the results. I'll show you again. So this is the results for the culotte stenting, and I hope so this is the culotte steps step by step. Again, so wire both. You will stand the most angulated branch first. If you stand the side branch first, make sure that you do a good pot, the first pot, and then you wire back in. You put a stand in the main branch. You do a second pot. You do a final kissing inflation, and you do a third pot. So then there's a stenting, pot, with cross wire, strut into the side branch, you stand, you pot, you final kissing, and the final pot. So this is the final results for this patient, and I hope that Raj will maybe do us a favor and do her angiogram 1 or 2 years later for us to have a look at the angiogram and also the OCT images. Okay, thank you very much.
Thank you for a good case, very informative. So our Dr. Hui, do you, no, Dr. Let me go ahead and introduce our next speaker is Professor Shaoling Chen from Nanjing, China. And he's going to talk about how to deal with complications of bifurcation PCI.
Thank you, Tamir. Can you see my slides?
It's coming on. It's coming on now.
Yeah, it's still open. Oh, sorry, it took a long time to log in. So I think now it's a very early morning in Atlanta, right?
It's about 3:30 in the morning.
Oh, very slowly. You know, there are many problems with the internet in China, I think. Okay, finally I got it. So can you see my slides?
Yes.
Yes, thank you, friend. Thank you, my great friend, Professor Rabo, to chair this session. So the topic is how to deal with complications of bifurcation PCI. This is my disclosure. So even there are two kinds of complication of bifurcation PCI. I will focus on the introduction of acute complication during provisional and decay persistent technique. Also, I will introduce device-related complication. In general, for all kinds of coronary bifurcation lesion, complication not always happen in complex procedures. So this is the first case. It's a Medina 011 true coronary bifurcation lesion involving AD and diagonal, but the lesion length in diagonal was less than 10 millimeters. Baseline diameter inside branch was also less than 50% So it could be defined as simple bifocal lesion according to our definition criteria. So we use the provisional stenting technique. We deploy a short stent in the RID. So before stenting RID, we check the OCT. From the OCT image, you can see the plaque in the RID was very stable, no any sign of vulnerable plaque. Because the case came from a junior, so there was no wire gel in the diagonal. So immediately after stenting RID, we perform post-dilation part technique for RID stent. So immediately after post-dilation on the right panel, you can see the blood flow in the diagonal was diminished very much. So we tried several attempts to try to negotiate the diagonal. Finally, we are very successful to rewire diagonal. We use two balloons to pre-dilate a diagonal followed by kissing and part technique. So I think the tip from this case is that for disease side branch, even for large side branch without very severe disease, so we always need a gelled wire, gelled balloon to protect the side branch. So this is the second case to show Medina 111 true coronary bifocal lesion at distal left neck. The lesion in sunflares were pretty diffuse, but the lesion in proximal RID was too long enough. So because the patient was included in our study, we used the provisional stenting technique crossover from RID to left main. So immediately after stenting left main, you can see the, I'm not sure. So the blood flow in sunflares was pretty good, grade 3. So, but the osteosunflares was pinched very much. So we try to use a balloon to dilate sunflares followed by kissing balloon inflation. During the whole procedure, patient had no any chest pain, no any sign of EKG changes. After kissing balloon inflation, you can see the two balloons inflated simultaneously into vessels. In the middle part, you can see immediately of the kissing balloon inflation. So there was a sign of type A dissection in sunflares. Because the blood flow in cell was pretty good, so we did not touch sunflares much more. But unfortunately, 4 hours later, since the procedure, the blood pressure dropped down very much, heart rate decreased, slowed down too much. So bedside echo confirmed the presence of temporal node. So we performed pericardiocentesis, we use IBP, so we deploy long stent in the sunflares. The procedure was completed by TAP, kissing balloon inflation, and the part technique. So I think the tip from this case was that we have to realize the importance of intravascular imaging is very important for any kind of complex PCI, particularly for left main disease and distal left main bifocal lesion. So this is number 3 cases to show the Medina 111 true coronary bifocal involving AID and diagonal. So we gelled the wire in diagonal, but we deployed long stent using provisional stenting technique. So this is the image immediate after stenting. You can see the diagonal was very much. So we tried to negotiate the diagonal, but we failed to do so. So we performed repeat post-dilation. And after that, finally, we are very successful to rewire the diagonal. So we use a two balloon to dilate the diagonal, followed by, oh, I'm sorry. I think I should back to, yeah. After we successfully rewire diagonal, so we perform kissing balloon inflation. And the final blood flow was good, but still there was very severe pinch disease. So finally, we used the TAP technique to finish my procedure. So from these 3 cases to show the complication of the provisional stenting technique, I'd like to say the number 1 complication after stenting my vessel is the requirement of second stent inside branch. So from this case, we can see gelled wire is very important in the side branch. And also, we need a very good risk stratification to define, to predict the occurrence of side branch injury, abrupt occlusion, dissection, something like that. For any patient who suffer the requirement of a second stent in that branch, I think there will be high rate of target vessel myocardial infarction and the TR. So let's move to another case to show the complications of the decay quashi technique. As Dr. Moran introduced her very interesting decay quashi technique. Oh, I'm sorry. There's some problem. Okay, can you see my slide clearly? I'm not sure. This is the Medina 111 distal left main true coronary bifurcation lesions. So we use the same French guiding from femoral approach. Also from an AP cranial, you can see also there is another bifurcation involving AD diagonal. So we use the decay quashi technique. I don't want to introduce the decay quashi technique much more from this case. So after a standing single flash, we successfully revise single flash. We used short non-compliant balloon to dilate the single flash stand with another balloon in the AID. Can you see 2 marks of balloon in the AID? After that, so we perform for the first casing and deploy the long stand from AID to left main. After standing, this is the second part technique. After that, we perform final kissing balloon inflation. For kissing balloon inflation, I'd like to say the overlapping segment of 2 balloons in the proximal vessel will be as short as possible. I think it will be very important to create a new carina. So after kissing balloon inflation, so from AP cranial, you can see the blood flow in diagonal was diminished very, very much. So simultaneously we check the IVOS. So from IVOS you can see there was a very severe dissection from proximal AD extended to the POC area. Also, we recorded the IVOS image from diagonal to show the presence of hematoma. So boldly I can see the hematoma on diagonal was induced by dissection from proximal AD. So according to the finding of IVOS, so I changed my strategy to use another decay technique for AD diagonal. So from arrow, you can see another wire in the diagonal. So we follow the steps of decay quash. This is the final result when we finish the decay quash for AD diagonal bifurcation lesion. For it, we've completed the remaining steps of decay quash for this left main bifurcation lesion. I think this is a typical case to show sometimes for some case we need to use 2 decay quash technique. For this case, we only use 1 long balloon to crush the diagonal stand and second vessel stand. Also, another point there, for this left main bifurcation lesion, sometimes we need to use a large non-compliant balloon to completely crush the stand from the side branch. This is number 5 case to show Medina 110 case involving LAD in diagonal because the bifurcation angle was very strange. So once we wired the LAD, we try to negotiate the diagonal, but unfortunately you can see in the middle panel, the wire was in the fourth lumen of diagonal. So after several attempts, I stopped to try to negotiate the diagonal. I changed it to deploy a long stand in the LAD. After stand, hopefully we can change the bifurcation angle because the stand strut was pretty rigid. It could be change the bifurcation angle. So exactly after standing LAD, so it was very easily to rewire diagonal. Unfortunately, you know, the wiring diagonal was a BMW wire. It's very soft. But from the angiography, you can see there are there are some problems with the distal perforation. So also we perform synthesis. Finally, the patient was stable. The tip from this case, I think that will be a soft wire, for example, BMW wire. So this is number 6 case to show the real complication during decay quash technique. So this is a his left main Medina 111 coronary bifurcation lesion, very diffuse lesion in third Also, the obtuse marginal looks very critical stenosis. So we use the TK quash technique. This is the AP cranial to show the diffuse lesion from distal part of ID. Also, there are some disease at the proximal diagonal. So the baseline, I was confirmed the very huge vessel, very large vessel from middle part of ID to the proximal. Also, we found very unstable plaque at the distal left main. So once we finished studying circumflex, we rewire from the circumflex. So from this view, you can see sometimes we need to use the X-ray to confirm, at least using two different interviews, injections to make sure the wire in from the proximal of the stent. So after rewire, we perform first the kissing balloon inflection and deploy another stent in the main vessel. After that, we rewire. From this angiography, you can see the wire was exactly in the giant gap. In the giant gap between circumflex stent and the vessel wall. Can you see that very clearly to show the presence of gap? So at this time, I think there was no way to take the circumflex stent out. So we used the second stent in the circumflex to do TAP technique. Even the procedure was smooth. But from the final angiography, you can see there was a high grade of residual stenosis at the ostium of circumflex, but blood flow was pretty good. So we stopped the procedure right here. Very, very luckily, the patient had no incident with stenosis during follow-up. This is the last case to show the device rupture. So this is another kind of Medina 111 bifurcating involving LED diagonal, very huge diagonal, very huge LED. So we checked IOS. So after that, we perform rotation aspirectomy, and we deploy very long stent in the LED to completely cover the whole lesion length. After that, we use the TAP technique using very long stent. It was 2.5 stent in diagonal. From angiography, you can see the stent in diagonal was not fully expanded. So we tried to recall the IOS image for both LED diagonal. Unfortunately, you can see from angiography, the IOS stent was ruptured in the diagonal. Simultaneously, you can see also there was a sign of diagonal stent rupture. Fortunately, after 1 year follow-up, angiography did not show any sign of incident with stenosis. But the very weird thing was that the patient presented very severe chest pain. So we recorded FFR for diagonal after 1 year. It was only 0.75. So we did TAR for diagonal. Thank you very much. Thanks for your attention.
Thank you very much. How much time do you have for this discussion, Dr. Rajgopal or Dr. Hui?
I think we have maybe 10 minutes for discussion.
So do you want me to go ahead with the points for each case, Dr. Hui? Would that be okay?
Yes, it's fine. Yes.
Sure. So we'll start with you. One of the things in your talk was definition of lesion complexity. You showed a number of criteria, but more recently the definition trial has confirmed lesion complexity based on the definition criteria and confirmed that in complex lesions, two-stent technique or pericardial decay crush is useful. Any comments from you from the presentation?
So I think how to define a complex applications still have challenges. So most of the times, based on many definitions, we need to have lesions of 5 or 10 mm from the ostium of the side branch, but sometimes it is not easy unless we have an intravascular imaging to show how significance of the side branch complexity.
All right. Okay. Now for the Rajgopal, have you tried other functional wires like an IFR or OCT to think about side branch significance?
Very little. IFR, yes. So I tend to use a lot of physiology. I use IFR, QFR for the main vessels. In side branch, of course, we can't use QFR, so it's either FFR or IFR. A couple of years ago, I used to do a lot of FFR in the speech side branches, and they almost always turned out to be negative. So I stopped doing it. These days, if the flow is good, and I tend to not do FFR, it must have been a couple of years, actually, at least 1 or 2 years since I've done an FFR in a side branch. If the flow is compromised, I treat it. Otherwise, I leave it alone.
Any comments about jailed IFR wires from anyone, including you, Dr. Rajgopal?
Jailed IFR, I don't know. Theoretically, it sounds really good. You leave an IFR wire in the side branch, and if the IFR is negative, pull it out and you're done with the procedure. But again, it's not something I've done myself. I don't know if others have tried it.
Go ahead.
For this point, I have some experience. During my TCAT question study, we compared angiography guidance and SFR guidance for side branch. So for some cases, we gel the pressure wire in side branch. I feel it was very safe. But sometimes for very calcified side branch, it will be very, very tough to remove the pressure wire.
After the procedure.
Yeah, after many members.
Dr. Anurag, you talked about OCT, very pretty images, and you were very educated about it. I mean, a lot of labs don't have imaging, even IVUS. So do you think imaging is absolute must in bifurcation PCI?
So like I showed you that in all the complex PCI need the imaging to prove it, because it can help you guide to facilitate the deletion and also optimization. For me, if you don't have the imaging for the bifurcation, I think we have a lot of technique to do, but for the decalage or the curate, sometimes if you want to get the better long-term result, imaging is quite important.
But even for the left main, I think it should be absolutely mandatory. I don't think you should do it at left main without imaging. Xiaoliang, with your ultimate results, do you have anything to add to this?
Yeah, exactly. 2 days ago, we just presented the 3-year follow-up of ultimate trial. Exactly, you say for all left main disease, in fluoroscopy images reduced in my sand. I think the penetration rate in my sand is about 85%, including IVUS, OCT, or FFR. But for left main disease, particularly for the suspicion of ossified left main disease, I think IVUS will work well compared to OCT.
So, to talk about imaging, one thing I found, particularly using the Philips Volcano system, and anyone can comment on it, that the side branch assessment can become very difficult, and you can get the device trapped and difficult to pull back, and you can have, unlike OCT, where you can have good pullback. I mean, some systems are difficult to pull back from side branches, and you can have longitudinal stent distortion. So I tend, if I only have that system available, then I use the Volcano. I was really in the main branch, because otherwise I think OCT is somewhat superior in assessing both side branches. Any comments by anyone on this point?
Anurag's got a lot. I tend to use OCT in about 60-70% of my pieces. Okay. Bifurcation stenting, I always do an OCT run in the main vessel, but I very rarely do OCT in the side branch. I can see Anurag smiling. He is the OCT expert here. It'll be nice to ask what he does for the side branch.
That's why I thought you changed the catheter this year. So you have to wait for the new catheter, because if you use the OCT for many times, the junction between the monorail system will be very weak. It's very difficult to pass to the side branch. So that's why just do the main branch, and we cannot see the side branch well with the OCT. If you can do it, you can have to open the new catheter. You can do it.
Yeah, the new catheters are very nice. Sometimes you can use a guide catheter extender to come right to the side branch and then push it through, and you can leave it there to do your pullback. Arasi, you had a great case. I had the privilege of seeing that before. So I want to talk to Xiaoliang about how big should a balloon be to really crush your side branch. And you've talked about it before. And Rossi showed that great case. So what are your thoughts?
I think this is a very important point. So we should to use the balloon adjusted according to the crossing main vessel diameter to perform crush. That's very important.
So should you use the same balloon that you're going to do pot with later to do the first crush?
Yeah, exactly.
It's okay. All right. And remember to always stop at the carotid. Rossi, do you have any comments?
Yeah, I mean, I think that was just wishful thinking. Since I had a 3O balloon in, because I used that to post-dilate the distal stent, I thought if I do a high-pressure balloon, I thought, oh, I could save myself from one extra step, which ultimately led to 10 extra steps. So I think it's better to just follow, not reinvent the wheel all over again. But if I had just gone with my original plan, I would have taken a 4.5 or a 5.0 balloon and I crushed it. But I was like, oh, I have a 3.0 balloon. Let me just go to 24 atmospheres and maybe that'll be enough. So as I said, that was a lesson learned. And I just wanted to make a comment on the OCT versus IVUS imaging for the side branch. I think it also depends on the type of catheters you have, right? And I agree with your point. A volcano IVUS catheter can be sometimes extremely difficult in a culotte situation to image the side branch. And I've had multiple times, and bifurcation PCI already has extra steps, and to put a guide extension catheter just to get adequate OCT images or deliver an OCT catheter or IVUS catheter to image the side branch, again, seems like, so many extra steps. I feel like the main point of this whole thing was be simple, be efficient, and be quick, and extra steps always can lead to other unexpected issues.
Yeah, so that's why I just focus on the main branch of post-imaging to make sure the main branch is preserved and has the largest diameter, particularly the left main. So Dr. Omar, so two things about your case, very nice case of a CTO with a bifurcation. Why didn't you start your culotte with this most angulated, which is your side branch and diagonal first? And the second question would be, any commentary on double kiss culotte? So I'll leave those two questions for you.
Thank you. Yeah, I think this case, I think we were just doing it for discussion. To be honest, we tend to do the more angulated, which is the diagonal, but I don't think there's any harm also doing the the main branch as well. Sometimes I would still do the main branch, like say the LED, if there's a lot of dissection and the flow might be compromised. So that's the time where I may do the main branch first. But I think it's okay. I think as long as you know your steps, you can do the main branch or your side branch, because it doesn't really truly matter. But the whole point being more angulated is so that your stent will not have much resistance when you're implanting the second stent. So I mean, so in this case, we were not sure we're going to go culotte up front. We were doing a provisional stenting, and then we changed to culotte later. With regards to the DK culotte, I think it just presented recently by our friend Gabo and as well. Yes, I mean, I've read it. So I'm interested this double case, but so far I need to read up a bit more. So far, we've done the usual steps, no problems with it, but I'll read up a bit more. I don't know what about the other panelists thought about it as well.
Charlie, do you have any comment about the double kiss culotte technique?
Yeah, I have many comments about the culotte and also DK mini culotte. 10 years ago, we proposed DK mini culotte, this concept. So you say, after you stand inside the branch, and then you successfully rewire main vessel, you need to dilate the main vessel followed by first kissing. I think this is the key. You kiss there. The next thing is that for any kind of culotte, there will be a napkin around the POC area. So Dr. Omar, from your OCT, can you see a little bit heaviness around the carotid from your OCT? I think that's a problem for any kind of culotte. So after that, we modify the DK culotte into DK mini culotte. It means the protrusion of the side stent into the main vessel was as short as possible. But sometimes for some cases, it was not easy because when you rewire the main vessel, so it's easy to do cathodic crush, mini cathodic crush. I don't know if you understand what I say. So that's my comment. So for your case, I think it's the CTO, also the diagonal look like the distal part, the distal to the CTO. I think there was no strong reason to use a two-step technique, but I think don't feel guilty if you deploy two-step for any bifocal lesion, because it's a bifocal lesion. Thank you.
Well, we're coming to the end of this conference. It's great talks. I mean, I hope you all learned. Also, I want to tell you that we've created the American Bifurcation Club in the US, and Rasi and I are the founding members. And we are really just showcases, lots of cases. We do monthly webinars. We're going to call it the ABC Bifurcation Hour. So look out for us in social media. One other thing I want to talk to you about is wire complications. I had one recently, and one of the most elegant ways, and Xiaoling showed a couple of wire purses, taking subcutaneous fat and small pieces of it, mince it up, small pieces, and just forcefully inject down the microcatheter, and it works very well, particularly for distal wire perforations, and you can really save a lot of grief. Any other comments from the organizers, Dr. Raj Gopal or Dr. Hui?
Thank you very much for all of your participants. A very interesting discussion about how to treat bifurcations lesion. Once again, thanks for all of you to be here.
Thank you very much for inviting me to moderate this session.
Thank you.
Thank you very much.
Thank you. See you. Bye-bye.
Bye-bye. Bye-bye. Leave.
Năm 1992, Hội Tim mạch Quốc gia Việt Nam được thành lập, đánh dấu bước phát triển mới của ngành tim mạch Việt Nam.
Hội Tim mạch Việt Nam là nơi tập hợp các bác sĩ trong chuyên ngành tim mạch để cùng nhau chia sẻ kinh nghiệm, cập nhật những thông tin mới nhất trong lĩnh vực chẩn đoán và điều trị các bệnh lý tim mạch.
Hội tập hợp hơn 1.300 hội viên với hàng trăm giáo sư, phó giáo sư, tiến sĩ. Gần 50 hội viên danh dự là các giáo sư, chuyên gia tim mạch nổi tiếng trên thế giới. Có hội đồng khoa học uy tín với thành viên là các chuyên gia đầu ngành trong lĩnh vực tim mạch. Thành lập được 4 phân hội chuyên sâu bao gồm phân hội tăng huyết áp, phân hội siêu âm tim, phân hội tim mạch can thiệp và phân hội nhịp tim Việt Nam.
Hội Tim mạch Việt Nam là một hội nghề nghiệp. Chúng tôi rất chú trọng đến công tác chuyên môn và nhất là công tác đào tạo cán bộ.
Hội đã tổ chức hàng ngàn cuộc hội thảo khoa học với các đề tài chuyên sâu có giá trị thực tiễn. Nhiều báo cáo khoa học đạt giải thưởng cao tại các hội nghị trong nước và quốc tế. Ứng dụng nhiều kỹ thuật mới trong chẩn đoán và điều trị tim mạch, trong đó nổi bật là kỹ thuật tim mạch can thiệp và kỹ thuật ghép tim. Mở hàng trăm các khóa đào tạo về chuyên khoa tim mạch định hướng cho các bác sĩ tại nhiều địa phương. Biên soạn bộ tài liệu cầm tay về các khuyến cáo dùng cho điều trị. Đặc biệt trong vòng 10 năm qua, tạp chí Tim mạch học Việt Nam ra đời trở thành tài liệu tham khảo đáng tin cậy của các bác sĩ tim mạch.
Song song với đó, Hội Tim mạch Việt Nam luôn chú trọng đến việc giao lưu, hội nhập quốc tế nhằm nâng cao vị thế của ngành tim mạch Việt Nam với bạn bè quốc tế. Đến nay thì Hội Tim mạch Việt Nam đã chính thức có quan hệ hợp tác quốc tế với 42 các cái hội tim mạch trên thế giới.
Từ năm 1992, Hội Tim mạch học quốc gia Việt Nam đã tham gia Ban chấp hành Liên đoàn Tim mạch Thế giới WHF, Liên đoàn Tim mạch học ASEAN AFC và Hội Tim mạch châu Á Thái Bình Dương APFC. Nhiều lần tham gia chủ tịch đoàn, hội đồng khoa học của các kỳ đại hội tim mạch thế giới. Năm 2008, Hội Tim mạch Việt Nam đã tổ chức thành công Đại hội Tim mạch ASEAN lần thứ 17 với hơn 3.000 đại biểu tham dự, được cộng đồng tim mạch trong khu vực và thế giới đánh giá cao. Bên cạnh đó, hội còn tích cực tham gia các hoạt động tư vấn, giáo dục sức khỏe cộng đồng trên các phương tiện truyền thông đại chúng. Tổ chức các hoạt động đi bộ đồng hành hưởng ứng Ngày Tim mạch Thế giới, thu hút hàng ngàn người tham gia hướng tới mục tiêu vì sức khỏe tim mạch.
Hội Tim mạch Việt Nam
cùng chung sức chung lòng vì những trái tim khỏe.
năm 1992, Hội Tim mạch Quốc gia Việt Nam được thành lập, đánh dấu bước phát triển mới của ngành tim mạch Việt Nam.
Hội Tim mạch Việt Nam là nơi tập hợp các bác sĩ trong chuyên ngành tim mạch để cùng nhau chia sẻ kinh nghiệm, cập nhật những cái thông tin mới nhất trong lĩnh vực chẩn đoán và điều trị các cái bệnh lý tim mạch.
Hội tập hợp hơn 1.300 hội viên với hàng trăm giáo sư, phó giáo sư, tiến sĩ. Gần 50 hội viên danh dự là các giáo sư, chuyên gia tim mạch nổi tiếng trên thế giới. Có hội đồng khoa học uy tín với thành viên là các chuyên gia đầu ngành trong lĩnh vực tim mạch. Thành lập được 4 phân hội chuyên sâu bao gồm phân hội tăng huyết áp, phân hội siêu âm tim, phân hội tim mạch can thiệp và phân hội nhịp tim Việt Nam.
Hội Tim mạch Việt Nam là một cái hội nghề nghiệp. Chúng tôi rất chú trọng đến cái công tác chuyên môn và nhất là công tác đào tạo cán bộ.
Hội đã tổ chức hàng ngàn cuộc hội thảo khoa học với các đề tài chuyên sâu có giá trị thực tiễn. Nhiều báo cáo khoa học đạt giải thưởng cao tại các hội nghị trong nước và quốc tế. Ứng dụng nhiều kỹ thuật mới trong chẩn đoán và điều trị tim mạch, trong đó nổi bật là kỹ thuật tim mạch can thiệp và kỹ thuật ghép tim. Mở hàng trăm các khóa đào tạo về chuyên khoa tim mạch định hướng cho các bác sĩ tại tim mạch can thiệp và phân hội nhịp tim Việt Nam.
Hội Tim mạch Việt Nam là một cái hội nghề nghiệp. Chúng tôi rất chú trọng đến cái công tác chuyên môn và nhất là công tác đào tạo cán bộ.
Hội đã tổ chức hàng ngàn cuộc hội thảo khoa học với các đề tài chuyên sâu có giá trị thực tiễn. Nhiều báo cáo khoa học đạt giải thưởng cao tại các hội nghị trong nước và quốc tế. Ứng dụng nhiều kỹ thuật mới trong chẩn đoán và điều trị tim mạch, trong đó nổi bật là kỹ thuật tim mạch can thiệp và kỹ thuật ghép tim. Mở hàng trăm các khóa đào tạo về chuyên khoa tim mạch định hướng cho các bác sĩ tại nhiều địa phương. Biên soạn bộ tài liệu cầm tay về các khuyến cáo dùng cho điều trị.
Today, I would like to talk about how to combine thrombolytic therapy and parenteral.
Sorry, we can't hear his voice.
Hello.
Hello.
Hello. Yes. Do you hear me? Yes.
Yes.
Actually,
Yes.
I have an update my presentation, and I called the call center this morning, and they told that they're going to update the new one. It will not have my picture. That the sound will be better too.
We're really sorry, but we haven't updated your presentation yet.
Oh, really? Yeah, because I have confirmed with the coordinator this morning. Yeah.
So do you want to leave right now or just use the old pre-recorded version?
It's okay. It's but just the better version that I have uploaded, but that's fine. This one is okay too. Okay.
Yes.
There will be time at the end if you'd like to update it further during the question periods. So that will be perhaps best.
Hello.
He can restore the floor in the laboratory.
Can you hear his presentation?
Yes, but the sound of this version is not well. I cannot hear it well.
Yeah. Also, the signal is not stable.
Yes, that's why I update another one this morning. Yeah. When we
Is it possible? Do you have the talk with you? Could you give it on your screen now?
Okay. Just give me a moment, around
Sure.
3 minutes. Is that okay? Okay.
Yes.
All right.
Yes.
Okay. Thanks.
This will be a wonderful session. We have speakers from across the world talking about the universal threat of thrombus and primary PCI. So I think it's going to be an exciting talk, exciting session. Lots to discuss, lots to learn about, lots to teach.
Yes.
Is Supawat still on, or did we lose him?
Propolis, maybe we change another topic first.
Yes, I think so. I think so.
Yeah.
Do we want to move ahead?
Waiting for next. Maybe we start with your presentation. How to deal with your large thrombus burden?
Sure, we can do the large thrombus burden.
Yeah.
So thank you to the organizers. Thank you for yes, it's a recorded presentation. It's a great honor to be part of this session. Please go ahead. Thank you.
My name is Greg Barsness, and I am an interventional cardiologist at the Mayo Clinic in Rochester, Minnesota. Although I am deeply disappointed to not be joining you in Vietnam this year, I am very pleased to be participating in the 2020 ASEAN Sky Fellows Course. We will be talking today about challenges in primary PCI and specifically how to deal with large thrombus burden. One of the major problems, in fact, in STEMI care is thrombus. The problem is not so much the thrombus itself, propensity of this thrombus to migrate distally. The clinical implications of this distal embolization and no reflow are dramatic. Because embolization and no reflow can affect up to 50% of patients undergoing primary PCI procedures, the implications are important. You see that angiographic no reflow is associated with a nearly doubling of mortality over 5 years. And CMR microvascular obstruction demonstrates a stepwise increase in adverse events with a stepwise increase in microvascular obstruction. So how do we approach this large thrombus burden and embolization? Well, the first and primary step is prevention of propagation, utilizing state-of-the-art processes for PCI care, as well as STEMI care pathways to make sure that we approach the appropriate patients with the appropriate medications at the appropriate time. Recognition of risk is important. Patients with advanced age, large thrombus burden, delayed presentation, LV dysfunction, and shock are all at increased risk, and these are not only additive but cumulative. In the management of mayhem, if distal embolization does occur, it can be a profound experience for both the operator and the patient. And management with aspiration, local antithrombotic agents, and alteration of your usual technical manipulation, including minimizing manipulation by using novel types, delayed or no stenting may be appropriate. Again, because it's so important to use appropriate medical therapies early, and aggressive antiplatelet therapy is essential, with the addition of additional antithrombotic agents when large thrombus burden is identified. Also, even in the setting of aggressive antiplatelet and antithrombotic therapy, if guide manipulation and selection is not fastidious, you can have problems. So you need the best guide with coaxial fit when you're dealing with these patients. You need to watch your pressure tracing. Avoid damping, monitor for damping. Do not inject a catheter with a dampened wave form, because this might happen. Here's a fairly normal looking LAD in the setting of an inferior STEMI, and you see with a guide injection, a large volume of thrombus is sent down the coronary tree. This is preventable, avoidable, and largely inexcusable. So fastidious guide technique is the first step in preventing problems. Most thrombus in STEMI, however, is not a propagation of technical issues, but is actually in situ thrombus. Here you see a mid-RCA occluded, open with a wire, but with a large thrombus burden. In fact, that thrombus burden is expressed distally with further manipulation, and ultimately the thrombus was retrieved with a good result. But this is what we're trying to deal with. This is what we're trying to avoid. One way to avoid this distal embolization is to trap the aspirate proximally. Here you see a moderate-sized TIMI grade 3 thrombus in the proximal vessel of the RCA. This was actually aspirated through the guide. No special equipment needed. It was just aspirated, retrieved, and the procedure was carried out. You can also use a guide extension for this very same technique, and you can combine antithrombotics, antiplatelet, lytic therapy with this kind of technique. And so with this large thrombus burden, you can see that a guide liner was wedged into the lesion, balloon was inflated distally, and 10 milligrams of TPA was instilled in the mid portion, totally obliterating and resolving the thrombus burden and allowing the successful completion of the procedure without distal embolization. A simpler way to do this, a more straightforward way that we've had, is manual thrombus aspiration catheters. There was a lot of excitement related to this in the 2010 era, especially related to the TOPIS trial, which demonstrated improved myocardial blush and improved ST segment resolution with use of routine atherectomy. However, the much larger total trial with over 10,000 patients demonstrated that routine manual thrombectomy or manual aspiration was associated with no clinical benefit, but a significant increase in stroke. The number needed to harm of only 250 patients using routine manual aspiration. This was verified in a randomized or meta-analysis of randomized trials involving 21,000 patients, and you see that death, myocardial infarction are no better with thrombus aspiration, but stroke is statistically significantly worse. The total trial, as I mentioned, was a much larger trial and did involve a large number of patients with high thrombus burden. And you can see with the 12-month Kaplan-Meier estimates of outcome show that high thrombus burden was associated with significantly worse outcome, including much higher cardiovascular death, shock, heart failure, and stroke. But 30-day mortality was actually no different with aspiration, whether you had high thrombus burden or no thrombus burden. There was no clinical benefit for aspiration, and actually aspiration increased the risk of stroke in patients with the highest thrombus burden, the patients you would most like to use aspiration thrombectomy in. This was actually verified in a patient-level meta-analysis involving nearly 20,000 patients again. So in the most recent guideline statements, routine aspiration thrombectomy is not useful or is not felt to be useful before primary PCI. However, it is tenable to use selective and bailout thrombectomy in primary PCI, although this is not well established. And in fact, a very recent registry analysis demonstrated that selective aspiration is still associated with increased in-hospital stroke and no clinical benefit at 6 months. So even when you think that you know the right patient to use aspiration thrombectomy in, it can be a challenge and is not shown to be beneficial at this point. Another type of thrombectomy is rheolytic or mechanical thrombectomy. No clinical benefit has been demonstrated in primary PCI, despite some smaller experiences that were favorable initially. So rheolytic thrombectomy as a routine strategy is not advised. Other devices that could be tried include filter embolic protection devices. These can sometimes be used to trap clot distally when you're manipulating proximally. However, you do need a large landing zone. Distal embolization can occur just with crossing the clot with these larger devices. These devices can clog and overflow. Optimal pore size is uncertain, and various humors can still be expressed through, and retrieval challenges can be a problem through stents, especially in tortuous native arteries. One potential way to avoid distal embolization and no reflow is to not stent. And this has been looked at and tried in the DENAMI 3 deferred trial, which was an open-label randomized trial of deferred stenting more than 48 hours after successful recanalization of a infarct vessel or routine stenting. And at 42-month follow-up, there was no clinical benefit, no survival benefit, no benefit on CMR parameters early on, and there was, however, an increased target vessel revascularization rate, with almost doubling the need for urgent target vessel revascularization in those patients undergoing deferred stenting. And so the European guidelines suggest that neither routine thrombus aspiration or deferred stenting is recommended. So what might help? What might be beneficial if you are worried about or experience no reflow? Well, for the treatment of no reflow, mechanical disruption can be helpful. A distal balloon or even distal wires can be sent into the vasculature, wound around, and even sometimes used to retrieve large thrombus burden. Chemical means can be used, including nicardipine, verapamil, nitroprusside, adenosine. These usually need to be given distally for the treatment of no reflow or even the prevention in the setting of STEMI, because you need to deliver that agent distally into the vasculature. In order to get there, you need to place a catheter distal, and often your distal aspiration catheters are a good means to deliver that. Usually guide infusions of these agents is much less beneficial because most of the agent is expelled into the aorta and not much of it goes into the distal vasculature. Finally, for prevention, minimal manipulation and minimal predilatation of lesions and clot can go a long way in decreasing the risk of no reflow and distal embolization. So non-aggressive sizing, direct stenting. So overall, the approach to large thrombus burden includes avoiding routine thrombus aspiration. You can consider upfront aggressive antiplatelet therapy once high thrombus burden is identified. You can give glycoprotein 2b3 inhibition or rarely local thrombolytic infusion, as I demonstrated, and there are various ways to deliver that. You can limit lesion manipulation and optimize initial stent expansion to avoid the need for post-dilatation, which is when much of the no reflow occurs. You can also consider selective thrombus aspiration if there's a large thrombus burden and a large conduit, especially if this is fresh clot that's easily expressed in the proximal vessel. Aspiration thrombectomy can facilitate optimal stent sizing and positioning, and so it's good if you are considering the need to be certain about the stent sizing. Aspiration catheters, as I mentioned, can be used for distal delivery to treat no or slow reflow, and you have to incorporate fastidious guide management and technique both throughout the procedure, but especially with aspiration use to avoid the known hazard of stroke. And with that, come on. I look forward to seeing you all again soon in person. Thank you.
Thank you for your presentation. We will discuss after the presentation, after or on April. How come you think how about to use the thrombotic medication like the Anstepla or Uricana for intracoronary thrombolysis in case of you had to face with large thromboprudent after you fail with the thrombo section. How about your outcome? How about your idea?
Yeah, those are great questions. So the use of local thrombolytic therapy has been shown in very small series to be beneficial, especially in the older literature, before the routine use of early dual antiplatelet therapy. So I think that there's a little bit more hazard now with bleeding, although local thrombolytics can be useful. As I showed in that single case, there are people using other strategies taken from the neurologic literature to use localized infusions of thrombolysis and truly kind of trapping a column of lytic within the coronary tree to kind of dethrombose areas of clot and aspirate that. And that in very small series, anecdotally, has been beneficial. As a routine strategy, we are not using a local thrombolysis in most cases, and the data is conflicting. I'd be curious if anyone else is using local thrombolysis for large thrombus.
I think because now we are sorry. I think now we have to do that to advocate to use a thrombolysis, to use the thrombolytic medication. Is the choice because if the benefit and also the safety, but also I think in some special case, if we have nothing, and also maybe the last choice. I also have some case in my opinion, some case when we also after using the low dose and intracoronary to use, we also see the reverse the TME flow and also but for the prognosis and for the long-term outcome, we're not sure. Just on the corrosion atrophy, we think it's better. Any comment, please?
Yeah, we've used it several times on my end in desperation once the other techniques have failed. Especially when you get thrombosis of very aneurysmal arteries, there the thrombus burden tends to be very high. I think the key messages, every time I've used it, it's worked so far, but obviously anecdote is not evidence. But the key is we usually use about 1 to 2 milligrams, and you have to give it time. When you give it down the coronary, you have to wait for a while. It takes a little while to work. But when it does work, it works quite dramatically. The other thing that we've used occasionally is to use a laser. The laser in fresh clot tends to vaporize the clot. There's no evidence for this. Clearly, we have no idea what long-term outcomes are, but it does work in vaporizing a thrombus.
Right.
Yeah, but not in old thrombus, but in fresher thrombus.
Yeah, I think many of these techniques work best in the fresher thrombus. Once the clot is established and cross-linked, it becomes very difficult to challenge. We used to use a lot of ipsiximab. Chip Gold back in the 80s, showed that you could dethrombose a vessel just by local administration of ipsiximab, but we don't have access to ipsiximab anymore, so that's no longer a reasonable option. But medical therapy certainly has a role both in prevention and treatment of thrombus. And so I agree with you that those are all things you need to consider. But good systems care, good technique, and it's important.
Yeah.
Good. Thank you. Probably.
Yeah. And an important learning point to point out: if you are to choose to use eptifibatide intracoronary, ipsiximab, when given intracoronary, does not need any buffering because it's the same pH as the coronaries. But if you are going to use eptifibatide, it does anecdotally agree, but you must be very careful with the buffering because the pH is not the same. It's more acidic. So the way we normally do it is to mix it up with blood and let the body buffer it yourself. So you give it dilute, you mix it with blood, and then you push it through.
We give a very, very slow infusion. I personally am not sure about the local effects of eptifibatide. Ipsiximab made sense to me because it was an antibody that just bound the clot. You gave a high concentration right at the clot. All of that was there. With eptifibatide, it's a reversible inhibitor, so it comes on and off, and pretty soon it's circulating throughout the entire body, regardless of where you infuse it. But it's a good strategy. It's what we have left, so it's a good strategy. Good. We should probably move on to the next talk. Who do we have? Who do we have next? Is Supawat around? Is he on again, or did we lose him?
I'm available now.
There you are. Okay.
Yeah, thank you so much. Yeah. All right. Okay. Let me share my slide and we can go on. All right. All right. Sorry for the delay. Everyone hear me well?
Yes. Thank you.
Okay. Yes. So today I would like to talk about how to combine thrombolytic therapy and primary PCI in ASEAN region in the Southeast Asia. I'm a Supawat Ratanapo cardiologist from Pramukau Hospital, Bangkok, Thailand. All right. So in Thailand and everywhere in the world, we have two reconstruction strategy: thrombolytic therapy and primary PCI. Both have a pros and cons. The thrombolytic therapy is widely available. As example, in Thailand, we have a streptokinase in every hospital. We have a TPA, TPS in a major city hospital, and we have inoculation in academic center hospital. However, it carry a risk of bleeding and is less effective when compared to primary PCI. These are choices that are available in the country. We have both fibrin non-specific like a streptokinase and more fibrin-specific like a tineciclase. We try to encourage the people to use more tineciclase in the country since it's a weight-based dosage and higher patency rate. So, and primary PCI nowadays, what is a recommendation? We do mostly a radial first. For the stent, we use a drug-eluting stent. We did not use a glycoprotein inhibitor in every case, just say for the bailout procedure, and no routine use of aspiration thrombectomy. And how we combine these to our country, there's a 3 ways to combine both thrombolytic therapy and primary PCI. You are familiar pharmacoinvasive strategy, rescue PCI, and facilitated PCI. For the pharmacoinvasive strategy, or another name called delay invasive management, it's like we give the lytics to the patient, then transfer the patient out to a PCI capable hospital. If the patient responds to lytic therapy, then we can do a elective angiogram with or without PCI in 3 to 24 hours. If the patient does not respond to the lytic therapy, we do immediate PCI to rescue. From the transfer AMI trial, 1,000 patients randomized with a semi-randomized to non-PCI center, and found that after give a Tinnicky plate, if we shift the patient out to PCI capable hospital within 6 hours, we can decrease ischemic complication. From the CARES in AMI, 600 patients, if we can shift the patient right away after we give a thrombolytic therapy, we can decrease mass of the patient. Next is a rescue PCI. It means that we give the lytics and the patient does not respond to thrombolytic therapy. The patient have a ST elevation decrease less than 50% at 90 minutes after infusion is start, or the patient have an ongoing chest pain, or the patient have hemodynamic instability such as cardiac shock. From the REACT trial, we know that if we bring this group of patients who did not respond to thrombolytic therapy to do a rescue PCI right away, we can decrease adverse event more than 50% at 6 to 12 months, and also decrease the long-term mortality at 5 years more than 50%. The last one is facilitated PCI that we did not use anymore. It comes with the concept that before we send the patient to do primary PCI, let's get some medication to help. From the Ascent PCI trial, after they try to get a lytic therapy and then send the patient to do PCI in 1 to 3 hours, the patient have a more mortality and more complication, and the study has been early terminated due to safety issue. From the Finance trial, they have the idea that maybe give a GPI before send the patient for primary PCI, or GPI plus lytic therapy. However, no method improve outcome for the patient on top primary PCI alone. So nowadays we did not use facilitated PCI anymore. Then let's see from the guideline, because in the ASEAN country, we use both US and European guidelines and original guideline too. From the US guideline that you all familiar, that are from STEMI guideline 2013, we divide the patient in 2 groups. The patient who sent to a PCI capable hospital have a first vital contact to balloon time. Device time should be less than 90 minutes. The patient who transferred to a non-PCI capable hospital, then we have a golden number 120 minutes to decide that should we transfer the patient out or we give a fibrinolytic agent within 30 minutes. For the indication, the one who have a symptom within 12 hours with the class 1 indication, that we can give a thrombolytic therapy. The one who have a high risk, the ongoing symptom or concern about the large area of myocardium, we may delay until we can use if the patient have symptoms 1 day ago. And if we're not sure the patient have ST elevation or not, we should not give a fibrinolytic. And then after we give the lytic therapy, we follow a pharmacoinvasive strategy. We bring the patient to do angiogram within 3 to 24 hours. From the European guideline from 2017, they push a little bit further with a primary when the patient arrives to a PCI capable hospital, should have a first vital contact to device less than 60 minutes. And if we plan to transfer, we should do in less than 90 minutes. but they can extend to 120. And if we decide that we're going to give a lytic therapy, we should give within 10 minutes. The small difference is when we do pharmacoinvasive strategy, US guidelines say that we should do choreangiogram in 3 to 24 hours, but your European guidelines said that we can do in 2 to 24 hours. And then when we look for the indication of lytic therapy, European guidelines recommend we can use in 12 hours of the symptoms, and after 12 hours, we should do primary PCI. For a typical ECG, the European guidelines say that if we're not sure about acceleration, don't give lytic therapy. Another frequently asked question, if the patient presents with a semi-equivalent ECG, what should we do, like a Delviter pattern? The answer is we don't give a lytic therapy at this point, but there's a several case series and case report about give lytic therapy in this group of patients. And this is all the conclusion that if the patient to present to primary PCI capable hospital, we try to get a first clinical contact to device time shorter as much as possible. We approach by the radio and we use a DES stent in most situations. If the patient transfer to non-PCI capable hospital, we have to think about transfer time. If it can be, everything can be done less than 120 minutes, we transfer to primary PCI center. If more than 120 minutes, we give lytic therapy. And this is a Thai ACS guideline that just launched 2 weeks ago. Everything almost resembles to a ESC guideline, except the time for primary PCI is less than 90 minutes. It's accessible for the Thai guideline at this point. When we look through, another thing that is a gray zone in both the US and European guideline is if the patient was given a streptokinase, should we give an anticoagulant or not? It's a big problem because the majority of the hospital in Thailand, we still use a streptokinase. And this guideline said that we can give an anticoagulant if APTT less than 1.5 times above normal limit. And then they also have a tailor-made on the guideline that we can transfer the patient after pharmacoinvasive strategy. We transfer to the PCI capable hospital, can be done immediately or after the patient stable 1 to 3 days, depend on the regional semi-nervous protocol. There's a limitation in the area in Thailand and some ASEAN countries about the healthcare infrastructure, about the available of EMS. Many people arrive at the hospital not by EMS, but just walk into the ER. There's no bed and ICU available for the patient. Some cath lab does not open 24/7 and close on the weekend. There's also a prolonged door-in door-out time due to a documentation, the transfer system. So what is really happened in some rural area in Thailand, the patient present to a non-PCI capable hospital. The patient was given a streptokinase as a lytic therapy. If the patient failed lytic, they then was transferred out right away for rescue PCI. But if the patient respond to lytic therapy and they did very good, many people was hospitalized at the same hospital, non-PCI capable hospital, and was discharged and have a schedule as an outpatient for like a CAG and elective PCI. And many people we lost this group of patients during the process of treatment, and we call a standalone thrombolysis. So there's many models that we try to implement to improve the system. The point-to-point is work in some area, and newly model is a hub and spoke that we adapt from the airline business. There's a research shown in southern India that when we identify hub and spoke model, classify the hospital, they can decrease the rate of standalone thrombolysis by 30%. Moreover, they can increase the rate of primary PCI, the rate of pharmacoinvasive strategy, and the most important thing, they can decrease mortality by 3% at 1 year. So nowadays we try to implement this hub and spoke model to the regional our STEMI network. Another thing that may be very important, many big cities in ASEAN region have a big traffic jam in the rush hour. In Bangkok, on a good day, I drive to the hospital to do a STEMI in 10 minutes. On the bad day, it's 2.5 hours. So this is a problem. When we look through the World Traffic Ranking 2019, Manila, Jakarta, Bangkok, we all in the top 10. And so this have to be implemented to the plan, and then it can affect the way that we can transfer the patient out or just give pharmaco-invasive strategy in the rush hour. In Thailand, we divide the healthcare, the STEMI program to a 13 area. All have an ACS registry that get the information and get the feedback to do a local and regional STEMI protocol and transfer. This is another registry that we have parallel to the first one called Thai PCI registry. We have enrolled to 6,000 patients in last 2 years. You can see in the greater Bangkok, we have a high density of a PCI capable hospital. Mostly the patient got primary PCI. Vice versa, the patient in the northeastern area, we have a less hospital with a PCI and cath lab. So the patient got more pharmaco-invasive treatment. In Jakarta STEMI network, they have analyzed and found that actually the ideal door-in-door time as an ACC stage should be less than 30 minutes. They can achieve only 9.7%. And then the mean of door-in-door time is average around 1.5 hours at least. Yeah, this can be from the system, from the documentation. And let me show the real case example. 56-year-old man sent to the non-PCI capable hospital because of loss of consciousness on Sunday morning. The patient was found have a shock and bradycardia. The patient have an inferior STEMI with a complete heart block. At a non-PCI hospital, the patient was started with a streptokinase, aspirin, cortisol loading, 300 milligrams, and start heparin IV drip. Then the patient was transferred to our institution for pharmacoinvasive strategy. On the way, the patient have a massive hemoptysis, 600 cc, more BP drop, and was intubated in the ambulance. So when the patient arrived, it's almost 90 minutes. The ST elevation decreased less than 50%, and the patient quite unstable. So the patient fulfilled criteria for rescue PCI at this point. So we concerned about the patient cardiac shock, have ongoing bleeding, have refractory hypoxemia from hemoptysis. We think the patient should have some hemodynamic support too. So we think about that we can do like a balloon pump, but it will not enough. And in Thailand, we don't have an impeller on tandem heart available yet at this point. So we have to put a VA ECMO in the cath lab. We do perform the angiogram, have some left coronary disease, and the right side have a large thrombus. Then we have to do a aspiration thrombectomy. Although we don't do it routinely, but in situation we decide to do. And after that, because the patient are bleeding and hemoptysis, we concern and hesitate to place the stent for the patient. So we use a drug-coated balloon to open the vessel. We get the optimal flow, and the patient blood pressure is stable. We plan to look for the angiogram later after we can control hemoptysis. Then we can control hemoptysis. We do a bronchoscopy. Then we can beat off IVP in 3 days, and VA ECMO we can beat off in 5 days. So this is an example that we can combine pharmaco-invasive strategy to our care system. We have a hospital that has streptokinase, and we have another nearby hospital with a VA ECMO. That's quite different in the region. So my take-home message is really challenged to combine both strategy in this area, because we have very different facility between rural area and metro area. Pharmaco-invasive strategy will be a preferred plan for the patient. And if we're going to give lytic therapy, we prefer fibrin-specific thrombolytic. Regional transfer protocol is really, very important, and we can implement hub and spoke model to improve mortality rate. Regional STEMI registry is something that every part of the country should do, so we can collect the data and improve our quality care to the STEMI patient. Thank you so much.
Thank
you very much. That was a wonderful talk. I'm not sure if we got questions from the audience, but I want to reinforce a couple things that you said about the system. So congratulations on having the system in Thailand. There are reports, and in our system, just having a process for STEMI care that's propagated to surrounding sites actually improves outcomes. And just having a system works. And your strategy of utilizing the pharmacodynamic approach is very reasonable. You showed your dido times that are, it's difficult all around the world to meet that 30-minute dido time, the door in, door out time. And one of the solutions to that, of course, is to give thrombolytic therapy instead of transferring directly to primary PCI. And that's exactly the strategy that a lot of places are using. So congratulations.
Thank you so much.
Yeah, I think we're running a little behind time, and I think we do have a strict limit, so perhaps we should move along to the next talk. Is everybody okay with that? I think our next talk will be Dr. Lim, talking about primary PCI in late presenters. Should we do primary PCI?
Người khác nghe thấy thầy nói thì bị nhiễu ạ, còn thầy nghe thì ok. Nhưng mà người khác
Sorry, I was mute earlier. Yeah, thank you, Greg and Rohan, and thanks to the organizing committee for the kind invitation to talk on this. Should we do primary PCI for AMI late presenter? Yeah, how late is late, and then some consideration behind late primary PCI and some of the data and a summary. So most of the guidelines nowadays divide the duration of the occlusion to 12 hours. Less than 12 hours considered as early reperfusion. Between 12 hours to 3 months considered as late reperfusion, but 3 months is really very late. The 3 months is because the chronic total occlusion versus acute total occlusion. The chronic total occlusion is defined as 100% occlusion beyond 3 months. Hence, this division between 12 hours and then 3 months. So for early reperfusion, undoubtedly all is indicated for all patients. The issue that we are going to discuss today is those between the 12 hours to 3 months. So why 12 hours limit? And this is mainly from the thrombolytic era, that there was no mortality benefit, but there was increased harm, mainly intracranial hemorrhage with fibrinolytics. And the late presenter were not included in the trial showing superiority of PCI over fibrinolytics. Hence, this 12 hours in the guideline. And then on the other extreme, the CTO, whether to revascularize the CTO, we need to take into consideration multiple factors, including the symptoms, the presence of the ischemic and viable myocardium, and multiple other factors as shown here. It is a complex consideration. So very early and very late has a completely different consideration. Then for AMI reperfusion therapy beyond 12 hours and less than 3 months. It all depends on the clinical status, whether there's symptoms, hemodynamic, electrical stability, and then we need to briefly consider reperfusion modality. Here, in this time window, there is very little role for thrombolytic therapy, and any reperfusion should preferably and should be done with the PCI. And then the time window, this 12 hours. And then beyond 12 hours, should it be 24 hours, 48 hours, 78 hours, 72 hours, 1 week, or how many days? So a few things to remember. Yeah, the PCI in AMI beyond 12 hours, there will still be some viable salvageable myocardium assist even after 12 hours of severe ischemia, as demonstrated in multiple studies in the past. And then comparing PCI versus thrombolytics, the PCI is a superior reperfusion strategy with a higher patency rate, with less recurrent ischemia, less reinfarction, less intracranial bleeding. And so it theoretically has a wider time window of efficacy and therefore should not be restricted to 12 hours. So beyond PCI. And let's look at this particular study coming out from the Denmark. It's a single center, high volume primary PCI, enrolling patient from year 205 to 207, 247 AMI patient with symptom duration between 30 minutes to 72 hours. They specifically look at the patient beyond, comparing the two groups, dividing them into the early versus late reperfusion beyond 12 hours, but still symptomatic. And the myocardial perfusion imaging was done just before the PCI and at 30 days after the index procedure. The results show that there's of course the infarct size is smaller in those with the early reperfusion, but even for the late reperfusion, there was still some myocardial salvage. There's this 44% of the salvage index. That goes to show that the late reperfusion still managed to salvage some myocardium. And this myocardial salvage is not confined to just the 12 hours time window. And because of that, yeah, this ESC guideline, yeah, that beyond 12 hours, if the patient has symptoms of ongoing ischemia, if there's hemodynamic instability, if there's electrical instability, there is a clear indication for primary PCI. It's a primary PCI, there's no thrombolytic here. What happens beyond 12 hours if the patient is asymptomatic and stable? So here comes the idea of this, this very appealing hypothesis, the late open artery hypothesis, promoted by first thought of by a group of investigators led by Bronwall. And in multiple rats, pigs, and dogs experiment, late reperfusion of infarct led to thicker infarct scar, and this limit the post-myocardial infarction expansion. And there is a late patency of the infarct-related artery. It also provides collateral blood flow to the peri-infarct zone, and theoretically salvaging some of the still viable myocardium. And a patent infarct-related artery also provides a scaffold supporting the surrounding myocardium, therefore limiting the infarct expansion. And some animal experiment also showed that the patent infarct-related artery increased the electrical stability. Of course, with the patent infarct-related artery, it may serve as a potential future source of collateral supply to other at-risk territory. And among some of these, rat experiment lend credence to this late open artery hypothesis. In this particular experiment, 68 rats had their LAD ligated and then randomized to 30 minutes reperfusion, 2 hours reperfusion, and this is a late reperfusion, and then a permanent LAD ligation. The rats were sacrificed, the heart examined at 2 weeks, looking at the infarct size, extent of transmurality, and the infarct expansion. Looking at the 2-hour reperfusion, you can see that this is a late reperfusion did not salvage much myocardium. The infarct size was about similar, not statistically different from the rats with the permanent LAD ligation. And then the transmurality was similar in both groups, and yet there was a statistically different index. This animal experiment provides evidence that a late late opening of the infarct-related artery may limit the expansion of the infarct area. Then comes this BRAVE-2 study, which is an international multi-center randomized control trial enrolling 365 patients in the year of 2001 to 2004 with a symptom onset 12 to 48 hours before, but no longer having ongoing chest pain and not in KLIP 3 or 4 heart failure status and no electrical instability. Essentially stable asymptomatic group of patients from 12 to 48 hours after the symptom onset. Randomized to primary PCI, 88% of them received stenting versus a conservative treatment. And the SPEC study was done 5 to 10 days later. The primary endpoint was the final infarct size on SPEC, and secondary endpoint, the 30 days death, MI, and the stroke. We can see that actually the invasive group has a significantly lower infarct size. So the primary endpoint was significantly in favor of the primary PCI for this group of asymptomatic stable patients 12 to 48 hours after the symptom onset. But there was no significant impact on the death, MI, or the stroke, but perhaps the patient population is not big enough. There are 365 AMI patients. And then the investigator conducted extended the follow-up of this group of patients up to 4 years. And at 4 years, there was clearly a separation of the survival curve between the two groups, strongly in favor of the invasive group. Death was only 11.1%, whereas the conservative group have a mortality rate of 18.9%, which is statistically significant. And the subsequent revascularization of the infarct-related artery was also strongly in favor of the invasive group. So beyond 12 hours, based on the BRAVE-2 study, the ESC 2017 guideline is this column 2A level evidence B, for patient asymptomatic stable patient, from 12 to 48 hours, PCI could be considered. And beyond 48 hours, there were a few late reperfusion studies using PCI with stenting strategy, more like the slightly more modern type of PCI strategy. It's listed here, but they were performed close to 20 years ago, actually. The number of patients was listed, and the biggest study was that of Oates and with a sub-study of Tosca. And the enrolling patient, stable asymptomatic patient, 3 to 28 days after the AMI, who had angiography proven occluded infarct-related artery. Randomized to PCI versus no PCI, all of them were on aggressive medical therapy. The conclusion was that there was no difference in the event-free survival between the group. And for the Canadian sub-study, there was this 1-year angiographic sub-study. There was no effect on the LVEF, but there was a trend towards less LV dilatation with reperfusion. As we mentioned, this is the largest late reperfusion study beyond 3 days, 3 to 28 days, 2,166 patients. You can see that there was no, the PCI did not reduce the primary endpoint of death, non-fatal reinfarction, or class 4 heart failure. But please note that here the PCI arm, even though it was performed with 87% of patients received stenting, but only 8% of the patient received drug-eluting stent. And take note of the exclusion criteria if the patient had severe left main or triple vessel stenosis, rest angina, severe ischemia on the stress testing, or hemodynamic instability, heart failure, or shock, or electrical instability. They were excluded from the study. And for the secondary endpoint, there was no statistical significance between the two groups with regards to death and the class 4 heart failure. But there was a total reinfarction trend higher in the PCI group. This was also seen in the BRAVE-2 study. And in the earlier lecture by Greg, there was this mention, there was this emphasis that the early clot versus late clot, they behave very differently. So the late PCI may run the risk of a higher peri-procedure MI from this particular study. The old investigator followed the patient up to 8 years, and again, there was no significant difference in terms of the primary endpoint. And the TOSCA-2 study, the one with the angiographic sub-study, and there was also a careful evaluation of the left ventricular systolic as well as the diastolic volume index. So that there was actually no, both groups have increase in the LVEF, the both on medical therapy or the PCI treated group, both of them have improvement in the LVEF, but the group treated with PCI has a trend towards less expansion or the dilatation of the left ventricle. And from Oates and TOSCA-2 study, it is now stated in the guideline that beyond 48 hours, if the patient is asymptomatic, stable, in the absence of a significant stenosis in the left main or triple vessel disease, no ischemia and no severe ischemia on the stress testing, a routine PCI is contraindicated. So this is a summary of the reperfusion strategy in the infarct-related artery according from 12 to 48 hours and beyond. If symptomatic, hemodynamic instability or arrhythmia, primary PCI, regardless of the time window. And asymptomatic from 12 to 48 hours, primary PCI could be considered. Beyond that, if stable and in the absence of high-risk characteristic, no routine PCI. Instead, a myocardial ischemia viability assessment should be performed for the really latecomer. And if there is an ischemic viable salvageable myocardium, then consider late PCI, and routine PCI is not indicated as mentioned. However, all these major trials actually recruited patients nearly 20 years back. 15 to 20 years. Yeah, there is a lack of contemporary data concerning the late reperfusion therapy with the contemporary PCI strategy using the radial access, second or third generation DES versus BMS versus POBA, and also the selective thrombectomy as we saw earlier, and the pharmacologic significantly improved pharmacologic therapy, the antithrombotic pre, intra, and post-procedure, as well as the many medications that favorably improve the LV remodeling. Yeah. So I think so there is still some gap. So I think that the final words is not in yet for this late open artery hypothesis. Thank you very much, and come on.
Fantastic talk. Thank you so much. That was very comprehensive, dealing with a very complex subject. I think we'll need to move right along. I'd like to introduce Professor Ho from Washington City, who was speaking about how to optimize antithrombotic therapy for primary PCI. You're on mute, Professor Ho. Can we unmute?
We have some difficult setting for Professor Ho, so we can connect with him immediately.
Yes. Okay.
I'm not able to hear Professor Ho. Can someone, can you unmute? There,
Yes,
good.
Can
Good,
you,
thank you.
Can you, yeah. Okay, I'm sorry. So, because this is the emergency occlusion due to thrombus in the coronary arteries, so the strategy is the emergency reperfusion therapy. So we need the anti-platelet, anti-thrombus, very strong, very soon as possible. So, first of all, antiplatelet drugs is the DIBT, dual and antiplatelet therapy, and it includes one aspirin in combination with one potent B2Y12 inhibitor. And in some years ago, we have suprasucrel and ticagrelor. In that time, the ticagrelor with the dominant role over the prasucrel. And as you see, in the after that, because in that time when we compare with the Trian data from Trian 320 38, the prasucrel proved for strong and early effect over clopidogrel and plateau for ticagrelor.
There you go.
Yes. And in that time, we have the concept of pre-treatment. Pre-treatment were born due to the clopidogrel, because the clopidogrel are not very strong and a little bit later. So we need to load the dose before the patient go to the cath lab. We need to load the dose in the emergency room or in the ambulance. But by now, after ticagrelor and prasugrel have the dominant role, how about the pre-treatment? We have some data. Of course, if we pre-treatment of ticagrelor, it's better, but not imperative. If we pre-treatment some strain thrombosis decrease, but the problem, some data emphasize the problem is the cross the tablet. You see, after we do some meta-analysis, Atlantic Chamber, early and the delay loading dose of the potential antiplatelet not change very much. But so the guideline in the 2018 of ESC, we should loading dose before at least at the time the patient come to the cath lab. But they emphasize the cross is better. As you see in the left side for ticagrelor in prasugrel, in the right side, the whole they compare the effect of the antiplatelet effect with the whole tablets and cross tablets. If we cross tablets, the level of the effect can gain earlier all of the ticagrelor and prasugrel. And just recently, after the result of the ESA re-up5, compare prasugrel and ticagrelor, as you see with the number 4018 with primary endpoint, composite deaths, MI, and stroke. And the safety bleeding about the type 3 and 4, prasugrel proved for better than ticagrelor. And intubation 1 or 2 or 3 years ago, if the patient lightweight or older patient, the dose in that time, prasugrel sometimes a relative contraindication, but with the result of ESA re-up5, with the reduced dose, adapted dose of prasugrel, when compared with the standard dose of ticagrelor, it's no different, and prasugrel will continue to prove for better. So, with the guideline of ESC, it's non-STEMI. This is no STEMI. It's the non-STEMI. But as you see nowadays, prasugrel in the acute coronary syndrome, prasugrel we prefer than to ticagrelor, and the two subgroup with the patient, older patient or the white body weight less than 60 kilograms, we have a half dose of the prasugrel. We change from 10 milligrams to 5 milligrams. And one more another antiplatelet drug. This is GB2B3A or cangrelor. And when we compare cangrelor with ticagrelor, if the labor time is no different, but if we need the effect very soon, it proves for cangrelor. So they say the triple antiplatelet, it means the third antiplatelet drugs, it will have the role in the situation look like the patient with the cardiogenic shock, or some situation we need the effect of antiplatelets as soon as possible. By now, we go to the another group, the anticoagulation. For the long time, the heparin, ultrafluorescent heparin is the standard treatment for acute for STEMI, and recently a pivalirudin become one the drug for we can consider after a STEMI, but the data recently, when we compare pivalirudin and heparin, we can see if a major bleeding, pivalirudin look like better, but the stem thrombosis, heparin continue to keep the role. So by now, the routine ultrafluorescent heparin is recommendation, which the recommend class 1 and the level of evidence C. Pivalirudin from 2A become 2B. So I can give the conclusion for the anti-properties of acute coronary syndrome or acute MI. In the STEMI, ST elevation MI, we should treat the anti-thrombosis, treat early and treat strong. In STEMI, in some situations, look like cardiogenic shock, we can use triple antiplatelet therapy. It means DIBT in combination with the cantilor or someone. And one more, the new concept is about the bleeding. In the 2019, we have the new definition of the high bleeding risk from the high bleeding group. According to the kind of the definition, we have the two groups of the criteria, major criteria and minor criteria, and the patient consider as the high bleeding risk if the patient have one major criteria or two minor criteria. And the major criteria consists of the 12 criteria, and minor is the 6 criteria. And to keep in mind easy, we can classify for 6 groups. The first group icing, the second group called PDT, the second group laboratory, the 4 CNS, the 5 bleeding history, and the last iatrogenic. And one group we can have a minor or major criteria, such as if the patient is older patient, it's a minor criteria. With the renal disease, we can severe renal function decrease if we major criteria, if a higher is the line. So we finish my presentation. Thank you for your attention.
That was wonderful, a fantastic and very comprehensive discussion of a complex topic. I think we should probably move along, and I'd like to introduce Deepak Karya from Arizona, USA, to talk about when and how we need hemodynamic support for primary PCI. Thanks, Deepak.
When and how we need hemodynamic support for This is Deepak Karya from the University of Arizona, and we're going to talk about when and how we need hemodynamic support for primary PCI. So you can consider hemodynamic.
Can we increase the volume, perhaps?
Different situations. One is cardiogenic shock, other is cardiac arrest, and the third is non-cardiogenic shock. So when we're talking about the hemodynamically stable patient with acute MI undergoing PCI, historically there's been a lot of interest in preventing reperfusion injury and a lot of investigation as to whether or not mechanical support in patients undergoing PCI will decrease reperfusion injury and infarct size. One of the most important studies in this area was the CRISP-AMI study, which looked at anterior STEMI patients without shock and randomized them to intra-aortic balloon pump prior to PCI versus standard of care PCI. And they looked at MRI and clinical events. And they found that at 6 months, there was no difference in all-cause mortality. However, on exploratory analyses, there was some benefit in terms of composites of death, shock, and new or worsening heart failure. Another sub-study of the CRISP-AMI trial showed that in the setting of persistent ischemia on the right side of your screen, where there's persistent ST changes or less than 50% ST resolution, there seemed to be a benefit of intra-aortic balloon pump over medical therapy. Another device that has been studied for unloading during reperfusion is the Impella platform. In the door to unload STEMI pilot trial, they had 50 patients, all of whom underwent Impella. Half of them had delayed reperfusion, half of them had immediate reperfusion. There was no standard of care group, and there was no difference in infarct size with delayed reperfusion with an Impella. The thought is that the Impella prior to reperfusion activates some cardioprotective mechanisms. The phase 3 study is underway. So in summary, in hemodynamically stable patients with acute MI undergoing primary PCI, there is no current role for routine mechanical circulatory support. A balloon pump is indicated for mechanical complications such as MR or persistent ischemia, or in selected cases prior to bypass. The use of Impella to unload the ventricle and prevent reperfusion injury, it's in clinical trials. It is not standard of care. There is limited randomized data for non-balloon pump devices. And if MCS is being considered, available data suggests that it is better to implant prior to the PCI instead of after PCI. So now we're going to talk about cardiogenic shock patients. Historically, the intra-aortic balloon pump has been by far the most commonly used agent or device for acute MI shock. However, with the IABP Shock 2 trial, there has been a significant change in how people approach balloon pump in the setting of acute MI shock. So this was a large randomized trial comparing two groups, one with intra-aortic balloon pump and optimal medical therapy, including primary PCI, and group 2 is optimal medical therapy but no balloon pump. And there was no significant mortality difference. This led to a reappraisal of IABP in cardiogenic shock and also a downgrading in some guidelines. So in summary, the balloon pump should not be the primary support modality for all post-AMI shock. However, it may still be used for short-term rescue. No trial has looked at very short-term or bridging strategy with a balloon pump or patients with mild shock. For other populations, such as mechanical complications, persistent ischemia, high-risk surgery, weaning off cardiopulmonary bypass, there is data on the efficacy of balloon pumps. There's data also to suggest improved outcomes when implanted prior to PCI. Next, we talk about the Impella platform. If you look at the randomized data for Impella, there is no survival benefit over balloon pumps. But these trials are fairly small trials. When you look at registry data, the interpretations become more complex. This is from the Impella CVAD registry of the acute MI shock population, which suggests that device implanted prior to PCI was associated with better outcomes compared to post-PCI. This is the Detroit Cardiogenic Shock Initiative, which was a multi-center, protocol-driven management of cardiogenic shock with hemodynamic assessment, Impella as the primary MCS device, post-PCI hemodynamics, escalation, and protocols. This showed that compared to historical controls where survival to discharge was 51%, post-protocol, the survival to discharge was around 75%. However, it should also be recognized that there may be patients who are too sick to benefit from this therapy. This was the IMPRESS shock trial, which looked at about 48 patients, half of which went a balloon pump and half underwent Impella. And these were sick patients. Most of them were intubated. The vast majority of them had cardiac arrest. In this population, Impella did not seem to have a benefit over a balloon pump. Most of the deaths were neurologic in origin. So in summary, for Impella, there is no randomized data showing survival benefit. However, it should be recognized that cardiogenic shock is a heterogeneous process, so the benefit of any MCS may occur at certain stages and levels of severity. So it is important to have risk stratification methods such as the SKY shock, which may identify appropriate populations for specific MCS devices. Impella may have benefits when used as a component of a multifaceted shock management approach. If planning to use it, consider insertion prior to PCI and recognize that there may not be benefit in advanced cases or cardiac arrest, such as the IMPRESS shock population. The next device we'll talk about is the tandem heart. It is a left atrial to aorta assist device. It is percutaneously inserted but requires a transeptal puncture. It provides excellent hemodynamic support, but is technically more difficult because of the need for transeptal puncture. So the utilization is relatively low, and there are no randomized trials in acute MI shock. Next, we'll talk about extracorporeal membrane oxygenation, or ECMO. For our purposes, we're talking about VA ECMO, venous arterial ECMO, which provides oxygenation and circulatory support. Advantages are device cost is lower compared to some of the comparators, can provide biventricular support, oxygenation, quick bedside cannulation. But there are disadvantages, limb ischemia. It should also be recognized that it supports circulation and an organ perfusion, but not necessarily cardioprotective, and LV distension is something you have to watch for. There's no randomized data, but there are trials ongoing. For the data of ECMO in cardiogenic shock and cardiac arrest, we'll look at a systematic review and meta-analysis where they screened about 1,000 papers and ultimately ended up with these articles, 4 about cardiogenic shock and 9 in cardiac arrest. And what they found was that for the cardiogenic shock population, compared to intra-aortic balloon pump, ECMO or extracorporeal life support seemed to have survival benefit. There was no significant survival benefit compared to Impella or tandem heart. For the cardiac arrest population, there seemed to be a benefit as well for ECMO compared to controls. And that benefit persisted in a propensity matched group. There was about 13 to 14% improvement in 30-day survival and 13 to 14% improvement in favorable neurologic outcomes with use of ECLS compared with patients in whom ECLS was not used. This was maintained on a propensity score analysis. Another study we performed recently looking at post-MI shock and ECMO from the ELSO registry. Some important points: survival to discharge was 40% in the MI population, not different from the non-MI population. MI was not an independent predictor of mortality in multivariable analysis. About half could be decannulated for expected recovery. And for people who had ECMO during cardiac arrest, survival to discharge was around 29%. So the role of ECMO in acute MI shock, it may be the most efficacious device in cardiac arrest or profound refractory shock. Early institution before the onset of multi-organ failure or arrest is associated with better outcomes. It is important to note that supporting the ventricle versus supporting the patient and end organ perfusion may not be always concordant. There's no randomized trial data, although the studies are ongoing. Non-randomized data don't show any differences between ECMO and Impella 5.0, but there are selection biases. So overall, most patients with acute MI undergoing primary PCI don't need any hemodynamic support. Decisions should be individualized based on the degree of shock, amount of support needed, patient characteristics, and importantly, institutional experience and device availability. There is not one device that is ideal for all situations. Some patients with mild shock who get promptly revascularized may not need hemodynamic support. But in general, when shock ensues and if you cannot manage it easily with revascularization or low doses of vasopressors, strong consideration to MCS prior to onset of multi-organ failure. Device insertion prior to PCI, more benefit compared to after PCI. And you should also recognize that some patients may be too sick or too late in the process of shock or cardiac arrest to benefit from any kind of hemodynamic support. Thank you for your time.
Wonderful talk. Very wonderful talk. That's a cardiogenic shock, hemodynamic compromise are areas of intense focus right now, and congratulations on that excellent work. I think we ought to move right along. Dr. Lowe, Josh, if you could give us your thoughts about how to deal with no flow in primary PCI.
Thank you very much, and it's a pleasure to be involved in VNCC and this Sky Fellows course. So my talk is kind of related to what Greg has talked about earlier on how to deal with large thrombus burden. This is on no reflow phenomenon, and basically this is already happened already, so how to deal with it. So I do not have any conflicts of interest. So we'll start with a case. This is a 45-year-old male who came in with an anterior ST elevation MI, and clearly the culprit is in the LAD with large thrombus burden. So we did primary wiring, and our first step was to do aspiration thrombectomy, which didn't really work in this case. So we moved on to do balloon angioplasty, and we kind of restored the flow, TIMI 2. We were fairly confident we could see the distal landing zone, and we didn't want to do anything more because we're worried about more embolization. So we went ahead to place a stent. So the stent was deployed, and this is the immediate result after the stent. So there is an appearance of no reflow here. Okay, so what is no reflow? Coronary no reflow is defined as the inability to perfuse the myocardium after opening a previously occluded or a stenosed epicardial coronary artery. And we know from literature and many registries as well that coronary no reflow is associated with larger infarct size, reduced LVEF, and even cardiac mortality. And even transient no reflow in primary PCI is associated with higher in-hospital and longer-term mortality. So this brings us back to Greg's talk on, how to prevent, how to deal with the large thrombus burden, which is actually very important. Now, the mechanisms responsible for no reflow is many, and there is a complex interplay of factors, including distal embolization of thrombus, the presence of ischemic injury, reperfusion injury, and individual susceptibility. So the cartoon on the right summarizes all these mechanisms in one picture, which you can just quickly glance over. So how do we diagnose no reflow? We use the TIMI scoring system. Now the TIMI grade is 0. That means no contrast, no flow actually reaches to the distal vessel. We call it no reflow. If the TIMI grade is 1 to 2, we call it slow flow. But this is, of course, only if there is an absence of a residual stenosis. So how do we confirm on this? We actually need to exclude, very importantly, a distal stent edge dissection. So what I usually do is I usually pass a microcatheter beyond the distal stent edge and just do a small distal injection through the microcatheter. And if there is patent flow distally, but there is an obstruction proximally, it could be an edge dissection, then it is a proximal and a mechanical problem that you have to fix. But if there is no proximal obstruction, and so we know that the slow flow is from a microvascular cause. So this is one example of how we use the distal injection to determine. So this is a patient who had an LAD stent. And right after the stenting, there is no reflow. So what we do is we pass a aspiration thrombectomy catheter, use it as a microcatheter along the rail of the guide wire, and do a small distal injection. In this case, you can see that proximally, especially at the distal stent edge, it looks okay. There isn't any edge dissection. So we can assume that the slow flow is due to microvascular causes. And in this case, after giving some IC nitroprusside distally, the slow flow is resolved. So in the assessment of no reflow, it is important to firstly exclude another cause, such as thrombus, spasm, dissection, or an embolism. We also need to make sure that the patient is hemodynamically stable. This may involve giving pressor agents, putting in an IBP, giving high flow oxygen, or if the patient is bradycardic, even have to pace the patient. Concomitantly, we have to check the ACT, make sure the patient is well anticoagulated. And there is a whole host of medications that Greg touched on briefly that we can give to treat no reflow. So this article by Lowe Sadler actually summarized most of the common agents that we usually give for no reflow. They fall into different groups, include the purine nucleosides such as adenosine, the calcium channel blockers, the beta-2 agonists, and even your antithrombotic agents. Now, how do we decide one from another? There isn't actually any real data to show the superiority in terms of clinical outcomes of one agent versus another. Although there is a small study showing that angiographic outcomes are actually improved with nitroprusside compared to a few other agents. But if you look at this chart, I think it's quite comprehensive that each of these agents also come with their sets of side effects. So for example, if you have a patient who comes in with an inferior ST elevation MI, and he's already bradycardic, hypotensive, and there is no reflow, it might not be a good idea to give adenosine or verapamil. Maybe it's a better idea to give something like epinephrine. So it depends on a case-by-case basis. Or if the patient is tolerating it well, I tend to give nitroprusside if the BP can take it. If there is large thrombus burden and we think that majority of the no reflow is due to the thrombotic load, we may want to instill some fibrinolytic agents like what Quant described, or even give some GP2B3 agents. But what is important is actually how to deliver the agents. There are, of course, many ways to deliver the drugs. The simplest, but the most ineffective is to give through the guide catheter. Although it's inexpensive and it's easy to give, but a lot of the drug gets washed back into the aorta and you lose the effect in the coronaries, whereas you suffer from the systemic side effects. So this is not recommended. There used to be a Clearway catheter, which is used in the INFUSE AMI trial for targeted drug delivery using a perfusion balloon, but this is no longer available and it's a very rigid system. What most people tend to do, and that's what I usually do, is to use microcatheters. We run it through distally, and I tend to favor using the thrombectomy devices because with this, I don't lose wire position. If you use your usual fine cross or Corsair, you have to actually take out the wire to instill your drugs. Well, this is easily available, it is cheap, but sometimes it may be difficult to actually rail it down distally. In this article, there was a reference to another article whereby the authors actually use a modified 2O balloon to actually track down the vessel. It is easily available and has superior tracking. And with certain punctures on the balloon, the authors were able to deliver the drugs distally and also within the lesion. Let me give you some pictures of how it's done. I'm not sure about the panel, but I've not done this. One or two of my colleagues have done this and they find that it's quite useful. So you inflate the balloon outside the body, and you actually puncture some holes using a 26 or 27 gauge insulin needle, such that you cause these perforations here. And you actually put your drug into the indiflator. Now with this balloon, you can see from the angio stills here, you are able to track the balloon fairly distally, and with just a 2-hemisphere inflation of the indiflator, you are able to expel the drug distally and also treat it at where you think the no reflow is occurring, proximally at the lesion itself. And in this image, you can see that the restored. So in my case, what I did was I ran a thrombectomy catheter down. I think it was a Thrombustor. And I gave some nitroprusside distally, and the no reflow was restored. The flow was restored already. So the conclusion from my talk is that coronary no reflow can occur in AMI with large thrombus burden, and this is known to be associated with increased morbidity and mortality. Although the mechanism for the no reflow phenomenon differs, including distal embolization and ischemic reperfusion injury, the diagnosis of no reflow should be suspected in any situation of impaired coronary flow. We have, of course, need to exclude dissection and coronary spasm. And we need to treat the no reflow with intracoronary drugs. And more importantly is that we have to deliver the drugs distally. So thank you very much for your attention. And I'll stop the screen sharing here.
That was wonderful. Thank you.
Thank you.
Go ahead.
Can you hear me now? This is our last presentation today, right? Yeah.
Yes. So that was wonderful. So I think that the great thing about no reflow is it's not a simple matter. You think it's, you don't want to see it, but it's not always treated the same, because no reflow can occur, as you point out, from anything from the guide to the tail of the vessel, and you have to rule out something at the lesion, something before the lesion, something after the lesion, and that detective work is critically important in order to get a good outcome, and you laid that out nicely. So that's wonderful. I don't know if we've got a minute or two here to talk about any of the other topics that came up this afternoon. Does anybody have anything else they want to say?
Greg, just a quick minor teaching point. I've seen people try to treat no reflow with nitroglycerin. That doesn't work. I think Dr. Lowe pointed out very nicely that you have to use microvascular vasodilators. Nitroglycerin is an endothelium independent, but only acts on the epicardial arteries, not the microvasculature.
That's an excellent point. Yeah, it could work if it was a guide catheter spasm or something proximal, but you're absolutely right. For that distal no reflow, for the humeral effect, I think you really need. You're right. The microvascular active agents.
Yeah, and the point that Dr. Lowe made about local
emergency.
Es ist ernst. Nehmen Sie es auch ernst.
Le moment que nous vivons est un ébranlement.
Thực hiện cách ly toàn xã hội trong vòng 15 ngày kể từ 0 giờ ngày 1 tháng 4.
Đại dịch Covid-19 là một thách thức chưa từng có, gây cho chúng ta rất nhiều mất mát. Mọi thứ bị xáo trộn. Xã hội ngừng kết nối. Cuộc sống như ngưng lại. Nhưng chúng ta thì không.
Truyền hình ở đây, bắt đầu là
đã khoác lên mình tấm áo blue màu trắng thì tất cả các bác sĩ, kể cả các bác sĩ tim mạch, đã bước chân lên hành trình luôn luôn cần phải học hỏi, tìm kiếm và chia sẻ kiến thức.
Trong cái tình cảnh đại dịch như hiện nay thì các bác sĩ tim mạch chúng ta càng cần liên tục cập nhật các cái kiến thức về chuyên môn.
Việc kết nối giữa chúng ta sẽ rất bền vững và sẽ không bị cản trở bởi dịch bệnh.
Chúng ta không chỉ thấy thách thức mà còn nhìn thấy nhiều cơ hội.
Nhờ sự giúp đỡ của công nghệ, việc chia sẻ kiến thức và học tập liên tục suốt đời đã không bị giới hạn bởi khoảng cách và thời gian.
Cơ hội mới cùng tri thức mới sẽ đến với tất cả các đồng nghiệp yêu mến trên mọi miền Tổ quốc Việt Nam.
Chào mừng đến với Đại hội Tim mạch Toàn quốc lần thứ 17.
Yeah, you can start the presentation. I don't see Dr.
Lou. Okay, so let's go ahead and start with the presentation, the second presentation by myself.
Yeah, the second presentation.
Let's go ahead and start that. Every aspect of our life, personally, professionally, politically, economic. And
các em cho cái bài thứ hai lên đi.
Also faced with a lot of challenges in managing our sickest patients, those with acute myocardial infarctions. It's really important to understand that my talk today is going to be linked with a lot of the other lectures in the meeting that also are related to COVID-19. I'm going to specifically be briefly talking about the cardiovascular system in COVID-19. Dr. Finn will elaborate on the pathophysiology and the pathology mechanism. I'm going to briefly talk about PPE, COVID-19, and STEMI. Talk about the effect of COVID-19 had on the incidence of myocardial infarction and the angiographic findings and coronary obstruction findings in patients with ST elevation MI and COVID-19. Talk about the clinical outcomes in those patients and how we manage those patients and what the guidelines say. So I'm not going to spend a lot of time on this slide. Dr. Finn is going to be spending quite a significant time of his lecture talking about the mechanisms of injury. But it's important to understand that COVID-19 presents with a lot of the STEMI mimickers, if you will. Those are patients that presents as if they indeed have ST elevation myocardial infarction, but have other pathological mechanisms of cardiac damage. STEMI indeed can present due to our identified plaque rupture and erosion, but also as a type 2 myocardial infarction. However, through different mechanisms, including immunological mechanisms, as well as direct myocardiocite damage, we can also see myocarditis in our patients, endothelial dysfunction, cytokine storm, and also pulmonary embolism with elevated troponins and methods that indeed mimic ST segment elevation MI. We all got very familiar with the term PPE, as well as using it, putting it on and taking it off. This was a statement that released by SI, again showing the importance of this in the patients as we treat them. At the very beginning of the pandemic, there was a shortage as there wasn't elsewhere in the world. As the pandemic progressed, we're very fortunate to have more abundance of the PPE. It was made, available, readily available, particularly in the acute settings when we had patients to take care of with unidentified COVID-19 status. COVID-19 impacted the incidence of acute myocardial infarction hospitalization in locations where lockdown was enacted. And you can see here in this study from Kaiser Permanente, which is a very large health system in Northern California, where there was a decrease by 48% in both the incidence of non-ST segment elevation and ST segment elevation myocardial infarction. This is a 43 million patient week. And you can see blue here is the COVID-19. As COVID-19 increased, you can clearly see the line in red, which is the acute myocardial infarction admissions, going down in incidence compared to the same period in 2019. And it really matches up nicely with the COVID-19. This was not a phenomenon that was just seen in the United States. This is another study from Italy, again showing a decrease in the incidence of all myocardial infarctions and in both the ST segment as well as the non-ST segment elevation myocardial infarction within 1 week that was studied in Italy. Now, interestingly enough, in this paper published in Circulation, that 28 patients who came in with ST segment elevation MI, 40% did not have obstructive CAD on coronary angiography. And it's important to understand that this is despite 89% of them showing ST segment elevation and 11% showing new onset left bundle branch block. And in addition to that, 80% of them having regional wall motion abnormalities on echocardiography, while the remaining 11% showed diffuse global hypokinesis or no wall motion abnormality. This group, despite not having obstructive CAD, had a very high mortality of 40%. Now, the characteristics of patient with ST segment elevation MI in COVID-19 in a study of 115 patients show that they have higher troponin and D-dimer levels than corresponding non-COVID-19 ST segment elevation. They have a higher thrombus burden, higher multivessel thrombus, as well as higher incidence of stent thrombosis and also microvascular involvement with demonstrated lower myocardial brush and lower ejection fraction. It's interesting to note that despite the fact that you don't see necessarily obstructive CAD in 40% of the population, you still see a correlation with mortality. And this is days from illness onset, and this is days from symptom onset. And you can see those with cardiac injury versus those without cardiac injury, a difference in mortality during the time period. And this difference indeed correlates with the levels of troponin, as you can see here. With the rise of troponin, again, this was the difference in survivors. This, interestingly, this high thrombogenicity correlated with higher requirements for heparin doses and higher requirement for GP2B3A use in that study. And you can see that this affected the number of ICU admissions as well as admission length, but did not affect the number of mortality, even though there was a trend. This is probably due to the small number of patients in the study. The management of patients with ST segment elevation myocardial infarction really took an early fork in the road, where a lot of societies and experts were suggesting that maybe fibrinolytics had a role in management of patients with acute myocardial infarction. And you can see that over the pandemic, and as we got more comfortable with it, there was more a shift towards, again, emphasizing the importance of primary PCI. This is an interesting study from Texas that showed that patients with myocardial infarction, on the left is the patients who received fibrinolytic therapy versus the patient who received primary PCI. And you can see markedly increase in the incidence of hemorrhagic stroke in patients who receive therapy compared to ischemic stroke in those who receive primary PCI. It's very startling, the number of deaths in the PCI, but could have been really more a marker of more significant and advanced disease, as represented by the need for mechanical ventilation, CPR, and hypotension, and requirement for hemodialysis. So it's unclear, but it's really interesting to kind of show that this is a very sick and a very different population from the primary PCI patients that we actually normally encounter without COVID-19 and before the COVID-19 epidemic. The European guidelines showed that in patients who presented with STEMI during the COVID pandemic, if they presented to a STEMI network hospital, that the decision was whether or not you can have a PCI within the reasonable allotted time. And those are patients who provided 24/7 cath lab services. If that was a possibility, they received primary PCI. If that was not, they got lytic therapy. Patients who were hospitalized or self-presenting to the hospital, again, if timely PCI was not possible, the recommendation was to administer lytic therapy. If it was possible, then the recommendation would be to transfer to a 24/7 cath lab and to undergo primary PCI. They did confirm, I think, two interesting things. One is that any STEMI patient should be managed assuming a positive COVID-19 status, and also to perform lytics only if obviously not indicated. And that only hospitals that were equipped to manage patients with COVID-19 should maintain their 24/7 cath lab service, which I think was a really interesting recommendation. Here you could see the recommendations from the ACC for patients presenting with ST elevation on their EKG. And at that time, when these recommendations came out, the ultra-rapid COVID-19 testing was available. If it was available, it helped differentiate the patients into either COVID-19 possible versus positive or probable. And you can see that where the fork was, if the patients indeed were positive or probable, and the patient had symptoms consistent with MI, together with EKG findings and a point of care ultrasound was performed to confirm wall motion abnormality, recommendation was primary PCI. However, if there were unequivocal symptoms, atypical EKGs, or the point of contact ultrasound was not clear, echo was done to confirm wall motion abnormalities, and then the decision at that time was to discuss attending about whether to proceed with cath lab activation or coronary CT angiogram. However, if COVID-19 was not, was only possible, was only suspected, then if the patients indeed had symptoms consistent with MI, they underwent primary PCI. However, if there was an equivalent nature, then an echocardiogram to really assess the presence or absence of wall motion abnormalities. Patients who had unknown COVID status in the field and they presented to the emergency department would get focused H&P and consider myocarditis and ultra-rapid COVID-19 testing if available. And if COVID-19 was positive or probable, again, a conversation with the attending physician and to transfer those patients to a dedicated COVID-19 cath lab with universal PPE and ICU isolation bed. It's important to note also that negative ventilation rooms were also suggested in some facilities as well. If, however, the COVID-19 status is only suspected as possible, again, the universal use of PPE, but the ICU isolation status takes a lesser step here in this case, especially if obviously you have a fast COVID-19 screening mechanism. well, how about if you have a STEMI present in a non-PCI referral hospital? There's obviously discussions about whether or not to give fibrinolytics. Again, a lot of discussion on what the possibility or probability of COVID-19 is, and that will depend on the ability and hours of transfer. You could see that primary PCI, again, is always recommended, or fibrinolytics plus PCI with, again, the same recommendations as prior in regarding to the ICU isolation bed. But here you could see that fibrinolysis starts to show up if there's, again, a concern for transfer delays to a primary PCI capable facility. So fibrinolytic therapy, despite it appearing at the initial thought as an attractive mechanism, is associated with higher intracranial bleed, as we showed in the study from Texas, higher incidence of fatal bleed, and 50% of patients eventually require rescue PCI. It also will not benefit the patients who have STEMI mimickers, as we showed in our first slide. So it should really only be limited to the non-PCI hospital when transfer delays are suspected. Another important component of patients with acute myocardial infarction is patients who present with out-of-hospital cardiac arrest and shock. These are the highest patients at risk for droplet infection. If they're futile, if there's really deemed to be a very low chance of survival, no catheterization is recommended. Routine catheterization should only be expected in the presence of hemodynamic instability in a patient who is not futile with persistent ST elevation, high suspicion for myocardial infarction with wall motion abnormalities detected on echo, as well as a multidisciplinary discussion team or the shock team. If a respiratory compromise is suspected, VV ECMO is sometimes required in these cases because of the accompanied pulmonary involvement. So in conclusion, there has been a marked decrease in the incidence of acute myocardial infarction during the COVID-19 pandemic in areas that enforced the lockdown. In about 40% of patients, there will be a non-culprit lesion. These vessels have higher thrombus burden, both within the infarct-related artery and multi-vessel. Patients experience worse clinical outcomes described despite that 40% non-obstructive findings. Primary PCI still remains the primary strategy with the more availability of the PPEs, and also to avoid the complications and further risk stratify the STEMI mimickers. And in out-of-hospital cardiac arrest and shock, it is very important to try to think of the prognosis and whether those patients will actually benefit or futility is a consideration. Thank you very much. I want to again to thank Sky and the organizing committee for allowing me this privilege and honor. Thank you very much.
Good morning. Is Dr. Liu on the line? Okay. I think then we should probably move on and have Dr. Finn present his presentation. Dr. Finn is the medical director of the CP Path Institute in Gatesburg in Maryland. Do we have Dr. Finn's lecture taped? Perfect.
Good afternoon. I'm going to talk to you about the pathology of COVID-19 induced cardiac injury, STEMI mimics. I really would like to thank the organizers at Sky for inviting me to give this talk today. Here are my disclosures. So the prevalence and impact of myocardial injury in patients with hospitalized with COVID-19 is becoming clear. This was one study from Mount Sinai where they looked at troponin I elevations within 24 hours of admission to assess myocardial damage. And you can see that there were a lot of comorbidities among the patients in this group. In all, 36% of patients had elevated troponin I concentrations, and of these, 18.5% died during hospitalization. After adjusting for disease severity and relevant clinical factors, even small amounts of myocardial injury were significantly associated with death and other comorbidities. Myocardial injury is prevalent among patients hospitalized with COVID-19. It's certainly known, but we don't really understand what the mechanisms of cardiac injury are. Here is an illustration of that same paper where we show different levels of coronary elevations. You can see going from 0 to 0.3, from 0.3 to 0.9, and greater than 0.9. You can see there's a progressive increase in mortality and a decrease in discharge among patients with higher troponin elevations. Now, there's been a lot of speculation and data coming out, especially from the MRI world, about patients recovering from COVID-19 and what the long-term effects are on the heart. You can see in this one particular paper in JAMA Cardiology, a total of 78 patients recently recovered from COVID-19. 78% had abnormal CMR findings, really raised native T1 and T2 signals, questioning whether this was some kind of myocarditis or a long-term effect on the heart. And of course, the news media has picked up on these findings and suggested that COVID has a terrible effect on the heart, and that even if you don't have any symptoms, it could have long-term effects. Well, what is the actual evidence for COVID-19 induced injury? What are the mechanisms of injury? We wanted to do a systematic analysis to understand how COVID-19 infection might affect the heart and what types of thrombi might be formed. This was done in collaboration with the hospital Papa Giovanna 23rd in Bergamo, Italy, and Dr. Guayumi there. In this series I'm going to show you, we had received the hearts of 40 patients who had died during hospitalization during the height of the pandemic in Bergamo for pathologic analysis. And this is how it all started. This was one of the first cases we had investigated at CV Path. This was a case from Bergamo in Italy of a 43-year-old woman who had complained of onset of chest pain while assisting her husband. He had been hospitalized due to COVID-19 interstitial pneumonia. A 12-lead EKG performed 2 hours after symptoms documented ST segment elevation. She was transferred to the hospital for urgent PCI. On admission, she was awake. Her blood pressure was low. You could see systolic was 70. She was breathing room air, but and her PaO to FI2 was normal, but her LV function, as looked at by echo, was severely depressed, and those were her labs. Troponin I was extremely high. Here's the presenting EKG showing ST elevation in the inferior leads. You can see that quite clearly, 2-3 and AVF. Here's the angiography. You can see left coronary was normal, as you can see. The right coronary was also normal, as you can see. So it didn't actually have clear diagnosis. The nasopharyngeal swab was positive for SARS-CoV-2, and she was actually started on a combination of antiretroviral therapies in the ICU, perhaps for her viral COVID-19 infection as well. She essentially went into cardiogenic shock, would remain hypotensive. EKG eventually ended up showing diffuse ST elevation. There was a pericardial effusion. And because really she went downhill quickly and they weren't sure what was going on, they thought maybe she had myocarditis. They treated her with methylprednisolone and IV heparin during the stay. She developed irreversible multi-organ failure. She had multiple signs of coagulopathy, and she ended up dying 46 hours after admission. Here's what the heart showed. This was a wake-up call for us. We didn't see, as you saw, any epicardial disease, but what we saw instead was we saw multiple microthrombi in the inferior and lateral walls of the heart, as well as the posterior wall of the right ventricle, which was causing massive myocardial necrosis and acute inflammation. You can see here on the illustration, there were also multiple areas in the kidney and spleen of microthrombi as well. This was the first case where we understood that COVID-19 could cause microthrombi in the absence of epicardial coronary disease. And in this lady, that was certainly the cause of death with cardiogenic shock, RV failure. Now, we did a more systematic evaluation in the 40 hearts we received from Italy. And we said, how many of these hearts had myocardial necrosis or myocyte necrosis, and how many did not have myocyte necrosis? They were divided. Of the 40 hearts, 14 had myocyte necrosis, that is injury, and 26 did not have injury. You can see here, we divided myocyte necrosis into acute myocardial infarction, defined as greater than 1 centimeter squared, cardiac necrosis versus focal myocyte necrosis, that is less than 1 centimeter squared. You can see that in our series, epicardial coronary thrombus was found in 2 cases with myocardial necrosis, but the far more frequent finding was microthrombi, found in 9 of the 14 cases, 64% of those with myocardial necrosis. The incidence of coronary artery disease, coronary stents, or single vessels or multivessels was really not significantly different between those with and without myocardial necrosis, suggesting that that did not play a large role. In terms of lungs, we didn't find any difference in terms of diffuse alveolar damage, pulmonary artery thrombus, or microthrombi in the lung in terms of difference between those with myocardial necrosis and no necrosis. Myocardial infarction here, I'm reminding you, was defined as necrosis greater than 1 centimeter squared. This is a typical example of a myocardial infarction. You can see the transmural evidence of myocardial infarction in the anterior septal wall here. Whereas focal myocardial necrosis, small foci of necrosis scattered throughout the heart are shown here, and you can see here in the H&E stain the capillaries that are surrounded by or filled with some sort of fibrin thrombus content. Here is a listing of all of those cases, of the 14 cases we found, and you can see 2 of them had AMI, that is epicardial coronary artery thrombus, so a typical STEMI thrombus, whereas one of them with AMI, the one I showed you earlier, had diffuse microthrombi causing large areas of myocyte necrosis. Most of the cases of microthrombi had isolated myocyte necrosis, as you can see here, and the distribution is shown there. And there were 4 cases where we could not find, 3 cases where we could not find any thrombus at all. You can see when we looked at the differences between patients with and without myocyte necrosis, you can see that the coronary burden, heart weight, LV cavity size, LV wall thickness, RV wall thickness was not significantly different. We then said, let's look and examine whether or not there are differences in the composition of the thrombi between those with epicardial STEMIs, where thrombi could be extracted, and those microthrombi. So in this series, what we did was thrombi were extracted from STEMI cases, not the ones, not autopsy cases, but actual STEMI cases, both COVID positive and COVID negative STEMI cases, and compared to microthrombi. What I'm showing you here is the staining for different elements of a thrombus in terms of those descriptions. What you see is CD61 is for platelets, von Willebrand factor, as you know, procoagulant, fibrin, D-dimer, and C5b9 is complement cascade. And what you really see here is that for fibrin as well as for complement, there was significant difference between the microthrombi and the aspirated epicardial coronary artery thrombi, showing you the microthrombi have different constituents. They're much higher in fibrin and much higher in complement. Well, a little bit about myocarditis as well in terms of the talk. Acute myocarditis is a disease of variable progression and presentation, making it one of the most challenging diagnoses in cardiology. Pathogenesis of myocarditis consists of distinct pathologic phases. The first phase is destruction of cardiomyocytes due to the occurrence of virus-mediated lysis. The second phase is immune response, which is triggered by myocyte injury, infiltration of natural killer cells and macrophages, followed by lymphocytes. In the third case, you can get dilated cardiomyopathy, may result as a result of extensive myocyte injury. The histologic criteria of myocarditis was initially diagnosed according to the Dallas criteria, which is defined as histologic evidence of inflammatory infiltrate within the myocardium, associated with myocyte degeneration and necrosis. More recently, more specific immunohistochemical criteria have been added because of the shortcomings of the Dallas criteria, and there's certain immunohistochemical definitions of the amount of leukocytes needed to be seen per high power field for the diagnosis of myocarditis. Obviously, it's a pattern of inflammatory infiltrate around the myocytes, extended presence of myocardial degeneration that defines myocarditis. Obviously, if virus can be retrieved from the heart, that strengthens the diagnosis of a viral myocarditis. Here is a review of the literature in terms of how many, this is our own case series where we looked at all, for 16 of the cases for any evidence of myocarditis. Although we found epicardial inflammation in some of these cases, we could not find any of the cases fit the histologic criteria for myocarditis, showing you it's not a common effect of COVID-19 infection. And here we see, we then said, well, can some infiltration of inflammatory cells into the heart be part of the COVID-19 disorder without causing myocarditis? So we compared cases of traumatic death control cases to COVID-19 cases, to severe myocarditis cases. We said, how many inflammatory cells are within each type of case? And when you see, when we compared the control cases to COVID-19 deaths, we didn't really find any difference in the total number of inflammatory cells in terms of T cells and macrophages. But you can see when we looked in terms of specifics at T cells, there were significantly less T cells in COVID-19 hearts, but significantly more macrophages, showing you that there can be some inflammatory infiltrate in the hearts. It doesn't necessarily meet the criteria for myocarditis. It doesn't mean that the case is myocarditis. When we look at the literature and said how many cases that have been reported in the literature, pathologic cases, met the criteria for myocarditis in terms of COVID-19 infection. This is a list of all the papers we reviewed. You can see the authors reported as an incidence of myocarditis of about 8.2% in this series of 128 autopsy cases and 7 endocardiomyopathy biopsies, whereas we thought the criteria for myocarditis was met only 3.7%. Overall, showing you that myocarditis is not a common diagnosis with COVID-19. So in summary, our study is the first to examine systematically the cause of cardiac injury in patients dying of COVID-19 infection. 35% of subjects dying with COVID-19 had evidence of cardiac injury identified by the presence of myocyte necrosis, with the majority having focal myocyte necrosis. The majority of the cause of myocyte necrosis was microthrombi, occurring about 64%. They were different thrombus constituents with richer fibrin and complement compared to aspirated STEMI thrombi, both COVID-19 positive and COVID-19 negative. By the way, those COVID-19 positive and COVID-19 STEMI cases were not different in terms of their constituents. Our data suggests that microvascular thrombosis should be entertained as a likely cause of cardiac injury in hospitalized patients with COVID-19, and further investigation of antiplatelet, anticoagulant, and anti-complement therapies are probably indicated to help improve the outcome in patients with cardiac injury and COVID-19. So with that, I'd like to thank you for your attention.
Thank you very much, Dr. Finn. That was an excellent review of, I think, something that really challenged us all during the early parts of the pandemic, trying to figure out exactly what was happening with patients coming in with STEMI and taken to the cath lab, and we don't find any obstructive epicardial disease. And I think the more we obviously are seeing and going through the pandemic, the more we understand and learn with your excellent work and others. We're going to move on to Dr. Tam Trung. He's an interventional cardiologist at the VA at the Loma Linda University, and he will talk to us about CPR resuscitation of the COVID-19 patient. If we can put on Dr. Trung's presentation, please. Okay, if we don't have Dr. Trung's presentation, Dr. Trung, can you go ahead and present live your lecture?
Okay, let me bring it up.
You'll need to be able to share your screen. If we can give Dr. Trung control of the screen to present.
Dr. Tam Trung.
Yes, I'm here. You guys don't have to record it.
Slide,
yeah. I think we've had, there have been some technical difficulties, Dr. Trung. So we just wanted to have a live presentation of your talk, if that's possible.
Yeah, so let me bring up the file then.
While Dr. Trung is bringing up the file, Dr. Finn, I am just
just a couple of questions for you. You know, it was very interesting how you showed there's a difference in the constituents, you know, in the aspired thrombus. And, you know, we obviously on the clinical side saw the more need for heparin and so forth. Do you have any idea about what targeted, you know, PTTs or how much more extra dose of heparin was given in those patients with STEMI?
You know, I don't really have an answer for that since those were done in Italy and sent to us as aspirated thrombi. But I think you're right about whether or not traditional antithrombotics like heparin are effective in this situation. And the Italians had the same experience. I mean, they had the same experience of seeing the ineffectiveness of traditional PTT therapeutic ranges for treating these thrombotic diseases. Now, of course, as you know, these patients get not only venous thrombosis, but arterial thrombosis. So I think it's an unresolved mystery. And I don't know if you know, but there's a specific study that's going on in the United States looking at anti-complement strategies as well for treating these patients. Whether that's going to work or not, I don't know. But those are great questions, I'd say.
And another question that I had for you, I'm sure that you probably also worked on some aspired thrombi in patients who came in with those large ventricles, right ventricles, and PEs and so forth. Was there a similarity between the aspired thrombi and the COVID-19 microvascular disease and the PE patients or the lung biopsies as well?
We did not look at, first of all, we didn't have in our series any aspirated thrombi from PE. We basically had in situ PE. And in fact, in what was interesting is actually, you saw how many of the patients had pulmonary thrombus. It was like 30 or 40% of the cases had PE. And a lot of times the PE was unrecognized because back in the day when this was going on, nobody really understood this. So what we actually found was a lot of these cases were undiagnosed PE. So, but we didn't necessarily compare the, and in fact, sometimes when we saw the PEs, they were already organized by the time we had, by the time we got to them.
Dr. Tâm Trương, it is your turn to give your presentation. Dr. Tâm Trương.
I'll be presenting resuscitation of the COVID-19 patient in the cath lab.
Undiagnosed
interventional cardiologist.
But we didn't necessarily compare the, and in fact, sometimes when we saw the PEs, they were already organized by the time we, by the time we got.
A lot of these issues can also be applicable to resuscitation of the COVID-19 patient outside cath lab. I have no relevant disclosure. Why is this topic important? Because patients with COVID-19 and underlying heart disease have increased risk of cardiac arrest and death. So many of us will be taking care of these patients on the ward in the ICU and also in the cath lab. The virus has high transmission potential, and the resuscitation effort is an aerosol-generating procedure. In general, the goals of resuscitation are high-quality CPR to perfuse the organs and treat the underlying cause of the cardiac arrest. In the COVID-19 patient, we have to also protect the healthcare workers. And in the remaining of the talk, I'll talk about ways to minimize the number of people involved and to minimize the risk of those involved. It's important to know that the prognosis of cardiac arrest in COVID-19 patients is poor. Generally, a lot of these cardiac arrests occur in the intensive care unit or the ward. And in one study, the survival to 30 days was as low as 30%. And these patients generally have respiratory cause of their arrest, and most of them have asystole as a predominant rhythm. Patients who have cardiac arrest in the cath lab are probably different. They're more likely to have a primary cardiac cause, possibly due to procedural issues like ischemia or other complications. They still likely have higher mortality than the non-COVID-19 patients due to concurrent respiratory issues, systemic inflammation, and direct cardiac involvement of the virus. Since many of these patients have poor prognosis, we need to make sure we have goals of care discussion and make careful patient selection for those going to the cath lab. We need to take into account patients' related factor, including their preference and their overall prognosis. So patients who have advanced age, a lot of comorbidities, they generally don't do well. We also need to take into account healthcare related factors. Hospitals should have some general guidelines to support medical decision making. And we're at the time where we have limited resources, so it's important to have policies so we have ethical distribution of resources. One strategy to reduce the number of healthcare workers exposed is to have the fewest people in the procedure room as possible. So we have a skeleton crew of people in the room, and the other people only go into the procedure room if they're necessary. So they all stay in the control room. We also have a dedicated COVID-19 room that we have stocked with all the common equipment that we need for an entire case, so we don't have to open the door to grab items from other rooms. There's some issue with pressurized room that we need to know. Most operating room and also cath lab, they can be positive pressure room, which is supposed to reduce infection to the patient. This is not optimal when we're working on a COVID-19 patient, because this would push the air that's contaminated to the surrounding area. So if you're able to change this to negative pressure or make it just neutral, it's probably better when we perform a procedure in COVID-19 patient. Wireless communication system is one of those high yield items. We've learned this from our electrophysiology colleague. This allows you to have clear communication, and you can close the control room door so other people are not exposed, because it's hard to speak through the N95 mask. Having this will help you communicate better with the rest of the team. A very key strategy to reduce the number of people in the cath lab during a resuscitation effort is to use a mechanical chest compression device. So usually when somebody has a cardiac arrest in the cath lab, we need at least 2 people to alternate and do chest compression with their hands. This is really not an optimal thing in the cath lab, because they're close to the radiation, and also we have to image, and they have their hands on the chest, so it's very hard to see. And there's a lot of interruption to the compression, so the patient's not getting circulation when the compression is paused. So with the compression device, you can basically take out 2 people from the room, so they're not exposed to the virus. And nobody's getting really unsafe radiation by being so close to the detector and the X-ray tube. You also get consistent superior hemodynamics compared to the chest compression without pauses. Some animal studies actually show that this translates to superior survival. You can also defibrillate the patient while chest compression is ongoing. You can also do angiography while chest compression is ongoing. So, on the left here, this is what we want to avoid. You see somebody's hand with rings on here. They're trying to do chest compression. It's not only less effective, it's also you're also exposing them to the virus and also to X-ray if they're doing it on the COVID-19 patient. So here is the chest compression device that's ongoing here. So nobody's standing there, and you can actually do angiography while this is ongoing. Because the device in the middle, you can use angulated views and still get pictures of what you need most of the time. So here is a tracing of the hemodynamic in one of our animal studies using a chest compression device. So you get pretty consistent. There's a whip artifact, but you can usually get systolic pressure about 100. Here are the available mechanical chest compression devices. The one we have is the Lucas right here, but there are other devices here as well. It's important to identify infected patients before they come to the cath lab, so we can be prepared. In our hospital, we screen everybody who comes to the cath lab except for STEMIs or other emergency cases in which we treat as if they were positive. Airway management, there needs to be a hospital-wide policy. In our hospital, we have the anesthesia team doing all the intubations and a backup emergency department team. In patients who have borderline respiratory status, it's probably a good idea to do the elective intubation in the negative pressure room before bringing them to the cath lab. It's not an optimal thing to do emergent intubation, but if it's needed, consider doing that early in the code rather than later. By this time, I hope that most places do have adequate personal protective equipment. What's important that these equipment need to be readily accessible for the resuscitation team. It's important to take appropriate time for the donning and doffing process, and it takes some practice. The rate of transmission should be very low to none if appropriate PPE is used. I've been told in our hospital, in patients who were identified having COVID-19, we had 0 healthcare worker who contracted the virus, including nurses who are in the room with them for 12 hours. Some hospitals have availability of ECMO or extracorporeal membrane oxygenation, also known as ECPR. The outcomes of ECPR in COVID-19 patients remain unknown. We know that in non-COVID patients, the best outcomes for using this in cardiac arrest are those who had a cardiac etiology with a shock of a rhythm. So this may be considered in experience center with careful patient selection. The nice thing is when you start ECPR, you can stop chest compression, which may reduce aerosol risk. This also allows time and opportunity for the interventionist to treat the underlying cause of the cardiac arrest. In summary, it's critically important to have protocols and policies in place. This include policies for patient selection and goals of care, patient screening, airway protocol. It would be a good idea to have a dedicated COVID-19 cath lab stocked with the usual equipment so the room doesn't have to be open to grab other equipment. And it's important to have readily accessible PPE. The hospital should consider purchase and use of high-yield equipment. In my opinion, the most valuable resource in the hospital is the people, so we need to protect them. So if we need to buy a wireless headset system and a mechanical chest compression device to protect people, I think that's well worth the money. Thank you.
Thank you for the excellent talk. I'd like to ask my co-moderator, Dr. Ho, about their experience with lytic therapy. And did you notice early in the pandemic an uptake in the use of lytic therapy for patients who had a suspected acute myocardial infarction and ST elevation under EKG? I think you're muted, Professor Ho. I think you're on mute.
In Vietnam, the strategy to do reperfusion therapy for the STEMI in the COVID-19 periods, I think a little bit different from another country, because strategy for reperfusion therapy for QMI in COVID-19 belong to two things. The first, reperfusion therapy emergency, I think every doctor knows about us. But the second, very important, the policy of the government and the health ministry apply for to prevent to against the COVID-19 in Vietnam, because our country, the ability is limited. So the government and the health minister of health give the policy to quarantine, prevention, to isolation the COVID-19 patient. So when the patient infect COVID-19, they don't go to any hospital look like your country. They were isolated in the infectious disease specialized hospital. So I think Vietnam Society of Cardiac Intervention give the strategy modify, not look like your country. We give it the three attitude. The first, delay or selective PCI. It means after the patient will determine COVID-19 positive change to the negative and the hemodynamics stable. Look like a STEMI go in with the stable hemodynamics, or maybe golden tie across. And the second strategy is the acute reperfusion therapy, but non-BCI. We use fibrinolysis because the patient not in the cath lab in our department. The patient inside the isolation hospital. So if the patient get STEMI, we send the cardiologist go to there and to do the fibrinotherapy. And the last choice is emergency PCI. It means the primary PCI when the patient have a STEMI with the unstable hemodynamics or hemodynamic unstable with the non-STEMI. We must do primary PCI or emergency PCI, but in the cath lab dedicated for COVID-19. It means the cath lab will supply with the PPE enough, but in the Vietnam by now we don't have the cath lab with negative pressure.
I see. Thank you. Yeah. Dr. Trung, I have a question for you. You gave an excellent review of CPR resuscitation in the COVID-19 patients. I was wondering if you ever had a chance to take any of those patients who had either pulmonary emboli and delivered any pharmacomechanical therapy or any type of right ventricular support. There was a large number, as we all know, in our own institution. We did a study showing that out of all the COVID-19 patients, only 8 to 9% got echocardiograms and a much lesser number got CT scans. So in your experience, did you apply any pharmacomechanical or RV support systems for those patients?
Personally, no. I've known friends from other institutions who've done the VV ECMO for those patients. They use either the Avalon device or another ECMO where they put both cannulas in from the groin and from the neck, and some even use a tandem lung to do that. But personally, no.
Dr. Phiên, a question for you. We've heard earlier on the benefit of steroid therapy in patients with COVID-19. Do you think that, with the understanding that there's really no treatment for myocarditis, but do you think that any benefit with what you showed us in the pathology could have been benefited cardiac-wise from administration of steroids?
That's a great question. I do believe that a large portion of what I'm showing you is the effect of the immune system on the coagulation system. So, you get COVID, the immune cells get ramped up, especially the macrophages, they release cytokines, and those cytokines cause a procoagulant state. That's a simplified version of it. So I do think that there is a role in the patients that have evidence of overactivation of the immune system, increased D-dimer, things like that, steroids may be beneficial. And we showed, I didn't show you the data today, but we've shown that when you give the COVID-19 spike protein to cells and you also use steroids, you really immunosuppress a lot of the cytokine storm that occurs. So I think there is a role.
Yeah. Alok, can I ask a question as well? From your data, would regionality on an echocardiogram help you differentiate, whether this might be a de novo epicardial thing? Did you find uniformity in the thrombosis, or was it in some cases still regionally patchy? Because, you know, one of the ways we distinguish what we are about to do is
right,
we try
exactly.
to echo on the patient.
Well, so Juan, that's a great question. The microthrombi that we discussed with you, you know, those were, a lot of the cases were isolated microthrombi. So although they may have some wall motion, it may not be easily apparent. In in STEMI, epicardial STEMI, where there's thrombus in the corner, of course you'd have wall motion. But in some of these cases, I don't think you might have a lot of wall motion because these are small foci of infarction. And so I don't know how sensitive. We actually went back, and this paper is in submission now. We went back and looked at how many of these people with microthrombi had EKG changes, how many had abnormal echoes, except now there was some missing data. So let me qualify, not everybody got everything, EKG echo. But it turned out that the EKG was the most sensitive for detecting microthrombi, but even it was not. Only like 50 or 60% of the cases of microthrombi had significant EKG changes. So we don't really have a good way of detecting these in the clinic, as far as I can tell you. And what will we do to treat them? We have no real treatments.
Yeah. I've been, you know, just from an extrapolation standpoint, in any patient I've seen with COVID-19, because of, you know, your data and such, who's troponin positive, I've actually put them on DAP, just I would treat a non-STEMI. Do you think at this point that that is a reasonable approach?
I do. I think that's smart, Quan. I mean, if they can tolerate DAPT, I think it's totally reasonable. Now, whether it's going to do anything, it's not clear. I mean, we don't have any evidence that you know, using DAPT, but you've heard these stories. You guys have seen the stories. I mean, our case was a special case where we published that, where, you know, we showed for sure that was microthrombi. But there are other cases in the literature of you know, COVID positive patients who have gotten severe cardiogenic shock, and then they survive and they leak troponin for months afterward, and no one really understands what's going on there. I can tell you that I personally don't believe those are myocarditis cases. I think it's some thrombotic disorder, whether it's microthrombi or some kind of injury. That's my feeling. That's what my understanding from looking at the literature and everything we've done at CVPath.
Do you think cardiac MRIs would help stratify and answer that question?
Yes, I think, well, cardiac, as you know, cardiac MRI is complicated. Its interpretation is non-specific. It in itself, I don't believe, is diagnostic of myocarditis. Now, you've seen the literature says, hey, these people had a normal cardiac MRI there. It's suggestive of myocarditis. But as you know, Quan, the diagnosis of myocarditis is really not an MRI diagnosis. It's really, you need to have really tissue to really firmly diagnose myocarditis. So I think that's one of the missing connections is, so you find an abnormal MRI. Well, what I glossed over, but I maybe should have focused on it, was a lot of the patients who have COVID also have epicardial foci of inflammation. So not in the myocardium, but the epicardium. What does that mean? Would that lead to an abnormal MRI? Who knows? So, you know, that case, Quan, that I showed you of the JAMA cardiology did not have a corresponding control cases where people had viral infections, not COVID, but viral infections. What happens to them? What does their MRI look like?
Yeah. So
I want to comment on the dual antiplatelet. You know, when I don't know if this has been a similar experience with everybody, but I think a lot of those troponins weren't really left ventricular origin. A lot of them were RV strain and RV leak. And so the question of DAPT, you know, in anybody who has, you know, elevated troponin is really a question is how we balance that with the need of, you know, anticoagulants. We had a paper just accepted in the European Journal of Hematology where we actually had almost 3,500 patients in that study, and we looked at prophylactic anticoagulation versus therapeutic anticoagulation and found that the mortality and outcome benefit was better in those who received therapeutic anticoagulation. You've got a patient who you're giving him, you know, therapeutic anticoagulation and DAPT, and they inherently have a higher chance of bleeding, and a lot of them had comorbidities. And so now you put yourself in this debacle. And if you look at the echo series, not just our center, but other centers, you know, taking in mind that it was a small percentage, most of these people had RV enlargements. Very few, under 10% maybe, had left ventricular involvement.
Well,
and so,
what I showed you in my series, Yeah, what I showed you in my series is you looked at the cases with and without necrosis, myocardial necrosis. And majority of the myocardial necrosis were not in the right ventricle. They were in the left ventricle in these cases. So, you know, what I showed you is there was no difference in the incidence of pulmonary emboli in those cases. Now, both had high pulmonary emboli. I'm not saying what you're saying is wrong, because I agree with you. But there was not, I was thinking to myself, well, what explains the myocardial necrosis is these people have more pulmonary emboli, like you're saying. But we didn't find a difference in the incidence of pulmonary emboli in cases with and without myocardial necrosis. No, that's a pathologic term. Myocardial necrosis. We can't detect that in the clinic. So, you know, in some ways, it's more sensitive than the troponins, but, you know, it's a complicated thing. To interpret this for clinical is complicated.
Yeah. I mean, I think for when you don't have a tissue diagnosis, everything is just a guesswork, right? Tissue is the issue, right?
You guys are advocating myocardial biopsies.
Well, you know, Juan, I got to tell you that I submitted a paper on this, another paper on the diagnosis of myocarditis, and one of the reviewers, the big issue with the reviewer was, so this is myocarditis, so it's infrequent. What do you recommend for myocardial biopsy? What do you recommend myocardial biopsy in case of COVID-19 suspected myocarditis or not? And my personal feeling was that no, it should not be done for multiple reasons. First of all, the diagnostic, you know, the ability for you to diagnose myocarditis is low given the overall prevalence or incidence of myocarditis in these cases. And secondly, there's no therapeutic advantage.
Yeah, yeah. You know, there have been several papers linking heparin usage with improved outcomes. Is anyone aware of similar studies looking at DAP? I'm surprised it hasn't been done to this point. You know.
So am I. Yeah. I mean, I don't know what your guys' threshold is, but I always worry about, you know, when you get called for a COVID-19 patient, they say it needs to go to the cath lab. I don't know what the practice is in many places. You know, I'm a little careful about taking to the cath lab. I just feel like the incidence of myocardial infarction is not that much greater in the COVID-19 positive than negative. And I showed you that the STEMI, although in aspirated thrombi, we compared COVID-19 positive aspirated thrombi and COVID-19 negative aspirated thrombi. Although there was slightly more fibrin and things like that and platelets, it wasn't significant.
Professor Ho, in Vietnam, is there the Lucas device? And do you have a lot of access to ECMO at all, or no in the hospital?
No.
Yeah.
We have some ECMO in Charai Hospital in Ho Chi Minh City and some ECMO in the Bạch Mai Hospital and some ECMO in Đà Nẵng, but I think not very much. So yeah, by now, because we equipment and healthcare worker, healthcare personnel, I think is limited. If we leave the COVID pandemic phenomenon is spreads, I think we cannot control.
Yeah.
Even respirator. Yeah.
Right. I hate to say this, but with limited resources like that, and given the likelihood of survival of someone with cardiac arrest, it's terrible. It's almost like you need to have a policy that CPR is not performed in those patients when they cardiac arrest. I hate to say it, but that might be what needs to be done.
Yeah.
There's some hospital that institute that.
Yeah, but
I think that was the universal. I'm sorry, go ahead, Professor.
Yeah, but in the first stay in the COVID in Vietnam, I think at least 10 hospitals were locked down because if the Ministry of Health discovers the transmission between the people to people locked down of the hospital. So I think by now we can control. But if it's the expansion look like America, I don't know, in Vietnam, I think we cannot have a ability to control. Yeah. Well, Professor Abbas, do you give your presentation?
Yes, the first one we switched.
Yeah.
Yes, he did. Yes.
Yeah. you know, I think the more we learn about this, the more I think we can brace ourselves for the, you know, upcoming of a possible second or third surge now, as we've been reading universally. I think we've learned a lot. We've certainly, you know, I think, as we earlier spoke in the pandemic, that flattening the curve just allowed more of a steady flow of patients into the system, where where now we can control them with the resources that we have, rather than be overwhelmed with the number of patients. And I think that certainly, you know, this was one, you know, pandemic, and you know, hopefully of one in many lifetimes, where we saw a lot of disciplines come together to try to really understand and work together in a very, you know, in a very fascinating role. And you know, I'm sure we'll have a lot of stories to tell our grandchildren and our great grandchildren. So with that note, I think we can come to a conclusion, and you know, to this session. I want to thank my co-moderator, Professor Ho, and all the speakers, Dr. Finn and Dr. Trung, for joining us, and Dr. Lee for arranging this virtual. Again, one of the other results of the pandemic is this ability to do this virtual conference and meet all these wonderful brains and speakers. Thank you very much, and thank you on behalf of Sky. Have a great morning in the US and even in Vietnam. Thank you.
Thank you. Yeah.
Thank you, Tom. Alok, Amr.
Bye.
Professor Ho, it's great to see you.
Giờ tới cái cuối cùng phải không?
Dạ.
năm 1992, Hội Tim mạch Quốc gia Việt Nam được thành lập, đánh dấu bước phát triển mới của ngành tim mạch Việt Nam.
Vâng, xin chào các đồng nghiệp đang tham gia hội nghị trực tuyến của Hội
các bác sĩ trong
Tim
chuyên
mạch
ngành
Quốc
tim
gia
mạch
Việt Nam. Và chúng ta đang trong cái phiên cuối cùng
chia sẻ
ngày hôm nay.
kinh nghiệm, cập nhật những cái thông
Chúng ta đang tham gia với phiên hội thảo vệ tinh của CMN với cái chủ đề đó là cái giới thiệu các cái công nghệ mới trong việc điều trị y khoa. Thì trong cái phiên này thì tôi sẽ trình bày một cái bài báo cáo về một cái chủ đề mà tôi nghĩ rất là thời sự và rất là hot, đó là cái can thiệp mạch vành bằng robot hiện tại và tiếp theo. Như vậy thì can thiệp mạch vành, lý do tại sao mà chúng ta phải can thiệp mạch vành bằng robot, và cho đến thời điểm này thì can thiệp mạch vành bằng robot nó đã thực hiện được những cái gì và cái hướng tiếp theo sẽ như thế nào, và liệu Việt Nam trong thời gian gần thì chúng ta có được cái can thiệp mạch vành bằng robot hay không. Đầu tiên thì chúng ta sẽ điểm lại vài nét về cái khuynh hướng mà chúng ta ứng dụng các kỹ thuật công nghệ hiện đại trong y khoa. Chúng ta sẽ thấy đầu tiên các đồng nghiệp sẽ thấy cái smartphone thì là những cái smartphone mà chúng ta đã có những cái app về vấn đề theo dõi sức khỏe, về luyện tập, chúng ta đã có những cái đồng hồ, và sau đó tiến bộ hơn là những cái kiosk, tức là những cái module, và về đi sâu vào trong những lĩnh vực thì chúng ta có y học chính xác, rồi điều trị tế bào, chúng ta có photo 3D, in 3D, rồi chúng ta có những cái thử nghiệm lâm sàng mà chúng ta dựa trên kỹ thuật số, nên là sau này chúng ta tiếp theo đó là big data, tức là những cái dữ liệu rất là lớn. Chúng ta có những con chip, và sau cùng trong cái dãy tiến bộ của khoa học công nghệ thì chúng ta thấy robot xuất hiện. Như vậy thì robot trước khi mà tiến vào y khoa thì đã có những cái lĩnh vực nào, thì chúng ta thấy rằng robot ngày hôm nay đã rất là có nhiều cái sự phát triển trong nhiều cái nền công nghệ khác nhau. Đầu tiên đó là robot xuất hiện trong những cái nhà máy, những cái xí nghiệp sản xuất, ví dụ như sản xuất xe hơi, sản xuất tất cả các cái phương tiện dụng cụ. Tiếp theo nữa thì chúng ta có thấy là robot xuất hiện trong những cái khu vực mà nó gọi là nguy hiểm. Ví dụ như là robot đi vào những cái nơi mà gỡ min chẳng hạn, hoặc robot vào những cái nơi mà khủng bố, thì để giúp cho cái việc kiểm soát những cái đối tượng khủng bố, đó là những cái nơi rất là nguy hiểm, và nếu chúng ta cử con người đi vào thì không phù hợp. Tiếp theo thì robot chúng ta thấy là xuất hiện trong những cái xe tự lái, ví dụ như những cái xe buýt tự lái, và ví dụ như là trên cái hình là một người chủ ngồi trên xe nhưng mình không lái gì cả, mình chỉ nhìn đường thôi, ví dụ. Và cuối cùng thì robot xuất hiện trong lĩnh vực y khoa. Robot xuất hiện trong y khoa. Và cho đến ngày hôm nay, các đồng nghiệp sẽ thấy là năm 2015 thì chúng ta thấy là đã có trên một triệu cái thủ thuật y khoa được thực hiện bằng robot. Đây là một con số không nhỏ của năm 2015. Như vậy thì cái thị trường phát triển của robot trong vấn đề chăm sóc sức khỏe, nhìn cái sơ đồ phía bên trái thì các bạn sẽ thấy là từ phát triển từ những năm 2000, 2005, 2010, 2015, và trong tất cả các lĩnh vực về công nghiệp, về và sau cùng đó là cái lĩnh vực chăm sóc sức khỏe. Và đầu tiên thì cái robot sẽ phát hiện ở trong cái lĩnh vực về ngoại khoa. Và đây là cái số lượng phát triển của robot của trong thị trường về cái chi phí. Và cái sơ đồ thứ hai là biểu diễn cho cái sự tốc độ phát triển của robot trong các lĩnh vực. Thì chúng ta sẽ thấy trong các lĩnh vực thương mại, rồi trong công nghiệp, rồi trong quân sự thì robot phát triển. Nhưng đặc biệt cái hàng cuối cùng đó là trong y khoa, và đặc biệt trong y khoa trong lĩnh vực surgery, tức là phẫu thuật. Ví dụ như là trong mổ sọ não, và đặc biệt ngày hôm nay chúng ta đang nói tới một cái chuyện đó là robot trong can thiệp mạch vành. Thì các đồng nghiệp sẽ thấy rằng cái tốc độ phát triển của robot trong y khoa là vượt lên tất cả các lĩnh vực khác. Như vậy đây là một cái khu vực, đây là một cái thị trường mà phát triển của robot đầy tiềm năng trong cái thời gian sắp tới, và hiện tại nó đang dẫn đầu về cái tốc độ phát triển. Như vậy thì chúng ta đi phần tiếp theo là tại sao chúng ta lại cần sử dụng robot trong tim mạch can thiệp mà chúng ta không để cho bác sĩ tim mạch can thiệp và nhân viên y tế mình làm. Chúng ta phân tích những cái được và những cái lợi, những cái hại. Đầu tiên thì chúng ta xem xét những lý do gì mà người ta phát triển robot trong cái lĩnh vực y khoa. Đầu tiên đó là sự khác biệt, tức là nó tạo nên cái sự khác biệt của một lĩnh vực y tế, của một ngành y tế, của một bệnh viện. Bệnh nhân thì thích được phục vụ có robot và đưa bệnh viện đạt đến đỉnh cao của kỹ thuật hiện nay. Đó là cái mong muốn của ban giám đốc, của ban lãnh đạo và của ngành y tế. Thứ hai là giá trị dựa trên cái việc là cái thuận lợi, tức là thí dụ như là chúng ta can thiệp bằng động mạch quay, thì hiện tại chúng ta chỉ can thiệp bằng động mạch quay phải, vì động mạch quay trái là nó không phù hợp với lại cái máy đi đây hiện tại. Nhưng nếu chúng ta can thiệp bằng robot thì động mạch quay trái đây là một nơi rất là thuận tiện để chúng ta can thiệp. Rồi khả năng chính xác của robot, robot khi chúng ta can thiệp, chúng ta đi qua, chúng ta đi dây dẫn, chúng ta đi bóng, thì trên cái đường đi thì robot nó đã đo chính xác từng mm và nhỏ hơn 1 mm. Như vậy thì khi mà mình đặt một cái stent, các bạn tính toán thì không phải bằng ước tính bằng mắt, các bạn không phải dùng iVert mà đưa vào trong tính, thì sau khi các bạn đi qua thì robot nó cũng cho biết được là cái chiều dài của cái tổn thương đó là bao nhiêu, và chúng ta có thể lựa hoàn toàn chính xác cái stent phù hợp. Cái tình trạng mà nhân viên của phòng thông tim gọi là kiệt sức, thứ nhất là cái tình trạng nhiễm xạ. Nếu chúng ta can thiệp thường, chúng ta nhiễm xạ rất là cao, trong khi đó khi chúng ta can thiệp bằng robot thì giảm được 95% nhiễm xạ, một cái sự giảm nhiễm xạ rất là lớn. Cái vấn đề tiếp theo ảnh hưởng đến sức khỏe của nhân viên, đó là giảm ảnh hưởng tác động sức nặng của áo chì và tư thế đứng, nó gọi là orthopedic strain, tức là những ảnh hưởng do tư thế đứng, do chúng ta phải mặc áo chì, bác sĩ can thiệp đứng liên tục và tạo được những bác sĩ can thiệp hàng đầu, tạo ra và sử dụng những bác sĩ can thiệp hàng đầu. Tại sao như vậy các bạn? Tại vì khi mà chúng ta đào tạo được những bác sĩ can thiệp tốt qua robot thì những bác sĩ đó có thể được tiếp cận trên toàn thế giới. Vì các bạn cái phần sau chúng ta sẽ thấy cái chuyện là chúng ta gọi là telestenting, tức là chúng ta đặt stenting từ xa. Một bác sĩ ngồi tại một chỗ có thể tiến hành can thiệp. Ví dụ ngồi tại thành phố Hồ Chí Minh có thể tiến hành can thiệp ở gọi là hiện tại thì người ta mới cách 20 dặm, nhưng mà với cái đà phát triển của công nghệ sắp tới có thể là cách hàng trăm cây số, và có thể người ta đang lập kế hoạch là từ đầu bên này của nước Mỹ qua đầu bên kia nước Mỹ. Như vậy thì một bác sĩ can thiệp có thể tiến hành tại chỗ mình làm, có thể tiến hành trong nhiều cái phòng khác trong bệnh viện của mình, và có thể tiến hành can thiệp ở một nơi mình rất cách xa mình. Như vậy thì một bác sĩ can thiệp giỏi có thể là được tiếp cận từ nhiều nơi và nhiều bệnh nhân trên thế giới. Và tương lai của cái nơi mà chúng ta đầu tư robot là chúng ta dễ dàng tiến hành những nghiên cứu. Các bạn biết là bây giờ những cái nghiên cứu về cái can thiệp robot, trong đó có mạch vành thì đang xuất ra rất là nhiều, và chúng ta có thể publish dễ dàng và thích hợp với tương lai. Đây là một cái hướng sự phát triển. Chúng ta có thể liên quan vào cái tham dự vào cái sự phát triển kỹ thuật và đào tạo y khoa. Như vậy thì chúng ta nhắc lại về cái lịch sử của phát triển tim mạch can thiệp. Cái người đầu tiên mình xem như là ông tổ của mình tim mạch can thiệp thì năm 1977, bác sĩ Arias Ruenzis là đầu tiên là tiến hành cái việc thông tim. Thì nếu chúng ta tính về cái phương tiện dụng cụ, chúng ta không tính về mặt kỹ thuật. Kỹ thuật thì chúng ta có những kỹ thuật ví dụ như kissing, chúng ta có thể làm CTO, chúng ta có thể đi cây crush vân vân. Nhưng nếu tính về mặt máy móc thì mãi cho đến năm 2016 chúng ta bắt đầu tiến hành những cái ca mà thông tim robot. Như vậy thì các bạn sẽ thấy rằng cho đến ngày hôm nay, một bác sĩ tim mạch can thiệp chúng ta ngồi không cần phải mặc áo chì, ngồi trong một cái buồng rất là thoải mái, giống như là mình đang ngồi làm việc hành chính và mình đang tiến hành can thiệp. Chúng ta có thể tiến hành can thiệp cái bệnh nhân mà phía sau bức tường của chúng ta đang ngồi, có thể là tiến hành của một cái đầu khác của bệnh viện, và chúng ta có thể tiến hành ở một cái đầu khác của thành phố. Và hiện tại thì cái nơi mà xa nhất là cách 30 km. Như vậy chúng ta sẽ thấy đây là một cái bước nhảy vọt của cái sự phát triển về mặt công nghệ cũng như là trong lĩnh vực tim mạch can thiệp. Những điều mà robot có thể làm được cho phòng thông tim đó là những điều gì? Cái thứ nhất là giảm sự chênh biệt trong kỹ năng can thiệp về kết cục lâm sàng, thực hành lâm sàng tốt nhất. Bởi vì các bạn biết rằng khi mà máy móc đã làm, giống như trước đây chúng ta lái máy bay thì chúng ta phải lái bằng phi công, và như vậy thì cái việc mà an toàn và cái việc mà chúng ta đi đến đích sẽ phụ thuộc vào một cái tài năng của một bác sĩ, của một phi công. Mà người phi công đó thì không phải lúc nào cũng gọi là tài năng hoặc là sáng suốt hoặc là cái độ lái như nhau. Trong khi đó nếu chúng ta tiến hành bằng robot thì nó sẽ giữ được một cái mức độ ổn định về mặt kỹ năng can thiệp và việc thực hành lâm sàng, mà nó sẽ tránh cái sự chênh biệt, sai biệt giữa người này với người kia, và nó luôn luôn hạn định. Do đó các bạn thấy rằng ngày hôm nay gần như là phi công lái máy bay đều thông qua máy móc, thông qua robot. Một cái việc nữa đó là cái kỹ thuật hợp nhất, tức là khi robot tiến hành làm thì nó sẽ kết hợp với tất cả các cái cơ sở dữ liệu hình ảnh và giúp cho người phẫu thuật viên làm có sẵn để kết hợp vào cái quá trình tiến hành của mình. Một cái việc là bảo vệ an toàn cho nhân viên. Ngày nay thì người ta đang rất là lo lắng về cái tình trạng ảnh hưởng đến sức khỏe và an toàn của những nhân viên trong phòng thông tin, của người thầy thuốc ngày càng cao. Ngày càng có nhiều cái công trình nghiên cứu và các chứng cứ về những cái việc nguy hại nghề nghiệp trong phòng thông tin. Và cuối cùng tức là mọi bệnh nhân đều có thể tiếp cận cùng theo một cái kiểu mô hình chăm sóc, cũng có thể tiếp cận với một cái mức kỹ thuật tiến hành can thiệp. Ví dụ như chúng ta đào tạo ra những cái bác sĩ can thiệp mà giỏi qua thực hiện qua can thiệp bằng robot, thì cái người bác sĩ đó có thể là được tiếp cận từ những bệnh nhân rất là xa chỉ thông qua cái hệ thống mạng và vi tính. Như vậy thì tất cả những điều này đều đưa đến cái mục đích cuối cùng là chăm sóc bệnh nhân được cải thiện, và bệnh nhân được cải thiện ở trong cái lĩnh vực tim mạch can thiệp. Người ta so sánh giữa cái can thiệp mạch vành kinh điển và can thiệp mạch vành bằng robot. Ta thấy ở cái hình ở đây, chúng ta thấy rằng đây là những cái bước mà kinh điển của can thiệp mạch vành. Đầu tiên là chúng ta chụp, chúng ta phải đánh giá cái tổn thương, chúng ta phải tìm những cái góc độ khác nhau để mà bộc lộ ra cái độ hẹp và tổn thương một cách rõ ràng nhất để chúng ta xác định. Sau đó chúng ta thăm dò và sau đó mình đo đạc về mặt giải phẫu, và chúng ta sẽ quyết định cái chiến lược mình sẽ đặt stent, đặt từ đâu đến đâu, chiến lược đặt stent thế nào, và chúng ta tiến hành là bung, tức là khai cái stent. Thì như vậy phía bên tay trái đó là chúng ta tiến hành can thiệp theo kiểu thông thường, và phía bên tay phải đó là chúng ta tiến hành can thiệp bằng robot. Thì các đồng nghiệp sẽ thấy về cái mặt đánh giá về mặt giải phẫu thì có những cái tổn thương mà nó xoắn vặn hoặc là nằm những cái góc khuất mà chúng ta rất là phải khó tìm nhiều cái view khác nhau. Trong khi đó thì bằng robot thì robot nó giống như là trí tuệ thông minh, tức là sau khi mà chúng ta chụp và chúng ta đưa dụng cụ vào thì trên lúc đường đưa vào thì máy móc nó sẽ ghi nhận những cái bất thường về mặt giải phẫu. Chúng ta có thể làm những cái sai sót về cái nhân lực của con người, trong khi đó thì robot nó là máy móc, thành ra cái độ chính xác nó rất là cao. Chúng ta ước tính bằng mắt thường thì robot lại đo chính xác đến cái mức mà gọi là dưới mm, tức là khi trên đường đi qua đi bóng các bạn thì robot nó sẽ đo luôn cái chiều dài cái đường kính. Và chúng ta tiến hành đánh giá và cảm nhận bằng tay thì cái việc mà đặt stent thì robot có thể đặt chính xác đến 1 mm. Như vậy thì rõ ràng rằng cái việc mà chúng ta can thiệp với kỹ thuật hiện nay thì cái nhân viên y tế phải bộc lộ ra trong cái môi trường phóng xạ rất là cao, cảm giác mệt mỏi, tức là những cái phòng thông tin mà chúng ta làm với một cái số lượng bệnh nhân lớn, ví dụ như là của Bạch Mai, của Đại học Y Dược, của các bệnh viện lớn trong thành phố Hồ Chí Minh, thì cái cảm giác của cái nhân viên y tế trong phòng thông tin rất là mệt mỏi, và chúng ta phải chịu cái orthopedic strain, tức là cái sự tác động của vấn đề tư thế và áo chì. Trong khi đó nếu chúng ta thực hiện can thiệp một phòng thông tin bằng robot thì gần như là cái vấn đề nhiễm xạ rất là thấp. Các bạn thấy rằng nguyên một cái kíp lớn thì sau khi chúng ta can thiệp bằng robot thì trong cái phòng thông tin đứng bên cạnh bệnh nhân thì từ 1 đến 2 người, còn lại bác sĩ can thiệp thì ngồi trong cái cockpit, tức là trong cái buồng lái, có thể đặt trong phòng thông tin có che chắn, hoặc là chúng ta đặt ở bên trong cái phòng máy. Và như vậy thì cái việc giảm tia rất là nhiều và giảm cái sự mệt mỏi, giảm cái sự chấn động về mặt tư thế và cơ xương khớp. Vậy thì cho đến nay thì cái hệ thống Carbat của Siemens là cái hệ thống mà robot được tiến hành can thiệp rộng rãi, đang ứng dụng rộng rãi trên thế giới. Và như vậy nó sẽ kiểm soát cái vấn đề can thiệp rất là chính xác, từ cái việc đi wide, chúng ta đi stent, đi bóng, rồi chúng ta tạo những cái nền tảng cho vấn đề chúng ta can thiệp, chúng ta đo lường giải phẫu, rồi bảo vệ, chống tia. Vì tất cả bác sĩ, chúng ta thấy những cái hình, ví dụ như là ở đây thì bác sĩ ngồi cùng trong phòng thông tin nhưng mà ngồi một cái góc mà có che chắn. ở đây là bác sĩ là ngồi trong cái phòng máy từ phía bên ngoài và có thể là ngồi từ một cái phòng khác cách cái phòng thông tin và có thể ngồi từ cái nơi khác không trong bệnh viện. Như vậy thì chúng ta là tiếp tục là xem tiếp là tại sao chúng ta sử dụng robot trong tim mạch can thiệp. Đầu tiên thì các bạn sẽ thấy rằng là cái đây là ở Mỹ, Việt Nam mình thì chắc cũng có, tức là cái thị trường về cái giá cả can thiệp ở Mỹ thì nó sẽ chênh nhau rất là nhiều, từ nơi này đến nơi khác, từ nơi này đến từ tiểu bang này đến tiểu bang khác, nó chênh nhau tới mức là 300%. Trong khi đó giống như mua hàng online vậy, nếu chúng ta có bác sĩ can thiệp tim mạch bằng robot và khi mà robot đã kết nối cái việc gọi là remote PCR, can thiệp từ xa, thì cái giống như các bạn mua hàng trên mạng thì cái vấn đề mà giá cả chi phí nó cũng sẽ ổn định tới một cái mức đồng nhất. Cái thứ hai là cái phòng thông tin ngày hôm nay người ta gọi đó là một cái nơi rất là nguy hiểm và đang được quản lý rất nhiều cái luật. Ở đây là ở Hoa Kỳ, ở Việt Nam mình thì quản lý lỏng lẻo hơn. Tuy nhiên với những cái luật về phóng xạ, về an toàn nghề nghiệp, về an toàn nhiễm khuẩn, về chống tia, thì các bạn sẽ thấy là phòng thông tin là một nơi nguy hiểm. Đầu tiên chúng ta thấy hàng ở trên là cái việc gì xảy ra, đó là cái tình trạng mờ đục thủy tinh thể xảy ra, và người ta khảo sát thì đối với những cái bác sĩ mà can thiệp thì ít nhất là 32%, thì trong cái quá trình can thiệp, tức là ví dụ như tôi cũng có thể bị, tức là ít nhất 32% sẽ bị đục thủy tinh thể một phần. Và ở đây người ta khảo sát là 50% bác sĩ can thiệp thì sẽ có cái tình trạng gọi là thay đổi cái thủy tinh thể mà phía dưới bao ở phía sau. Cái thứ hai, brain tumor, tức là u não. Như vậy người ta sẽ so sánh của bác sĩ tim mạch can thiệp so với nhóm chứng thì thấy rằng có cái sự chênh biệt. Tim mạch thì cái u não tỷ lệ cao hơn. Tiếp theo nữa đó là những gánh nặng về tư thế, giống như đã nói, tức là chúng ta đứng rồi chúng ta mặc áo chì thì những cái tác động ngay trên cái gánh nặng về orthopedic nó ảnh hưởng về lâu về dài rất là nhiều cho cái bác sĩ tim mạch can thiệp. Và cái orthopedic burden này nó sẽ tăng theo cái số năm chúng ta tiến hành làm can thiệp và cái số ca chúng ta tiến hành can thiệp. Và ngày hôm nay chúng ta thấy rằng ví dụ đến năm 2015 thì trong năm 2015 có 42 bài báo xuất bản cũng liên quan đến những cái nguy cơ trong phòng thông tin. Như vậy người ta gọi là cath lab là một cái nơi mà risky play. Và một cái vấn đề nữa, nếu chúng ta triển khai được can thiệp, chúng ta tiến hành đào tạo được những bác sĩ can thiệp mà thực hiện qua robot, thì chúng ta cũng giải quyết một vấn đề khác, đó là cái vấn đề tiếp cận y tế toàn cầu. Ngày hôm nay thì những cái bác sĩ mà đặc biệt là bác sĩ chuyên ngành chuyên sâu, những người có khả năng thì là trong một cái tình trạng thiếu thốn. Chúng ta sẽ tập trung ở những cái thành phố lớn, những cái bệnh viện lớn, những cái đô thị lớn, trong khi các cái nơi xa xôi thì người ta không tiếp cận được những bác sĩ giỏi. Nhưng nếu chúng ta thực hiện can thiệp qua robot thì đến một tương lai gần thì chúng ta có thể ngồi ở Việt Nam nhưng mà có thể là một bác sĩ nước ngoài can thiệp chúng ta. Như vậy thì đó là những vấn đề về lý luận và những vấn đề về lý thuyết. Còn cơ sở dữ liệu, những cái data hiện nay của can thiệp bằng robot đã có nhiều hay chưa? Các bạn ở đây là tôi xin trình bày một số cái nghiên cứu, trong đó thì sẽ nói một số cái nghiên cứu mà liên quan đến gần đây, đó là Precise và Cobra PCI. Precise đó là một cái nghiên cứu mà đánh giá cái sự an toàn và cái tính khả thi và thành công về mặt lâm sàng, thành công về mặt thủ thuật của robot. Còn cái nghiên cứu Cobra PCI đây là bắt đầu nghiên cứu vào can thiệp phức tạp. Như vậy thì cho đến thời điểm này, các đồng nghiệp nào mà có theo dõi cái lĩnh vực về can thiệp robot thì chúng ta thấy rằng là ngày hôm nay người ta tiến hành can thiệp robot đã bắt đầu tiến hành can thiệp trên những ca CTO, những ca thân chung, rồi những ca là tổn thương bifurcation. Ở đây là những cái ngày đầu tiên của những cái ca đầu tiên mà người ta ghi nhận trong y văn để tiến hành can thiệp robot. Cái nghiên cứu Precise, nghiên cứu này gọi là nghiên cứu pivotal, tức là nghiên cứu bản lề, thì các đồng nghiệp sẽ thấy rằng là những cái tai biến thì gần như là không đáng kể. Cái tỷ lệ thành công về mặt thủ thuật, về mặt dụng cụ thì rất là cao, 98,8%, thành công về mặt lâm sàng thì 97,6% và giảm liều tia một cách ngoạn mục. Tức là chúng ta ngồi bên ngoài cái phòng thông tin, do đó là giảm liều tia tới 95,2%. Và cái nghiên cứu PRECISE này thực hiện trên 9 cái site multi-center, 9 site trên 164 bệnh nhân, và không có trường hợp nào biến chứng nào liên quan đến vấn đề thủ thuật của robot. Ở đây thì chúng ta trình bày nhanh. Ở đây là thành công về mặt kỹ thuật. Thành công về mặt kỹ thuật nghĩa là chúng ta tiến hành can thiệp bằng robot được, mà chúng ta không phải chuyển sang can thiệp bằng thông thường. Và ở đây người ta thống kê theo đường đùi và theo đường quay. Các bạn thấy rằng trong can thiệp robot thì đường quay đó là một cái đường rất là lý tưởng, và cái động mạch quay trái là động mạch gần như mà rất ít làm thì là rất thuận lợi cho robot. Tỷ lệ thành công về mặt lâm sàng, tức là từ cái vấn đề chúng ta can thiệp, chúng ta mở tổn thương, khi chúng ta can thiệp thì đưa lại một cái kết cục lâm sàng là bệnh nhân cải thiện, ví dụ như là cải thiện giảm triệu chứng đau, cải thiện giảm suy tim, giảm những cái biến cố về lâu về dài. Và chúng ta đánh giá tỷ lệ thành công của robot là 91,7%, và như vậy người ta phân tích những cái số liệu mà những cái trường hợp không thành công hoặc là phải chuyển sang làm tay. Thì ở đây là có một số trường hợp là xác định là can thiệp robot là nó gọi là hybrid, tức là kết hợp một phần robot, một phần thì bằng nhân lực thông thường, và một phần thì chuyển sang vì nửa chừng là không can thiệp được, thì cái tỷ lệ này rất là thấp. Và đặc biệt là cái vấn đề giảm chia sẻ. Các bạn sẽ thấy rằng là trong can thiệp mà bằng robot thì chỉ có 1 hoặc 2 người là tiếp cận đứng sát bệnh nhân, còn phần lớn là không tiếp cận, và bác sĩ can thiệp thì ngồi phía bên ngoài. Cái nơi mà chúng ta làm can thiệp, cái đo cái nồng độ và chia xạ và cái nơi chúng ta ngồi bên ngoài giảm được 95,2%, và B là 3 con số 0 sau dấu chấm. Ở đây bắt đầu là người ta nghiên cứu can thiệp thân chung bằng robot. Nghiên cứu Cobra PCI là nghiên cứu can thiệp những cái tổn thương phức tạp. Thì các bạn thấy rằng cái tỷ lệ thành công của can thiệp phức tạp, ở đây phức tạp là chưa tới cái mức thì rất là phức tạp, nhưng bắt đầu là đã có một số trường hợp là CTO, có một số trường hợp thân chung, có một số trường hợp là bifurcation, thì các bạn thấy là tỷ lệ thành công khá là ngọn mục. Chúng ta can thiệp bằng tay thành công là 99,1, ở đây là gần như là tương đương. Đây là về cái tiêu chí về thời gian thủ thuật. Thì như vậy các bạn sẽ thấy là tổng thời gian chung thì can thiệp của robot có lẽ là cao hơn can thiệp thường, nhưng có lẽ là chưa quen. Nhưng các bạn sẽ thấy rằng bây giờ nếu mà cái mức độ phức tạp trong những trường hợp phức tạp thì chúng ta thấy càng phức tạp thì cái việc can thiệp robot bắt đầu khuynh hướng cái thời gian can thiệp này giảm hơn so với chúng ta can thiệp thông thường. Ở đây là những cái nguồn lực mà chúng ta phải dùng, và đây là cái kết cục outcome của 12 tháng. Thì khi mới can thiệp thì có vẻ như can thiệp nhân lực hiện nay là tốt hơn, tuy nhiên cái sự khác biệt không có nghĩa thống kê, nhưng sau thời gian 12 tháng thì nó gặp nhau, tức là can thiệp bằng robot và can thiệp bằng tay giống nhau. Như vậy thì những cái lợi ích nào chúng ta đạt được từ khi chúng ta can thiệp robot, và đặc biệt can thiệp robot thì người ta ưu tiên chọn đường quay. Thì đương nhiên cái này chúng ta đã biết rất là rõ. Lợi ích của bệnh nhân khi chúng ta can thiệp đường quay là giảm chảy máu, giảm những biến chứng đường vào, bệnh nhân có thể ngồi dậy đi đứng rất là nhanh và ra viện rất sớm. Về phía bác sĩ thì chúng ta cái này các bác sĩ mình nhiều khi không chú ý. Khi can thiệp bằng tay thì chúng ta sẽ thấy rằng là khi can thiệp bằng tay thì cái điều tia xạ chúng ta phải chịu tác động là gấp 2 lần khi chúng ta can thiệp bằng đường đùi. Và người ta tính rằng mỗi khi mình thực hiện thông tim mà bằng đường động mạch quay 100 trường hợp thì tương đương với là bác sĩ phải chịu là chụp 6 cái phim X-quang. Nhưng nếu chúng ta tiến hành can thiệp bằng robot thì robot nó lại là một rất là thuận lợi khi đi bằng cái đường bằng tay. Thì cái việc bác sĩ thực hiện can thiệp bằng tay trở nên dễ dàng. Và một điều đặc biệt là can thiệp đường động mạch quay trái thì cũng tốt tương tự như động mạch quay phải. Khi đó thì với cái bàn thông tin thông thường thì chúng ta can thiệp chủ yếu là động mạch quay phải. Như vậy chúng ta thấy ở đây người ta lặp lại cái đó, việc mà can thiệp bằng động mạch quay trái thì dễ dàng hơn, đặc biệt là cho những bác sĩ can thiệp mà chúng ta mới thực hành động mạch quay trái. Và đối với robot thì người ta khuyến khích rằng những người mới làm là nên làm động mạch quay trái trước. Như vậy thì chúng ta tóm lại cái lợi ích mà của can thiệp bằng đường quay. Thì như vậy bệnh nhân thì giống như các bạn đều biết là bệnh nhân sẽ đi lại nhanh hơn, cái thời gian nằm viện ngắn hơn, ít cái biến chứng đường vào hơn và bệnh nhân thuận tiện hơn. Và phía bác sĩ là giảm cái liều antia, giảm cái việc mà tác động trên lưng và giải quyết được cái việc mà động mạch quay trái, vì chúng ta động mạch quay trái thì cái tư thế đứng của bác sĩ không thuận tiện. Về phía bệnh viện sẽ giảm được chi phí nằm viện, sẽ giảm được những cái biến chứng, những cái chi phí tốn kém mà liên quan đến đường đùi. Như vậy thì bây giờ chúng ta bàn qua một cái vấn đề mà cũng rất là ưu điểm của can thiệp bằng robot, đó là can thiệp từ xa, nó gọi là remote intervention. Thì đầu tiên là can thiệp từ một cái phòng trong cùng một bệnh viện, nhưng mà không phải nằm trong phòng thông tin, gọi là same hospital procedure room. Tiếp theo, cái này là cái buồng này là nằm trong cái phòng thông tin nhưng mà để một góc chắn lại. Cái thứ hai là nằm trong cùng bệnh viện mà vào cái buồng kiểm soát. Và cái thứ ba là cái buồng kiểm soát mà có thể là chúng ta kiểm soát nhiều cái phòng thông tin khác nhau, và chúng ta không có làm trực tiếp tại cái đây. Như vậy các bạn sẽ thấy là bác sĩ tim mạch can thiệp thì mặc áo civil thường, ngồi có thể là mình ngồi vào buồng này mình làm từ cho buồng khác. Và đặc biệt ngày hôm nay người ta đã thực hiện được cái việc là gọi là can thiệp ngồi từ một bệnh viện này và can thiệp một cái bệnh viện khác. Như vậy thì cái gọi là gì, cái yêu cầu về mặt kết nối và mặt kỹ thuật từ cái chỗ mà bác sĩ làm can thiệp, cái cockpit buồng lái đó, tới cái chỗ bệnh nhân thì chúng ta sẽ nối bằng cái gì? Đối với cái cockpit, cái buồng lái bằng ngay trong phòng thông tin thì không có vấn đề gì, đó là chúng ta nối bằng những cái dây nối bình thường và những cái phần mềm bình thường. Nếu bệnh nhân nếu mà cái chỗ làm của bác sĩ bắt đầu mà cách cái nơi cái chỗ bệnh nhân mà 10 mét thì chúng ta cũng có nối bằng cái hardwire bình thường. Nếu chúng ta mà trên 200 mét là khoảng 70 mét thì chúng ta bắt đầu là phải nối bằng cáp quang. Và nếu chúng ta cách bệnh nhân ví dụ như là 20 mai trong cái trường hợp mà người ta triển khai ở Ấn Độ thì hoặc là chúng ta phải nối bằng cáp quang, hoặc là chúng ta phải nối bằng Wi-Fi. Và Wi-Fi trong trường hợp này là chúng ta phải có hệ thống Wi-Fi 5G. Và như vậy thì cái việc triển khai 5G cũng sắp sửa triển khai được. Như vậy ở Việt Nam thì chúng ta hy vọng rằng đến một ngày nào đó thì chúng ta có thể là ngồi tại thành phố Hồ Chí Minh nhưng mà chúng ta can thiệp ở Bình Dương hay là Đồng Nai chẳng hạn. Như vậy thì người ta đưa ra cái khái niệm mới là telestenting, nghĩa là chúng ta đặt stent mà từ xa. Ở đây là minh họa là từ cái đầu bên này của nước Mỹ mà đặt stent cho cái đầu bên kia của nước Mỹ. Như vậy là telestenting là việc kết hợp robot và cái truyền thông tín hiệu, telecommunication, và bác sĩ thì ngồi làm ở một nơi mà cách xa với bệnh nhân. Một cái vấn đề mà người ta cảm giác rằng là robot cũng giải quyết rất là tốt, đó là chúng ta can thiệp mạch vành tiên phát trong nhồi máu cơ tim cấp ester trên lên. Bởi vì các bạn biết rằng nhồi máu tim cấp ester trên lên là chúng ta phải thực hiện càng sớm càng tốt. Thì như vậy các bạn sẽ thấy là ở ngay cả tại Mỹ thì cái vấn đề mà phân bố của địa lý, của dân cư và của bác sĩ can thiệp cũng đã gặp một số vấn đề khó khăn. Ví dụ như là chúng ta thấy rằng những cái điểm đen á, những cái điểm mà đen, những cái vùng đen á, là cái thời gian lái xe từ cái nơi mà bệnh nhân tới bệnh viện có thể can thiệp là nhỏ hơn 60 phút. Như vậy thì những cái vùng mà không đen, những cái vùng trắng là cái thời gian mà lái xe từ nơi bệnh nhân bị nhồi máu cơ tim tới bệnh viện có thể can thiệp là trên 60 phút. Cái thời gian mà mình gọi là thời gian mà thời gian golden time, là thời gian vàng, hoặc là thời gian cửa bóng. Thì như vậy các bạn thấy là nhìn trên cái bản đồ của Mỹ thì những cái vùng mà có chấm đen là không phải là nhiều. Chúng ta thấy có những vùng thì gần như là trắng. Như vậy thì những cái khu vực ví dụ như là toàn bộ nước Mỹ 80% là từ nơi ở bệnh nhân mà đi xe tới cái nơi bệnh viện có phòng thông tim là quá 60 phút. Những cái khu vực như California, Delaware, Florida vân vân thì các bạn thấy từ 30 cho đến 60 phút. Thì đây cũng là một cái việc mà nó sẽ kéo dài cái thời gian cửa bóng hoặc là thời gian vàng. Và hiện nay
năm 1992, Hội Tim Mạch Quốc gia Việt Nam được thành lập, đánh dấu bước phát triển mới của ngành tim mạch Việt Nam.